Okay.
Good morning. Welcome to day 2 of the 12th Annual Healthcare Conference. My name is Nellie Pouchie. I am the Chief Officer of the Ministry of Health and Wellness, and I am pleased to be here with you this morning for these presentations. Those of you who are here in person, I hope you've had a chance to eat before we get started. We have a full program today, and so I want to thank you for being here. The Wellness Center, I want to thank especially this morning for sponsoring this morning's breakfast and making sure that we start off on the right foot. I also want to thank all who are joining us by the various social media platforms. We are happy to have you watching with us. Our first speaker is Dr. Archita Joshi-Bhatt, consultant in pulmonology, critical care, and sleep medicine at Health City, Cayman Islands. Dr. Joshi-Bhatt will be speaking on the topic of chronic respiratory diseases, focusing on conditions such as COPD and asthma, and how to prevent and treat them so that we can all breathe easier. Let's welcome Dr. Joshi-Bhatt.
Thank you, Ms. Nellie, both for the kind introduction and for cleaning the surface before I could come here. I'm going to put my mask aside for a moment. A very good morning to all those who are here and all those who have joined us virtually. It is a privilege to be beginning the day's session today, and I thank the organizers for the opportunity, and as well as for the theme of this year's healthcare conference, which is Breathe Easier. Believe me, as a pulmonologist, this topic is very dear to me, and nobody can recognize the importance of breathing easy, probably more than me, on this island, because I have seen people suffering from so many chronic respiratory disorders, and the preciousness of each breath is not unknown to me. For the last more than 1.5 years, the entire world has been focused on one respiratory infection, that is COVID-19, as this is rampaging across the globe. This pandemic has overshadowed many other fields of medicine, has overshadowed our focus over many other chronic medical illnesses. And while people all over the world are losing their breath, fighting against this deadly infection, and we here who've been fortunate in the Cayman Islands are holding our breath, bracing ourselves in preparation for this pandemic to hit our shores again, the other acute and chronic medical illnesses haven't really ceased to exist. They very much exist amidst us. And it's high time that we focus on other problems that relate to healthcare as well. So today I will be talking about 2 such chronic respiratory diseases, which have affected hundreds of millions of people worldwide. And the topic today would be discussing these chronic respiratory disorders. As already discussed, in the times of pandemic, all we've been overwhelmed with is news and information and data and new research about COVID-19, but our focus has, gone away from other problems. So the sheer burden of chronic respiratory disorders is very high. It affects hundreds of millions of people all over the world. There are many chronic respiratory disorders, including COPD, asthma, bronchiectasis, pulmonary fibrosis, pulmonary hypertension, sleep apnea. The list is endless. We can't talk about all of them, obviously, but I will be focusing on at least the 2 major ones. Most of these chronic respiratory disorders are really not curable, but they are treatable. And what is important is that these are very much influenced by our environment, what we breathe in. So there are many environmental factors which influence our respiratory health and may contribute to developing chronic respiratory disorders. And these include smoking, tobacco smoking, environmental air pollution, indoor air pollution, occupational exposures to chemicals and dusts, and also frequent respiratory tract infections during developing years or in childhood. And these can bring about chronic respiratory disorders in children and later in their lives and adulthood. So hundreds of millions of people suffer worldwide from chronic respiratory diseases. Just putting up some figures. According to a report published by the WHO and then, of course, published in 2020, 262 million people were estimated to be affected by asthma alone in 2019, and it led to some 461,000 deaths. These are not small numbers we're talking about. Another major leading cause of chronic respiratory disease and morbidity and mortality is COPD, or chronic obstructive pulmonary disease, which has affected 64 million people worldwide, and now is the third largest cause of death worldwide. So to sum it up, chronic respiratory disorders are silent killers, and they're often neglected. We don't really talk or think about them as serious problems, but they are. So bringing our focus on to asthma. Asthma is a major non-communicable disease which affects both adults and children. And in fact, it is the most common chronic disorder in children. Children, as we know, are quite resilient and will have more acute illnesses and small respiratory infections or other problems, but this is one of the most chronic diseases affecting children. It is, the hallmark of this problem is inflammation and narrowing of the breathing tubes or the airways, which leads to symptoms like coughing, wheezing, chest tightness, or shortness of breath. And they could be all of these or some of these, which could be the manifestation. It is caused by complex interaction between the environment and the genetics of an individual, and hence will lead to a varied presentation. It can be a heterogeneous clinical presentation, the underlying pathology being inflammation, and possibly even remodeling of the airways subsequently. The good news, the breathe easy points here, is there is treatment available for asthma, and it is fairly simple to treat asthma if we treat it right, if we diagnose it correctly, and if we follow the general international guidelines which help a lot of people to manage asthma quite easily even in their primary practice. So inhaled medications are the mainstay of treatment for asthma. They are fairly easily available, and avoiding asthma triggers is another way of controlling this illness. And most asthma-related deaths, unfortunately, happen in low and middle-income group countries, where there is difficulty in diagnosis and treatment of these disorders. We here in the Cayman Islands are quite fortunate, so I wouldn't want people not to be updated about this illness. And just to briefly touch upon what the actual pathology in asthma is, as you may be able to see on the slide, a normal airway is simply a breathing tube with a layer of smooth muscles around it and a lining inside called the epithelium. And what happens in asthma is not just narrowing of or constriction of the smooth muscles in the wall of the breathing tubes. This is what we traditionally always believed, that asthma is a disease of bronchoconstriction. But there is also a lot of airway inflammation. There will be mostly eosinophilic inflammation. There is hypoplasia of the cells which produce mucus, and there is mucus hypersecretion. So it is more than just bronchoconstriction. There is a complex pathophysiology. I don't want to overwhelm everybody with the details of the diagram, but just to understand that when an inhaled antigen presents into our airways, the mast cells, which are one of the defense cells in our body, actually recognize this, and then they produce inflammatory mediators like leukotrienes and histamines, and they also signal the body to start preparing in defense. And the cytokines which do the signaling are usually interleukin-4, interleukin-5, and 13. These then, in turn, signal the bone marrow to produce cells called eosinophils, which are responsible for allergic manifestations. And these cells reach the airway. They migrate into the battlefield, if we may say so. They enter the airway matrix, and then they would cause ongoing inflammation. Certain other cytokines which are produced in the airway, like interleukin-4 or GM-CSF, they promote the production and they promote the eosinophils to survive in this matrix, and as a result of which, leading to long-term inflammation, even after the allergen or the triggering factor may have gone away. and this eventually leads to airway remodeling. So just to make you understand the pathology, because now we have a good understanding about asthma and its various endotypes and phenotypes. This has been an advancement over the last few years, where we don't just talk about asthma as a disease of bronchoconstriction, but we say we know what is the pathology behind it, we know how it happens, and we've divided it now into at least 2 major endotypes. One is a T2 high endotype and a T2 low endotype. Just to make you understand, in the previous diagram when we talked about the inflammatory mediators producing or causing cellular production, there are 2 types of cellular immune responses in the body. One is a T1 response and a T2 response. And usually in asthma, we see more of a T2 type of response, and I'm only touching upon this because it has implications on treatment, which I'll be briefly touching upon later. So pardon me if I'm talking too much in pathological terms. So we now know that the asthma can now be divided into a eosinophilic asthma and a non-eosinophilic asthma. Eosinophilic asthma can be caused by allergic eosinophilic inflammation or non-allergic inflammation. Non-eosinophilic asthma can again be divided into paucigranulocytic and neutrophilic. So these are the various pathological subsets that we see in asthma. Now, how does it really relate to the manifestations or the clinical manifestations? These are known as asthma phenotypes now. And asthma phenotypes can be, again, like I told you, the broad category is T2 high, those who are mounting more an allergic response or an eosinophilic response, versus the T2 low, which have more of a neutrophilic pattern, to put it simply. And the traditional way that we understand asthma has been the atopic or the allergic asthma, which usually is characterized by eosinophilic inflammation. The markers would be a high blood or a sputum eosinophil count, a high fraction of exhaled nitric oxide in the breath when we test, and mostly these individuals will present in young age and will have easy-to-control disease, not much impact on the lung function per se. However, there is an adult onset asthma as we used to, or late onset asthma as we call it now, which can have a more variable performance. They still have eosinophilic inflammation, but they may have more frequent exacerbations. There is another subset known as aspirin-exacerbated respiratory disease, which again has a different mechanism of action at the cellular level. There are non-T2 or T2 low kind of inflammations that can happen in the airway, which we see more in elderly or in individuals who are obese, particularly women. So there are multiple types of asthma phenotypes. And that brings us onto the treatment, and therefore the focus now is more on personalized management of asthma. We no longer say that one size will fit all, or one inhaler, or one treatment is meant for everybody. And there is an increased focus on trying to personalize the treatment of asthma for individuals. So this algorithm helps us understand that it's a constant process. It's not something that you once diagnose somebody with asthma, put them on treatment, and forget about them. It's a constant process of assessment, adjustment, and then reviewing the individual's response to treatment, making further adjustments. So for the diagnosis of asthma, first we, of course, want to confirm the diagnosis of asthma, which could include performing lung function tests, which could include assessing what are their risk factors, what are their comorbidities, what makes them more prone to having poorly controlled symptoms, are they compliant to their medications? If they are they not taking it correctly? So all of this, non-pharmacological aspects, like avoiding triggers, recognizing exacerbations quickly, these are all part of asthma management. So just to put it, just to run through the slides, there is a global initiative against asthma, which is a global alliance, really, which produces updated guidelines every so often in order to keep all physicians and particularly pulmonologists abreast with the management guidelines. And they come out with these simple algorithms. And we all know that for a long time, or at least a lot of us know that for a long time, asthma has been a step, the treatment of asthma has been a stepwise approach. So there's always a step up and a step down as the individual progresses through the course of asthma. And in children, really, there's not been much change in the recent GINA guidelines from 2019. However, you may notice that there is emphasis on, even in the step 2, which is where individuals have a more frequent exacerbations or need their short-acting bronchodilators more often, to add a daily or a regular dose of inhaled corticosteroid. In children between 6 to 11, again, there has been an increased focus on adding an inhaled corticosteroid even in step 1. So every time they have an episode of wheezing or chest tightness or need a bronchodilator, they should ideally also be given an inhaled steroid along with it. And an early addition of a low-dose inhaled corticosteroid has again been advocated in this group. But the major paradigm shift has happened in individuals who have, who are adults and adolescents above the age of 12 years. There has been a major change in the guideline, which now indicates that even as step 1, even when individuals have only intermittent or mild asthma, the focus should be on adding an inhaled steroid to their treatment, not just a bronchodilator. I'm sure anybody who knows individuals with asthma know that the first treatment that was prescribed for decades was basically adding a salbutamol inhaler or an albuterol inhaler, which an individual takes when they have an asthma episode and then forget about it when they do well, right? However, this has changed, and this was the significant fundamental change in 2019. And the reason why it has changed is this. There's a significant rationale behind it. About 30 to 37% of adults with acute asthma, or 16% of patients with near-fatal asthma, and 15 to 20% of adults dying of asthma had only symptoms less than once in a week in the last 3 months, according to a study published in 2007, which really doesn't correlate, right? If somebody has mild asthma, they have symptoms less than once in a week. Why should they have near-fatal asthma episodes? But this is the real-life data that people can have acute exacerbations, which can be dangerous, even with mild asthma. And hence, the focus on adding an anti-inflammatory medication like an inhaled steroid. We all know that asthma triggers are variable, they're unpredictable. We can have exposure to viruses, which is very relevant in this current pandemic. We can have exposure to environmental dust or pollution, which we can't really predict. And that can lead to a severe or acute exacerbation, even though your baseline asthma may be well controlled, or you may not have constant or persistent asthma. So for almost 50 years or so, we've been using only short-acting bronchodilators like salbutamol or albuterol as the primary treatment for mild intermittent asthma. But this has led to individuals believing that this is their primary treatment. This is what they should take, and this is all that they need to take. And as a result of which, their acceptance of inhaled steroids is poor. Their compliance to inhaled steroids is poor. And the advantage is also that they notice with the, these drugs, which are short-acting bronchodilators, is that they're relatively economic, and they're easy to buy or easy to get. They have low cost associated, and they quickly relieve symptoms. So, people will go to something that relieves their symptoms quickly. However, there is data to show that regular use of a short-acting bronchodilator can be associated with poorer outcomes. So even using it constantly for a period of 1 to 2 weeks, or using it regularly for a period of 1 to 2 weeks, has been associated with adverse effects. It leads to a downregulation of the beta receptors in the airway. This is where these bronchodilators act to cause bronchodilation. They increase the rebound hyperresponsiveness of the airways. They can decrease the bronchoprotective nature of the medications eventually when they are repeatedly being used. And they increase the allergic response and increase eosinophilic airway inflammation. So this is an alarming data that shows that just using a short-acting beta agonist may, in fact, worsen, constantly or regularly for a period of even just 1 to 2 weeks can lead to poorer outcomes. Using more than 3 canisters of a bronchodilator like salbutamol in a year can lead to a higher risk of severe exacerbations. Using more than 12 canisters, which is not unusual. I have had patients coming and tell me that they use 1 canister over a period of a week, which is very dangerous. And using more than 12 canisters in a year is associated with much higher death due to asthma, and that is an alarming number. Inhaled corticosteroids, we all probably may be aware of, are known to reduce asthma risk. They reduce the risk of asthma exacerbations and reduce airway inflammation. However, adherence is a problem, especially in people with mild asthma. Therefore, the Global Alliance or Initiative Against Asthma proposed that we, in the rescue inhaler that we prescribe to individuals, we add an inhaled corticosteroid, along with formoterol, which is classically a long-acting bronchodilator, but also has a quick or rapid onset of relief. So hence the change in the guidelines. Going forward, we also need to touch about, we were talking about right now individuals with mild asthma, but there is a subset of individuals who have severe asthma. As you can see, about 25% of individuals may have difficult to treat asthma, and about anywhere between 5 to 10% of the general population may have what we know as severe asthma or severe persistent asthma. It's not a small number, considering we're looking at an estimate of around 200 to 300 million people suffering from asthma. And so the guidelines again indicate addition of additional medications or bronchodilators. This group of drugs is known as long-acting antimuscarinic agents, or LAMA, as we call it in short. And there is this indication has also been extended to using combination inhalers to improve compliance among individuals. Inhalers which include an inhaled corticosteroid, a long-acting beta agonist, or a LABA, and a long-acting antimuscarinic, or a LAMA drug, all together in one inhaler. So in step 5 of the chart that we were noticing earlier, which I can probably quickly step back to, there is an indication for adding a long-acting antimuscarinic agent. And this has been shown to reduce the rate of exacerbations, and it has also been shown that it can reduce or improve the lung function or reduce the decline in lung function in individuals with severe asthma. So this is one welcome change. It has been around for a while now. It's not just this guideline which has added it, but increased emphasis. But the caveat is that we have to ensure that an individual who's being put on a long-acting antimuscarinic has been treated with adequate doses of an inhaled steroid. We cannot use this treatment in an individual we have not optimized the inhaled corticosteroid doses in. So it's important to adequately treat with inhaled steroids and then add this medication if the asthma symptoms remain uncontrolled. There is again some change here where there has been indication for added azithromycin, given which is an antibiotic, for those who may not be aware. This antibiotic or group of antibiotics has been shown to have a lot of anti-inflammatory effects, and hence there is an increased interest in using this drug in certain chronic disorders, including asthma and COPD. And there has been some data which shows that using thrice-weekly azithromycin can improve outcomes in individuals who have severe persistent asthma, and it can reduce the rate of exacerbations in these individuals. However, before we consider this, we need to decide, this is only meant for people who are on high-dose inhaled steroids. There's not much role for individuals, or there's uncertainty of role in individuals who are only on medium-dose steroids, and I'm talking about inhaled steroids. But we have to remember that this drug can have an implication on electrocardiographic changes in the heart, and so people need to be monitored, first to be selected carefully and then to be monitored. And it can also increase the risk of acquiring resistance to infective pathogens with constant use or regular use of an antibiotic. So we have to keep in mind the possibility of developing drug-resistant bacteria or infections in the community. There are certain atypical mycobacterial infections, which are chronic infections in the breathing tubes and in the lungs, which are treated by this group of antibiotics. So if an individual has this infection, they may not be a good candidate for monotherapy or treatment alone with this one agent. And so these individuals have to be carefully selected before we decide on adding azithromycin. Now, remember all that torture that I showed you with that diagram, and we were talking about interleukin 4 and 5 and interleukin 13 and eosinophils, was for a purpose, because now there is availability of biologic therapy for the treatment of asthma, and particularly for individuals who have a Th2-rich kind of a endotype, where these individuals mount a more eosinophilic inflammation and have predominance of certain interleukins, which are cytokines in the body, interleukin 4, 5, and 13. And how we identify these individuals is with the help of biomarkers, which I told you would be the eosinophil levels in their blood or their sputum, or it could be the presence of antibody in their blood called IgE. It could be also detected with with a breathing test that we do called fraction of exhaled nitric oxide in the breath. And these individuals, when somebody has high levels of these markers, they could be candidates rather for biological therapy. And we now have a good array of monoclonal antibodies which target these particular inflammatory cytokines and reduce airway inflammation and outcomes in, improve outcomes in asthma. These are, of course, reserved only for individuals with severe asthma and who are requiring high-dose corticosteroids or who have frequent exacerbations needing oral corticosteroids. So there are multiple monoclonal antibodies. I think one of the earliest one to be on the market was omalizumab, which is an anti-IgE antibody. There are drugs like mepolizumab, reslizumab, and benralizumab, which work on the interleukin-5 pathway. And there is dupilumab, which works on the interleukin-4 pathway. So when assessing eligibility, and if you know a patient who has severe persistent asthma, this is for my physician colleagues, and you find that they may or may not have eosinophilic inflammation when you start a treatment, it is always a good idea to recheck when they have severe persistent asthma, because these individuals can shift their patterns. They may later, during the course of treatment, show a pattern of eosinophilic inflammation, and trying to reassess these individuals is a good idea. And considering the option of biological therapy for treatment refractory or for people who have difficult to control asthma is a good idea. There are certain additional indications for which these monoclonal antibodies are also approved for. Particularly in the case of omalizumab, there has been an approval for individuals who have chronic idiopathic urticaria, or as we simply know it as hives, which is for an unknown reason, not triggered by allergies that we cannot, or allergies that we cannot identify. Nasal polyposis, or nasal polyps as we know it simply. Mepolizumab has also been approved for a condition known as eosinophilic granulomatosis with polyangiitis, or Churg-Strauss disease as we knew it in the past. Benralizumab currently has no other additional indications except for in severe asthma. And dupilumab has been approved for chronic rhinosinusitis and nasal polyposis, as well as atopic dermatitis. So there is hope. There are some breathe easy issues, points here as well, that individuals who have chronic, persistent, and severe asthma can be considered for biologic therapy. Now, there have been some additional changes to the guidelines, and these include some indications for how to perform spirometry or breathing tests on these individuals and when to hold their medications. But the point I would like to focus on here right now is there has been some data to show that we can truly primarily prevent early onset of asthma in children by treating pregnant women or women who plan to conceive and have vitamin D deficiency with supplementation of the vitamin D and correcting the deficiency. This has been shown to reduce the risk of early life wheezing episodes. So some interest there in the new guidelines. Now, although I said we're talking a lot about the pandemic, when we talk about respiratory disorders, we can't forget about a respiratory infection that worsens respiratory disorders. And so a quick touch upon COVID-19 and asthma. What has been the impact of COVID-19 on asthma? So a lot of individuals who come to our clinics or who come to doctors, I'm sure everybody has answered this question over the last year and a half. If I have asthma, am I more likely to get this infection? Well, you're not more likely to get the infection. If you have mild to moderate asthma, it's unlikely that the severity of COVID will be much more in your case as compared to another individual. However, if somebody has severe asthma or has poorly controlled asthma and has needed oral steroids, studies have shown that these individuals have worse outcomes, and there is an increased risk of COVID-19 related death. And hence the importance of having well-controlled asthma and focusing on managing your asthma symptoms well, so that the outcomes, if one were to acquire COVID-19, the outcomes of the disease would be far better, despite the fact that there is an underlying asthma. Now, a lot of people also ask about, oh, because there is a chronic respiratory, an acute respiratory infection circulating, I'm sure asthma may have worsened world over. In fact, the data is to the contrary. We've had lesser cases of asthma worldwide and lesser acute asthma exacerbations reported in the year 2020 in various countries. And probably because of the social distancing, the reduced risk of infections, people staying indoors, not interacting, not getting respiratory infections, and practicing good hygiene. So that's a welcome change. What do we do with asthma medications in the context of the pandemic? And like I mentioned, there is a role for good control of asthma, and hence no medications should be discontinued, including those individuals who have severe asthma and are requiring oral steroids. They should continue their treatment. Those who are on biologic therapy should continue the treatment. And in one study, in fact, it was shown that individuals who had asthma and who were on inhaled steroids had slightly better outcomes than individuals who had no other respiratory disorder and never received inhaled steroids. So inhaled steroid use in asthma may in fact be protective against a severe form of COVID-19. It is always advisable to talk to your physician and follow an action control plan for asthma, not just say, okay, today I think I should be taking this inhaler because I am short of breath or I feel tight today, so I'll just take this extra puff. That's not how we should manage asthma. There should be a written out plan so that individuals who have this problem are able to deal with it better, and their family members or their care providers can be a part of the planning, and they would know when there is a written plan that this is what needs to be done. So I encourage people to do that and practitioners to do that for their patients. In the context of the current pandemic, it is always better to avoid nebulization and to focus on using metered dose inhalers or pressurized inhalers, preferably with a spacer, because nebulization is an aerosol generating procedure and can cause the spread of the virus in individuals who have the COVID-19 virus infection and are nebulizing themselves. It is, in terms of hospitals or practices which offer respiratory services, it is important that we follow infection control guidelines to prevent COVID-19. The first guideline would be to avoid spirometry, which is a breathing test, simply put as a lung function test. And especially when you are reporting community transmission in the community, or to pre-screen individuals with PCR testing before we subject them to this test. Also to follow all droplet and contact precautions to avoid spread of the virus, and follow all protocols for wearing protective equipment. So again, there is the questions about, there are a lot of questions about if I'm an asthmatic, should I be taking the vaccine for the COVID-19? Various vaccines have been available worldwide. A lot of data is now available, and we know that it is safe to take vaccines in individuals who have asthma. However, there is only one contraindication to taking vaccination, and that is if you have had an allergic reaction to a component in the vaccine. So talk to your doctor. There's nothing wrong in talking to your practitioner about your risk factors, but unless there has been a severe allergic reaction, and when I say severe allergic reaction, it usually means anaphylaxis to a component in the vaccine, then yes, there may be a contraindication to using that particular vaccine. But otherwise, it's fairly safe, and for reasons that I've already shown you, that viruses or respiratory infections can be a trigger to bring about an exacerbation of asthma, which can then be life-threatening, I think it is important we protect ourselves. And when there is an effective vaccine available, perhaps it's best for all asthmatics or anybody with a chronic respiratory disorder to get vaccinated. Now, that brings us to our second topic for discussion today, which is chronic obstructive pulmonary disease. I'm going to have to brush through this because I see a clock ticking in front of me somewhere hidden there. And so I'm going to just talk about it quickly. For a lot of people, when we tell them you have a diagnosis of COPD, they ask me, what does it mean? So it simply means chronic obstructive pulmonary disease. By definition, it is a preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation, which is because of either airway inflammation or because of alveolar abnormalities, and is usually caused by exposure to noxious particles or gases, particularly tobacco smoking. The common symptoms are cough and progressive shortness of breath. Recurrent lower respiratory tract infections could also be a warning sign of an underlying COPD. Why is it important to know about it? I already mentioned at the beginning. In the year 2020, and in fact, even before then, COPD has been declared as the third leading cause of death worldwide. And it caused about 3.23 million deaths in 2019. So it's not something trivial that we're talking about. We're talking about a respiratory disorder which gives us a lot of morbidity and mortality. And there are a lot of modifiable risk factors which contribute to developing this disease. And these are tobacco smoking, occupational exposures, air pollution, genetic factors, of course, socioeconomic status of an individual, underlying asthma, and or other risk factors as well. Again, unfortunately, like most other chronic respiratory disorders, most of the morbidity and mortality is seen in the low socioeconomic group of society and in low and middle income group countries. So what really happens in COPD, as I've already touched upon, there is a cause. So there is environmental factors like tobacco smoke. There are genetic factors which make an individual susceptible to COPD. These lead to inflammation in the airways. These lead to damage to the alveolar epithelium. It leads to what we know as airflow limitation in the small airways. It leads to development of what we know as emphysema, or thinning out and dilatation of the air sacs. And as manifestations, it manifests with shortness of breath and cough. At the cellular level, this is what happens. So again, there is a trigger, which is either an infection, or it is exposure to a noxious particle or a gas or tobacco smoke, which leads to inflammation in the epithelium. The inflammation can follow different pathways, but the baseline is that there is a discrepancy or an imbalance in the pro-inflammatory and the anti-inflammatory mechanisms in the lung, which then leads to airway damage. When it follows a certain pathway, which again is more the inflammatory pathway or Th2 type pathway, it leads to what we know as chronic bronchitis. When there is a more neutrophilic tendency, it leads to alveolar damage and destruction, known as emphysema. Emphysema, individuals, like I mentioned, will have more damage to the air sacs and will have decreased elastic recoil in the lung. In bronchitis, individuals will have more dilatation and thickening of their breathing tubes, which leads again to chronic cough. The spectrum is more of chronic cough in bronchitis and more of shortness of breath and emphysema. However, this is a spectrum. So COPD encompasses both these diagnoses. And the diagnosis is made based on symptoms, of course, assessment of risk factors, but the diagnosis has to be confirmed with the test known as spirometry, which I have earlier mentioned is a simple breathing test where an individual is expected to blow into a machine. We record the flow of air or their forced vital capacity and how much air they can breathe out in the first second when they're doing a forced breathing out maneuver. And that helps us classify the severity of COPD. So there is, again, just like I mentioned, GINA, or a global initiative against asthma, there is something called GOLD, which is a global initiative against obstructive lung disease. And that helps us classify COPD based on the severity that we see on the lung function test as GOLD 1, 2, 3, or 4, or simply put as mild, moderate, severe, or very severe. However, just looking at a breathing test should not help us assess the severity. And most international bodies now recognize that because an individual will have symptoms too. So assessment of severity of symptoms is equally important. And this is usually done using a dyspnea scale known as the MMRC or modified MRC dyspnea scale. And based on the individual symptoms, they are classified into a grade 0, 1, 2, 3, or 4. Individuals are also given what we know as a COPD assessment tool, which is a 40-point questionnaire where somebody rates their symptoms on a scale of 0 to 5, and there are 8 such questions asked. And then we categorize which category they fall into. Now, after looking at their breathing test results, after looking at their presentation of symptoms and their self-assessment of their COPD, we further classify them on an ABCD model, which then helps us assess where this individual actually stands. Are they mild COPD with severe symptoms and high risk of exacerbations? Are they mild to moderate COPD with less symptoms and less chances of exacerbation? Are they severe COPD with less symptoms and less risk of exacerbations? Or in that spectrum, sorry. It gives us categories A, B, C, and D, and this helps in the management of these individuals. So the standard of management in stable COPD is using bronchodilators. These bronchodilators could be short-acting or long-acting. The group of drugs that we now recommend for use in individuals with COPD are long-acting antimuscarinic agents. These can be either used alone or in combination with a long-acting beta agonist, which are, again, a group of drugs which we've touched upon during management of asthma. These are basically long-acting bronchodilators, to put it simply. And that is now the, the standard of therapy. There is a role for adding anti-inflammatory medications like inhaled steroids, like we do in asthma. And there are certain groups of individuals who will benefit more from addition of inhaled steroids, and I'll touch upon that again. But individuals who have frequent exacerbations, or individuals who have had flares of COPD which require hospitalization, or who have a high eosinophil count, which we talked about earlier, will benefit from adding inhaled steroid. And those are the individuals we should consider adding inhaled steroid or a combination therapy with inhaled steroid, a long-acting bronchodilator from the beta agonist group, and a long-acting bronchodilator from the muscarinic group. So regular treatment will improve outcomes, reduce risk of exacerbations. And again, like I mentioned, triple inhaler therapy has been advised in these group of individuals. There is little role for adding oral steroids in individuals with COPD, because most of this inflammation is chronic and permanent, and steroids or systemic steroids are only reserved for short courses during an acute flare of COPD, but not during routine management of stable COPD. In individuals who have frequent exacerbations, there is a new group of drugs which is now available, which is known as phosphodiesterase 4 inhibitors, or roflumilast. And this group of drugs can reduce the risk of recurrent inflammatory exacerbations in these individuals. There is some role for antibiotics. Again, we've talked about adding azithromycin in another respiratory disorder, and there is some role where people talk about adding azithromycin, but it comes with the same risks, and also of developing drug-resistant infections in the community. So we don't advocate it routinely, but this is an option. There are other drugs which are mucolytics, or drugs which reduce mucus production in the airways, and these are used. There are certain other anti-inflammatory agents which have been proposed, but so far there is not much guidance for the use of these drugs. Some individuals have, like I mentioned, there was a genetic predisposition, and they have a disorder known as alpha-1 antitrypsin deficiency, where they genetically do not produce an antiprotease in the body, which is known as alpha-1 antitrypsin. This leads to increased neutrophilic inflammation in the lungs and causes early onset of emphysema or COPD, particularly when individuals present with COPD symptoms at an early age, whether they're smokers or not smokers, say in the age group of 40 and over. We should be looking into this cause and assessing or screening them for alpha-1 antitrypsin deficiency. And augmentation therapy is now available to substitute this enzyme in their blood by regular infusions to reduce the risk of exacerbations and ongoing lung damage. Other drugs have not shown to have much role in, in managing stable COPD. I mentioned about the corticosteroids. The strong support in favor of using inhaled steroids is for individuals who have eosinophilic inflammation, for individuals who have frequent exacerbations. It can be considered in the individuals who are in between, who have had one moderate exacerbation in the year, or who have blood eosinophil counts in the 100 to 300 range. But they are not of much use in individuals who have had recurrent pneumonias or respiratory tract infections, for the simple reason that inhaled steroids may increase the risk in such individuals to develop another infection. We've been talking constantly about pharmacotherapy, treatment options. We cannot forget that non-pharmacological interventions are equally important in individuals with chronic respiratory disorders, particularly COPD. Smoking cessation is the most important advice that we can give to an individual who has COPD and smokes or continues to smoke. And I think that should be the first thing all physicians should consider advising their patients. According to the recent GOLD report, a session that a physician provides to the patient about smoking cessation has far more impact on actually quitting than an individual trying to do it on his own. And so I encourage everybody, who practices medicine to encourage their patients who are current smokers to give up, particularly if they're showing symptoms of COPD. So that should be one of the first discussions we have, and I'm sure it is. There are treatments available for encouraging individuals to quit smoking. These could be nicotine replacement therapies in the form of patches, gums, lozenges, sprays, etc. There could be other pharmacological or other medications that can be provided to reduce urge of smoking or to reduce the side effects from quitting tobacco smoking. And there has been an increased interest in individuals for the use of e-cigarettes to help them quit. And because this is so relevant in the current context or in the current generation, I do want to touch upon it. The use or the benefit of e-cigarettes in helping individuals quit is uncertain. There was one study which showed no benefit. There was another which showed some benefit. But we must remember that these e-cigarettes are not just vaporizing nicotine, but also a lot of other chemicals. And there have been case reports of severe acute lung injury, eosinophilic pneumonia, alveolar hemorrhage, respiratory bronchiolitis, and other lung abnormalities, even death with the use of e-cigarettes. So a word of caution there. Although some studies have shown that they may benefit or improve the rate of quitting, we still have to weigh the risks and benefits. There are other non-pharmacological interventions that can be used for individuals with COPD, which include oxygen therapy and use of non-invasive ventilatory support. And these are for individuals who have stable COPD and are right candidates for the treatment. We all know that oxygen can be a double-edged sword in people who have COPD. So too much is bad and too less is bad. So optimizing oxygen therapy or providing long-term oxygen therapy to individuals who are the right candidates does improve quality of life and helps improve their activities of daily living. So using interventional therapy for COPD is again something that has been around and is developing every day, every year. And there has been focus on lung volume reduction surgeries, either surgically with bulectomy or bronchoscopic interventions like coiling or bronchoscopic interventions like endobronchial valves. There is also a role for lung transplantation. Particularly, I talked about certain young individuals who develop COPD because of genetic risk factors, or in younger individuals, not in the very advanced age group, who may still be candidates for lung transplant. There are a lot of preventive aspects. So we've looked at the medical treatment, we've looked at the non-pharmacological treatment options, and now we come to the preventive aspects of COPD. And I already mentioned smoking cessation is one of the most important interventions, but also improving air quality or improving air pollution levels where we live, and focusing in general on this aspect is important. Avoiding occupational exposures or using protective equipment when we have occupational exposures to noxious chemicals or dust or fumes would help. Again, we should always evaluate for what are this individual's risks before we can provide such advice. Again, vaccination has a very important role in COPD, and for ages together, the management of COPD involves preventing preventable diseases or infections. And that helps improve outcomes in COPD. Each infective flare of COPD leads to worse outcomes and further deterioration in lung function. So preventing what we can, like providing influenza vaccination to individuals annually, providing pneumococcal vaccination, which is one of the most common forms of bacterial pneumonia in the community, providing Tdap or pertussis vaccination to individuals who haven't received it when they were younger. These are all recommendations. These guidelines were published before the vaccine was available, and so I will try to include COVID vaccination in this group as well. I think it's very relevant to prevent COVID-19 in individuals who have COPD, who already have poor lung function, who have severe respiratory symptoms, and then go on to developing an acute viral infection of this nature. Their survival and performance status is far worse than an individual without a chronic respiratory disorder. Again, there is role for other interventions like pulmonary rehabilitation, which has been shown to improve readmission rates. It has been shown to improve performance of an individual. There is a role for educating individuals about how to manage themselves better. And I think all of us forget this aspect as physicians when we talk about management of a disease. We are so engrossed in the pathology and the treatment options for the pathology, we forget about a holistic approach and about addressing individuals who cannot be helped further with palliation of symptoms, offering them hospice care, offering them end-of-life decisions, talking to them about it. Say, if you're not going to improve, how do we manage further? Providing pain relief when they're in discomfort, providing oxygen, providing adequate nutrition. So this is something we should look at in terms of managing COPD. And just to briefly touch upon, I'm not going to take much time here because I think it's obvious from what we've discussed through the day today that COVID-19 can have a serious impact on individuals with COPD. So if you suspect an individual with COPD having SARS-CoV-2 infection, it's a good idea to screen, to test them. The testing can be done with PCR, maybe even with rapid antigen testing. These individuals should be tested to look for the extent of involvement of their lung, so preferably CT scans to see the disease severity, optimizing the treatment for COPD, where relevant, if there has been a deterioration in their oxygenation, addition of medications which are currently indicated for treatment, which include remdesivir in individuals requiring oxygen or steroids, should be considered. Early non-invasive support, high-flow oxygen supplementation, and if required, even ventilatory support may help survival. So just a quick review. So if you have an individual who has been exposed, screen, understand what their symptoms are, treat what you can. And for those individuals who recover after COVID-19, I have already mentioned that every time an individual with COPD develops an acute respiratory infection, their lung function declines. They need a long-term supportive care. They will need maybe oxygen in the post-discharge period. Maybe they'll need more pulmonary rehab. So having a post-discharge plan for these individuals is equally important. So I think, I don't think I have the scope to discuss the details of this management, but it is important to prevent, as I've already mentioned, particularly individuals who have COPD, early recognition and early supportive care or treatment options when we have them. So that brings me to the end of this presentation, and in fact, for anybody who has questions, feel free to ask. I think we have a change of 10 minutes left for that, so I'll be happy to answer any questions that you might have, and I really thank you for your patient listening. Take care. Sorry? Oh, sure.
Do we have any questions in the audience?
Good morning. Thank you for an excellent presentation. You mentioned e-cigarettes in the context of smoking cessation. I think we're all aware that there's a problem with young persons using e-cigarettes for recreational use, but not only young persons, we have persons in their 30s and 40s also using e-cigarettes, not for smoking cessation, but for recreational use. What is your advice to these persons?
My advice to anybody who smokes anything is not to smoke, usually, whether it is an e-cigarette, whether it is tobacco, rolled tobacco in a cigarette, tobacco in a cigar, marijuana, any inhaled product can cause lung injury. So if e-cigarettes are being used for recreational purposes, it's obviously not a good idea. A lot of people tell me, oh, it's a non-nicotine based e-cigarettes, it's just flavoring agents. And I always have this to say, that we know about the harm that cigarettes cause. We know that there are at least 70 or more carcinogenic products in tobacco smoke. We don't know about what the impacts of the chemicals that we're vaping may have on our long-term lung health. So we already have case reports, I have already mentioned. And so if you're using it purely for recreational use, perhaps it's not a good idea. And I always discourage people from smoking anything.
Any other questions? Dr. Archita, we've also received another question, so if no one else in the house has one. And it says, what can I use instead of oral steroids for my asthma, given the risk is higher if I get COVID?
Now, I knew this question would arise in a lot of minds, and I want to emphasize here, what is important in having better outcomes when you have asthma and acquire COVID is that your asthma is well controlled. If oral steroids are needed or you are somebody who has had chronic persistent asthma, which is steroid dependent, and are not a candidate for other therapies, it is advisable to continue oral steroids, because if the asthma symptoms are not controlled, the outcomes with acquiring a COVID-19 infection are far worse. So I remember putting up a slide there which said that if you are on biologic therapy or are already on oral steroid, please continue it. Do not discontinue. If there are options, discuss them with your physician. If there is a scope for improvement in your inhaled therapy alone, it is a good idea to try and enhance your inhaled therapy rather than being on oral or systemic therapy. But if you don't have an option, please control the asthma. Yeah? The moment you try to withdraw something, flare up with your asthma, end up in a hospital, or get this infection, the outcomes are far worse.
Thank you. Okay, one more on the floor.
Okay. Just while you're on the topic of asthma, I'd like you to clear something up for us. Because I often hear my patients say, when I ask them, do you have asthma? They say, well, I had it. I had asthma when I was a child. Is it a case of once an asthmatic, always an asthmatic? Because I think many people are a little bit confused where this is concerned.
Yes, that's a very good question. And asthma is a very variable disease. As I may have, I don't know if I did touch upon it, but asthma is variable, in its presentation, in its exacerbations, in its change over a period of a lifetime, and hence the model of the step up and step down therapy that we've talked about. So a lot of individuals say, oh, I had childhood asthma and I grew out of it. It is true, it is possible that happens because your immune responses change over a period of time, or you may not be exposed to the same allergens as you were earlier, or you may have been living in a certain region which exposed you to certain kind of allergens and now you don't live in that area. Maybe cold temperature or smog was your trigger and you don't get yourself exposed to that anymore and your asthma symptoms may be well controlled. But once an asthmatic, always an asthmatic may be too extreme to say, but once an asthmatic and if you have symptoms which indicate mild or intermittent asthma, it is better to assume that you do have asthma or mild intermittent asthma or a tendency or predilection to have airway inflammation and have the knowledge and the resource to treat it in case of an acute exacerbation. Because exacerbations, as we've just discussed, are unpredictable. They are not going to come with a warning sign that I'm heading your way and you're going to have an asthma attack. It can be unpredictable, it can be variable, and it can be sudden. So it's always good to have a plan. And hence the discussion about an asthma action plan. If you've had asthma in the past, you notice every time you get a flu-like illness or get a cold, you start wheezing or have chest tightness, and you say, oh, it's just related to the respiratory infection. It's better to discuss this with your physician and have a plan in case this happens again, in case it's severe, or in case it doesn't subside, what am I going to do, right? So I think it would be too extreme to say that, oh, you had childhood asthma, and so you're an asthmatic for the rest of your life. But it is better to be aware of where you stand and better to be aware of what you should do in case you have symptoms, right?
Okay, just one final question, Dr. Archita. Do you recommend wearing masks for severe asthma? Is there a preferred type of mask that an asthma sufferer should use?
There is no preferred mask per se, but yes, I know I have a lot of patients who tell me I can't breathe when I'm wearing a mask, I feel suffocated. But believe me, wearing a facial protection that covers both your nose and your mouth, or a filtering face piece as we call it, is extremely important in reducing the amount of infection that you may acquire. Now, the type of mask for an asthmatic is not different, but the type of mask may be different in context of the type of exposure that you're going to have. So if you're in a social circumstance and you are distancing yourself, or you're outdoors, you may briefly be able not to use your mask, particularly if you're vaccinated. If you're maintaining a good social distance, you're at least 6 feet away from individuals and are not in a closed indoor environment. But whenever you are in a closed indoor environment, it is better to have a mask that covers both your nose and your mouth, not hanging under your chin, not over your forehead, not lying on a table surface where it's in touch with almost everything else, preferably on, if you must remove it, on a paper napkin, which doesn't let it get contaminated, or in a pouch, which keeps it from touching other surfaces. But I would advocate wearing a mask. If you're in the healthcare sector, you look after individuals who are sick, or you are tending to somebody who's not well, if you feel that you're going to be exposed to individuals who produce aerosols, wear a higher category filtering face piece, like an N95 mask maybe, which will be more protective. However, for general individuals in general, in the public, it's better to wear either a cloth or a surgical face mask. Also important to remember that these are disposable masks. They should not be reused. So it's preferable if you feel uncomfortable with a mask of this nature or you tend to reuse, it's better to wear a cloth mask and clean it often. But individuals with asthma, to answer your question, should wear a mask.
I know I said that was the last, but we have one burning question coming in from online.
You have 2 minutes.
Okay. So it says, with the updated GINA guidelines, how have asthma action plans changed since step 1 and 2 involve the use of ICS? How do you advise how to increase the dosage before using a SABA or NEX? Seeking help.
Could you just repeat the question?
Okay. With the updated,
last part,
yes. How do you, how to increase the dosage before using a SABA or NEXT? Seeking help.
Well, I'm a little confused with the question because an SABA is not what we are asking individuals to add, but an LABA or a long-acting beta agonist or a long-acting antimuscarinic in uncontrolled asthma. So the way to assess is, first we establish the diagnosis, just to elaborate on that circle that we were talking about. Establish the diagnosis, look for comorbidities, and look at whether a change in the individual's symptoms, whether they have moved now from level 1 to level 2 or level 3, is to assess if there are any other triggering factors and mitigating those as well. So you understand if they have a new pet in their house and they know they're allergic to the pet and that's triggering their asthma, you want to avoid those things. You want to advise the individual to say, this is your trigger and you can avoid it. Or is this something else which is mimicking asthma? You want to try and, of course, assess that as well. And if this is a true deterioration in asthma control, then adding layers to the treatment. So according to the new step pattern, I don't know if I can go back. Maybe somebody can put me on. According to the new step ladder pattern, the step 1 is, for adults and adolescents over 12 years, is that we start with an as-needed inhaled corticosteroid along with, we add an inhaled corticosteroid along with formoterol. Now, formoterol was chosen because although it has the characteristics of a long-acting beta agonist, it also has rapid onset. And so it can be used as a rescue inhaler. And that gives an individual 1 inhaler to take. Now, for children, you may have noticed in that pattern, again, there was something which said that if you use a bronchodilator like a salbutamol or short-acting beta agonist, you add an inhaled steroid along with it. Each time you take that, you give that child another dose. Most adults are not going to do that. We know that. So providing them with 1 inhaler, which has both the steroid and a relatively rapid onset and a longer-acting bronchodilator is a good idea, as needed. Yeah, I think we are there now. This is advisable for both step 1 and step 2. When they continue to have persistent symptoms or are having frequent episodes of wheezing, are requiring their rescue inhaler therapy more often, you increase the dose of the steroid component in the inhaler. Say if you're using formoterol with budesonide or using formoterol with mometasone, you increase the dose of the steroid component in that inhaler combination and assess for control. You can also think of, there is a track 2 which is running at the bottom, which is our traditional way of treating. That if you're not using a formoterol-based combination in an individual who you know is very compliant to inhalers, it's just fine. You can give them another long-acting beta agonist or steroid. What we know as, other combinations would include fluticasone, which, with combination with salmeterol or vilanterol. There are multiple combinations. And if you know that the individual is compliant, you can continue to follow the traditional pathway, which is where you give them a regular, dose of just inhaled corticosteroid and give them a short-acting beta agonist when needed. Or you give them a low-dose maintenance inhaled corticosteroid and a beta agonist when needed. or a low-dose maintenance inhaled corticosteroid and beta agonist, long-acting beta agonist, along with as-needed inhaler. And once they progress, you increase the medium dose, and then you add LAMA, or long-acting antimuscarinic. This is our traditional track. This is still an alternative. It's called track 2 now, but this is the change that has been suggested, that in individuals who you know are not going to be compliant, you give them a prescription for an inhaled steroid, they are probably not going to take it because they have mild symptoms or their compliance is not good. It is better to add an inhaled corticosteroid and formoterol combination as needed, and or you can give it to them continuously as a maintenance when they reach a level 3, and use this as their reliever as well. So this therapy is known as MART, or maintenance as well as rescue therapy. So they use the same inhaler. They're just carrying one, so that they're more compliant. They carry one with them, take it when they need it. If they need it every day, they take that regularly and use an additional dose when they have an acute symptom. So this is the change in the protocol, and only in step 5 we think of adding long-acting antimuscarinics. Now, to answer the question that the individual asked, I'm sorry I had to go back just to make my point, is that when to add is based on subjective and objective assessment of asthma. So when an individual comes to you, usually there are questionnaires or tests that you can use to assess asthma severity or asthma symptoms. I usually use the asthma control test, which is a globally accepted parameter, or you can use an asthma control questionnaire. These are multiple point questionnaires which allow an individual to answer how their symptoms are controlled. And you look at the score on it. If it looks like their asthma is well controlled, if they're not using rescue medication every so often, you can choose not to change their treatment option, their treatment step. If their symptoms are not well controlled, if they have audible or clinical wheezing, if they're using a rescue inhaler every so often, you step up. So that's how we step up and step down. And all individuals, any individual with asthma, can progress from one step to the other over the course of their asthma. So somebody may have mild intermittent, but then start needing regular therapy because they have persistent symptoms. Somebody may step down back into where they were. So it's a step up and step down process. And I think it's the physician's job to assess where their patient is before they think of adding medication. And looking for identifiable triggers, looking for other things that may be triggering their asthma as well, or ruling out other things that may be mimicking their asthma. It may not necessarily be worsening of asthma.
Thank you very much, Dr. Thank you for that answer.
All right. That was really the last?
That's the end of our Q&A.
Thank you so much.
Thank you.
Supposed to clean everybody.
It's reassuring to know world-class healthcare is right here at home. We have Cayman's most comprehensive suite of in-house services to diagnose and treat a wide range of diseases and conditions. Bringing together leading experts, the best technology, and the latest techniques, we work as a team to understand your health and ensure you get the best possible outcome. From your first appointment through to treatment and follow-up, your journey with us is seamless. Health City, world-class healthcare within your reach.
So we want to thank Dr. Archita very much again for that very informative presentation. And we want to welcome those of you who may have joined us since our initial welcome this morning. Also want to acknowledge the presence of our Honorable Minister for Health and Wellness, Ms. Sabrina Turner. Welcome again, everyone. So thank you again, Dr. Archita. Those were very interesting comments. And for those who are suffering from chronic respiratory conditions, it's reassuring to know that even though they may not be curable, there are various treatments available to control the symptoms and to improve the quality of life. So our next speaker then, on to our next presentation, is Dr. Irka Ebanks, Complementary and Alternative Medicine Physician at the Health Services Authority. In their new Complementary and Alternative Medicine Clinic. Dr. Ebanks will be presenting virtually on the topic of using complementary and alternative medicine to breathe easier. Let's listen.
Good morning. Thank you for having me today at the 12th Annual Healthcare Conference. My name is Dr. Irka Ebanks, and I'm going to be speaking on using complementary and alternative medicine to breathe easier. The objectives for this presentation begin with, what is CAM? For many of you, you may know, but for others, this will be a brief introduction. We'll then look at what it's like to have a consultation with a medical herbalist. We'll take a look inside the herbal medicine dispensary, and then we'll proceed to 2 cases, and finally, we'll have a few pointers in the summary. So what is CAM? How is complementary and alternative medicine defined? Well, firstly, I must say that there has been great debate over the years about its definition. Scattered throughout the literature are various versions. However, this one that has been developed by the Committee on the Use of Complementary and Alternative Medicine by the American Public is fairly well accepted. It reads, complementary and alternative medicine is a broad domain of resources that encompasses health systems, modalities, and practices, and their accompanying theories and beliefs, other than those intrinsic to the dominant health system of a particular society or culture in a given historical period. CAM includes such resources perceived by their users as associated with positive health outcomes. Boundaries within CAM and between the CAM domain and the domain of the dominant system are not always sharp or fixed. In 2000, the National Center for Complementary and Alternative Medicine developed a classification system to better categorize, as there are numerous modalities. The first are those that fall under alternative medical systems. And as the name implies, it is a category that extends beyond a single modality and refers to an entire system of theory and practice that developed separately from conventional medicine. Examples include traditional Chinese medicine, traditional Indian medicine, or Ayurveda, homeopathy, and naturopathy. The second category is mind-body interventions, which include practices that are based on the human mind, but that have an effect on the human body and physical health, such as meditation, prayer, and mental healing. The third category, biologically based treatments, include specialized diets, herbal products, that one is near and dear to my heart, and other natural products, like supplements or nutraceuticals. Examples could include fish oils and omegas. The fourth category is manipulative and body-based methods. This category includes therapies that involve movement or manipulation of the body. Included here are chiropractic therapy and massage therapy. The fifth and final category in this classification scheme is energy therapies, which include the manipulation and application of energy fields to the body. Example, Qigong, Reiki, and therapeutic touch. I've underlined or highlighted herbal products because this one is near and dear to me. As I'm a herbal medicine practitioner, let us go through what it would typically look like to have a consultation with a medical herbalist. As you see on the slide, patients can be referred by other healthcare professionals, but may also make appointments on their own, depending on the type of clinic. Typically, the conditions addressed are chronic. Example, sleep disorders and fatigue, stress and anxiety, coughs, colds, flu, digestive health, and so on. Someone once asked me which I prefer, if conventional or complementary medicine, and I replied, I cannot choose and believe that both should have a space on the platform to shine. Conventional medicine is incredible when we think of acute medicine, cutting-edge surgeries, etc. But where it sometimes lacks is in the chronic illnesses area. Often, patients just cannot find relief or even answers, and this is when many of them seek alternatives. When the patient comes to the clinic, they first register with the registration clerk, as with any service at HSA. They then take a seat and wait for a nurse to call for triage. Once triage and screening is complete, the patient then waits in the reception area to be called by a practitioner. In this case, myself. Once with the practitioner, a thorough case history is taken. This tends to be a little longer and a bit more detailed. Of course, we ask about the main reason for visiting the CAM clinic. We ask about past medical history. Very importantly, we ask about medications and bodily systems. We go through each one, but we may go into more detail regarding a patient's constitution, their temperament, and if the practitioner has some training in Ayurveda or traditional Chinese medicine, then some questions could be incorporated into the thorough case history here as well. Diagnostics can also be ordered. Vitals would be in the system, of course. Physical exam would be included, and particularly in holistic medicine, we tend to use tongue and pulse diagnosis as well. And for some practitioners, they'd use basic iridology, which is to look into one's eyes to help with diagnosis. Blood investigations can be ordered. Labs and imaging could also be ordered. We would give lifestyle changes, basic nutritional advice, and other recommendations. So what is usually unique to these types of consultations are the individualized formulas. Here at HSA, products are ordered in bulk. And when the practitioner, myself, prescribes a bespoke formula, our CAM pharmacist, Rosemary Bailey, then prepares it and the patient later collects it. Here is what our HSA CAM clinic looks like on the inside. In the far left corner, you'll see on the bottom the consultation room, and just to the side we have the compounding room, where the remedies are mixed or prepared, and also this is where the bulk items are stored. At the very top we see the dispensing room, and we see liquid tinctures and also dried herbs in the glass jars there. We have essential oils and we have creams, etc. This slide now shows the various preparations that can be made using botanical products. It's not an exhaustive list by any means, and we can start by using dried or fresh herbs, mostly dried. We have teas, or what we call infusions. These are typically the delicate parts of the plants that are infused into water. We have decoctions. These use the hard and woody parts like the roots and the bark. Then there are infused oils. The plant particulate is infused in a carrier oil, and poultices, which are topical applications that use moistened herbs to apply directly to skin. And then we have various other preparations that can be made from those. Moving on, we have tinctures. These are alcohol-based, which is a better solvent than water. And they can be done using either dried herbs or fresh herbs. Traditionally, they were made using vodka or brandy. The alcohol also allows for a longer shelf life, but tinctures can also be made using vinegar and glycerin. They are liquids. And we have liniments. Those are liquids for external use, usually done by using alcohol and alcohol plus vinegar or alcohol plus oils. On the far right side, we have powdered herbs. These typically start from dried herbs and they're ground to produce a powder. And as you see there, they can be taken straight away just like that in juice or water, for example. But they can also be made into capsules for easier ingestion for the patient. Also, glycerites and suppositories and pessaries can be made. Now we're going to go through our case studies and see how we can apply complementary and alternative medicine. In case study number 1, we have a 36-year-old patient who's been suffering with chronic sinusitis for approximately 4 years. He has a history of allergic rhinitis with chronic use of antihistamines and nasal steroids. He's taken a few courses of antibiotics, but these have failed to resolve the condition. And of note, in his case history, he mentioned that there is a high dairy intake, and he's also a cigarette smoker. His physical examination was fairly unremarkable. The plan for this patient was to create an ointment which he could use to rub over his sinuses, and an essential oil mix for steam inhalation. He was advised to avoid antihistamines and steroid-based decongestant drugs. He was recommended to start a dairy-free diet for at least a period of 3 months. And the reasoning behind this was because it could potentially be the trigger for some of his allergies. And of note, it was explained that the sinuses are relatively inaccessible regions of the body, and once a chronic infection has taken hold, it can be difficult to eradicate. The patient understood and still wanted to proceed with treatment. The target in this case would be the respiratory system, and here I give examples of what could be included in these formulas. For the ointment, we could include immune modulators to support the immune system in its fight against microbes, and examples would include echinacea, andrographis, and picoriza. Also included could be anticatarrhals or mucous membrane tonics. These help clear the stasis or mucus and dry up secretions. Examples, eyebright, golden seal. And just a note about golden seal, we like to use this carefully as it's on the endangered list, and we should obtain from reliable sources which harvest from cultivated patches. Also here we see ribwort or plantain, which is different from the plantain here in the Caribbean, which I did not know initially. We could use things like eucalyptus, tea tree, frankincense, and myrrh. The patient could use just a few drops in water once or twice a day, and before bed is great. The ointment he would rub on over the sinuses for approximately 10 minutes once or twice daily. The patient is then seen approximately 2 to 3 weeks to ensure that there are no untoward side effects, such as allergic reactions or dermatitis, and also to determine if the patient is compliant and how everything is going in general. I tend to schedule most of my follow-ups after the patient has commenced their formulas in 2 to 3 weeks' time, especially for that particular reason of ensuring that there are no untoward side effects. This patient in particular, after a period of 6 months of treatment, symptoms were considerably improved. Case number 2, we have a 34-year-old female known to suffer with allergic rhinitis and congestive issues. She came in because of progressively worsening low moods and anxiety, and she suffered with subsequent insomnia, which has been happening for about 6 months. Of note in her history as well, we went through her diet, and it was pretty obvious that her dietary choices were poor, and she was suffering with constipation mainly. She also mentioned chronic lower back pain for approximately 7 years, and she'd been going to the GP and orthopedic specialists, and she had had an MRI done as well, which showed minimal changes or nothing significant. She has been attending physio sessions, and she was prescribed pharmaceutical analgesics, but she was not compliant with those. And of note, she takes no other medications. Physical examination in this case as well was fairly unremarkable. I wanted to mention here that at times patients come with so many ailments, and it may be a little overwhelming even for the practitioner. However, it's important to remember that the aim is to get to the root cause, which may take time. And we could use the analogy of peeling away layers of an onion to get to the core. Patients come, and we shouldn't simply see a list of symptoms or diseases, but aim to find those underlying connections. Also, when working on a plan, at times, less is more. Not all issues can be tackled at once. The plan for this patient began with baseline blood investigations, as you see listed there, and we provided herbal formulations in the form of a tincture and a tea, and I also referred her for acupuncture and chiropractic therapy. Baseline blood investigations were all within normal range except for vitamin D. Her vitamin D level, it was deficient. This could have been the cause for her constipation, low moods, and insomnia, or perhaps simply a contributing factor. Here we see that the main target is the nervous system. We wanted to provide her with some relief in terms of her anxiety. She came in and she was quite broken looking, and you could almost feel the anxiety that she was feeling. So here we see that we could use anxiolytic and nervine tonics. These were to promote relief from anxiety and insomnia, but overall as well, just to bring some restoration to the nervous system. Examples include chamomile, lemon balm, passion flower, skullcap, lime flower, and valerian. And just a word of caution with valerian is that in some persons it may act with an opposite effect, so much so that it doesn't give relief or relaxation. It can actually cause an energetic boost. The secondary target would be her digestive system, because of course in holistic medicine we believe that digestive health is at the core of overall health. We included bitters and cholagogues, which would improve digestion and liver function, and examples of these are dandelion root, barberry, milk thistle, and globe artichoke. We also included gentle digestives and gentle laxatives. Again, we see the chamomile coming up, and with the laxatives, we have yellow dock or licorice. And just a note on laxatives, just as in conventional medicine, we would not want to use those long term. And in this case, we would not need to use anything too strong. Additional targets included her respiratory system. So we would include anti-allergic or anti-inflammatory herbs such as the baikal skullcap, chamomile again, and marigold and frankincense. Many of you know frankincense. Also respiratory decongestants or anticatarrhals. These drain excess mucus and dry up secretions, as in the previous example. And here we have thyme, peppermint, and elderflowers. On subsequent follow-up, referral to a holistic or naturopathic nutritionist would be beneficial. We wanted a full dietary review, not just to provide a structured approach to her diet, but also because it was important that the patient have professional help in terms of removing certain foods which could have been triggers for her allergies. A naturopathic nutritionist would also test for allergies and nutritional deficiencies, and also provide supplements or nutraceuticals where needed. Of particular importance with this patient as well, relaxation techniques would be ideal. Yoga, for example, but in this case, perhaps a form of yoga that's more relaxing, such as hatha yoga. It would provide a more grounding and relaxing experience. Also Reiki and massage therapy with aromatherapy and reflexology could benefit. Further considerations on subsequent follow-ups could include hot and cold water therapy used in the management of pain, and it also helps to improve immunity. Dry skin brushing, which helps to detoxify skin by increasing blood circulation and promoting lymph flow. Grounding techniques and breathing exercises for that underlying anxiety and overwhelming feelings. The classic tips, of course, are eating well, staying hydrated, good sleep hygiene, exercise, and sunshine. And in this case, eating well does not just mean particular diets, but just to incorporate a more wholesome diet, remove refined foods and sugary foods, processed foods as much as possible. In this particular case, we found that after, quote unquote, peeling away the layers, we saw that many of her symptoms may have manifested due to physical and mental trauma, and so a counseling referral was pertinent. Remember that not all physical symptoms are solely attributed to the physical sense. Our health is the complex intertwining of many aspects of our lives. And as the WHO in 1948 defined, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, a phrase that we can still apply today. For myself and many others, breathing easier isn't simply about the respiratory system or the literal sense of the phrase, but also about what happens once there is breakthrough in the burdens we may feel when our health is not optimal. For some, it may take years of seeking help and one's own discipline towards change, but it's so important to make positive strides, aim to find the root cause of those burdens, and to address them. In summary, I'd like to leave you with a few pointers. Botanical medicine is no magic bullet. It works best when applied as a lifestyle change, and remember that what works for me may not work for you, and vice versa. More does not always equal better, and be mindful that these are medicines as well. Complementary and alternative medicine, like conventional and orthodox medicine, works best when a multidisciplinary approach is taken. Patient compliance and dedication are so crucial to successful treatment. And of course, if you are dealing with an acute or serious issue, then please seek immediate medical attention. This is likely not the time to apply CAM. Thank you for having me here today.
So Dr. Irka, thank you for that. Dr. Irka Ebanks is in the audience with us. So if we have any questions on the floor, she will be pleased to answer those.
Thank you very much for an interesting talk. I'm just interested to know how complementary medicine is regulated on the island. I'm sure it's got an important role for chronic illness, but for most of us who's not familiar with it, obviously we would want to make sure quality assurance is adequate. In terms of the treatment, when we use a drug in conventional medicine, they're tested, they're coming from licensed factories, we know the quality. When you saw some alternative herbal medicine, how can you ensure the quality is adequate and safe? Do you also have a dictionary or like a formulary for all the complementary herbal medicine that you use?
Hi, thank you for the question. So we order our herbal medicines through our pharmacy stores at HSA, and they have sort of a strict protocol in terms of ensuring quality assurance, but also the distributors that they work in collaboration with, they also have strict guidelines on quality assurance. And there have been a few companies that I have worked with in the past which did not pass the list here at HSA. And so we had to find other places which passed that quality assurance. And the second question, I believe, was, could you repeat that for me? There was a second question at the end.
There are three questions. The first one was, how is it regulated on Cayman Island, alternative medicine? Secondly, the quality assurance in terms of your source of your herbal medicine. And thirdly, do you have a formulary where all the prescribable herbal medicine are summarized with their side effects and possible interactions with conventional medicine? Because obviously when you prescribe something which is not familiar to majority of health practitioners, we also want to know that obviously there's no interaction, there's something that you can refer us to as a reference.
Yeah. So we have started on a formulary and we are continuously working on it, but we do have databases which we check herb-drug interactions always to ensure that we are being as safe as possible. And in terms of the regulation, we do have the CPAM, complementary, the CPAM, which oversees for us.
One more question this side.
So with the process that you were talking about in the beginning about, the ability to just make an appointment and come and see you in some cases, if my situation is I need to get a referral from a GP and then come see you through the Cynico process, and you recommend things like massage therapy, all that sort of stuff, what has your experience been with Cynico's openness to covering that, or even the GP's openness to covering that? Or is that something I should expect to pay myself?
Right, so currently we are in discussion with the insurance companies to have our services covered. Our staff and dependents are covered by the hospital, but unfortunately we haven't secured that coverage from Cynico and certain other insurance companies. But in terms of GPs referring, I have seen a number of GPs and other specialists as well referring, so it's been a positive feedback.
Okay, but for now I should expect
To pay out of pocket, yeah.
So then, even though I'm a Cynico patient, I could technically call your office and say, I'd like an appointment, and just pay?
Yes, definitely. Anyone can come and, have the service, and they would pay out of pocket for now.
Hi, good morning. I was just wondering, what is the average length of, let's say, your initial consultation with a patient? No doubt, by the time someone comes to see you, they've exhausted their general practitioner, they've gone to several other doctors for second, third, fourth, fifth opinions, they've had endless investigations, and they're probably at the end of their tether and seeking some relief from complementary and alternative medicine. How long does that take?
So I like to schedule my initial consultations for an hour and follow-ups for half an hour. Follow-ups, we schedule it for half an hour, but usually it's much quicker than that. The initial consultation is an hour. We do take more time to go into more detail, for example, than the GPs can allow. And perhaps that's just the system.
A question from online, Dr. Irka, is, can the use of N-acetylcysteine be used for the reduction of mucus and inflammation in the case of nasal congestion issues?
I am not too sure about the answer for that question, but in my practice, we tend to work more with the whole herbs. So we try not to look at it in such a reductionist way. Yes, of course, we know that the plants have various constituents that help with certain aspects. For example, gut soothing, we need plants that have lots of mucilage, for example. But in terms of that particular substance, I'm not 100% sure, but I could get the answer for the person.
This is primarily a comment. About 25 years ago, the National Institutes of Health started a CAM branch and funded it with almost $200 million. And out of that has emerged a large body of literature that supports much of what you're doing. One of the things that we have to remember is many of these spices and so forth have antioxidants, and extracts of antioxidants are actually less effective than the natural compound. Many of them have other properties, of course, and the last thing is that the vast majority of all allopathic medicines are actually made from the original compound that was identified as having the activity. So, good work. Thank you.
Thank you for that comment. That definitely, I'm so happy that you mentioned that, because that's what we see oftentimes is the whole plant or the whole substance is better. And sometimes we don't know the full scope of what's in that, and you have synergistic elements that help. And in Orthodox medicine, we tend to break things down so much so that you may remove certain compounds that may have helped, you know, or to balance as well. So thank you so much for that comment.
One more question over here.
Good morning, Dr. Ebanks, and thanks for that lovely presentation. Very enlightening.
Thank you.
I wanted to ask whether, so far in your practice, you've seen persons with non-communicable diseases coming in to see you, or more. I wanted to have an idea of more of what you're seeing at the moment, if that's okay to disclose.
Yep, absolutely. So we have seen patients who have diabetes, hypertension. We've seen 2 cases of TMJ syndrome. We've seen patients who have just the regular sort of low moods, low energy, digestive health issues. We've seen patients who just want to come in because they want to try the alternative medicine, and there's nothing really wrong, but they want to just try it. So we have patients from across the board. We've seen patients with UTIs, we've seen patients with orthopedic problems, joint pains, and we have seen a few cases now that have just been really positive, and only, I would say, 2 where perhaps we've needed to adjust their formula, because, you know, it's not anything significant, but they remembered, oh, I'm allergic to Solanaceae family, for example, like eggplant and whatnot. And we've had to adjust based on that. But we've had lots of positive reviews, so I'm very pleased about that.
So everything is prepared on site, nothing is pre-prepared?
Yeah, so
Everything is prepared in accordance.
in terms of the remedies. So the remedies, we order in bulk through the pharmacy stores at HSA, and then our pharmacist, Rosemary Bailey, she mixes the tinctures or, you know, teas based on my recommendation, and then the patient comes and collects.
Are there any other questions for Dr. Irka? If not, thanks again, Dr. Irka. That ends our Q&A session for you.
Healthcare is changing now more than ever. But one thing that will never change is the personal care you can expect from us at the Health Services Authority. Whether you've been in an accident and need emergency care, or you have a chronic health condition, you want advice on your medications, or you want to transform your diet to live a healthier life, our staff is committed to providing you with the comprehensive, compassionate, expert care you deserve, because your health matters to us.
Our thanks again to Dr. Irka Ebanks. There are many paths to improved health, and it varies by individual, but I'm so happy that the HSA is offering a new path to its patients. I just wanted to acknowledge our sponsors this morning, without whom we would not be able to make the conference a reality. So we want to acknowledge Health City Cayman Islands, Doctors Hospital, Integra Healthcare, Astor Cayman Med City, Kelly Holdings Events and Communications, DART, Compass Media, and the Cayman Islands Health Services Authority. So we've ended this segment just a couple minutes ahead, so we will now take our short coffee break and reconvene at about 10:45. So we'll have a little bit of an extended break there. We want to thank Cineco again for sponsoring this morning's Caffeine Fix, and we'll be back with you at 10:45. Welcome back. Thank you again to our sponsor, Cineco, for the coffee break, and also to acknowledge our other sponsors of the conference again. So Health City Cayman Islands, Doctors Hospital, Kelly Holding Events and Communications, Astor Cayman Med City, Integra Healthcare, DART, Compass Media, and the Cayman Islands Health Services. Thank you to all of our awesome sponsors. Our next presentation will be given by Dr. Sanjay Awasthi, who's an oncologist at Doctors Hospital. Dr. Awasthi will be talking about advancements in lung cancer treatment and diagnosis. The technological innovations to treat cancer have evolved significantly, and nowadays a cancer diagnosis does not have to be a death sentence, thankfully. Please welcome Dr. Awasthi.
I get to take my mask off. I'd like to thank the organizers for the honor of inviting me. I feel privileged and will be talking today about lung cancer. I've focused the talk much more on prevention and less on the actual technology of treatment. Oncology is a field where we treat up to over 100 different cancers, and even one of them, like sarcoma, may have 100 different types. So the protocols and the guidelines are so complex that I would like to aim this talk primarily at the lay public and the practitioners who see cancer patients. So I'd like to start off first by introducing myself. I'm new to the Cayman. I've learned how to say it, I think, properly. I've been here for a few months. I've been practicing oncology for, as of this year, 30 years, primarily in academics, but also in private practice. I've had a hobby, I guess that's consumed most of my other time, which is to study why cancer occurs and how you can stop it with herbal products and antioxidants, but not the actual use of them, but to look at a chemical level as what they do. I was fortunate enough to have a father who was a botanical chemist, and my hometown has an institute called the Central Drug Research Institute. And in the basement of that institute, it is said there are books in old Sanskrit that really only the Germans could translate. So they had Germans in there. Of course, they knew Sanskrit also, and they translated these formulas from extraction of medications that resulted eventually in a lot of the allopathic medicines that we use in cancer and other treatments. So I'd like to get started. So I put this up here just to say that saying that smoking is the cause of lung cancer was actually recognized by a long time ago. This is Van Gogh's picture, and he recognized in 1886 that there were people actually dying from cancer. Now, the cigarette that he's smoking has been rolled. When you have just a relatively few cigarettes that you can roll in a day, you don't smoke as much. But when you produce millions of cigarettes an hour, it makes a big difference as to the amount that people can smoke in a day. One pack is 20 cigarettes, and people smoke 40 cigarettes a day, some of them, the ones that I get to know. And at the rate of about, let's say, 5 minutes per cigarette, you can calculate how many minutes of the day they're actually puffing. So the focus in the beginning is primarily to say that that prevention is 1 ounce of prevention is worth a pound of cure, or maybe even more than a pound. You don't want to come to me and be subjected to potentially toxic treatments. So my advice, strong advice, is not to smoke. On this slide, I'd like to point out a couple of things. One, that there has been an obfuscation in terms of the causes of lung cancer. The obfuscation had to do perhaps with the cigarette industry, but I think that it also was a hesitancy even on the side of the doctors to recognize that this is the cause. It wasn't until the 60s and eventually in the 70s that it was recognized. And this is to say that general practitioners see patients that still come and ask why they got the cancer after having a cigarette in their pocket. So the other thing I wanted to point out here is that there has been sort of vitriol on the side of physicians as well as to the fault of the tobacco industry. And certainly they are at fault, but I think that physicians themselves have to take some responsibility. I've put some references in here for the record and some quotations that we can go through. So one of the things people don't realize is that smoking predisposes most cancers. Almost all cancers are less likely in patients and persons who do not smoke. So this is a list, and I will not repeat it, but as you can see, this represents over 3/4 of all human malignancy. So, everyone expects a joke, so this is not really a joke, but, a gentleman is in the ambulance and is asked, have you quit smoking? Do you smoke? Yes. Do you want to quit? Yes. When did you quit? This morning. So this is something that I've heard many times. A patient comes in to see me with diagnosis of lung cancer, and I ask, when did you quit? And they will tell me yesterday. This is something that is not publicized enough, I think, although it is very well recognized now, that just living with the smoker increases your chance of developing lung cancer or heart disease by up to 30%. That is, that if your partner is smoking and the smoking is being done in the house, then perhaps that you should make them aware of this. The lung health study found that heavy smokers who received counseling from a doctor were much more likely to quit smoking. As a physician, I think I've been guilty of this as well. Seeing a patient and follow up for one type or another of cancer and even lung cancer and forgetting to ask, are you smoking now? And do you wish to quit? Do you, is there any way that I can help you in doing this? So for the general practitioners, I think that this is an important thing to say. And so how do you stop? Well, there are nicotine replacement products. There are many different types, gums, patches. I had a patient tell me once that, that patch didn't work. I rolled it up and it smelled awful when I smoked it. So you have to give them the proper instructions on how to do it, and recognize that the amount of nicotine that gets into the blood is sometimes sufficient to trigger things like arrhythmia, asthma, and it should not be recommended for pregnant women or teenagers. So there are pharmaceuticals that allow you to quit. The success rate is below ideal, near 1 out of 3 for short periods of time, and then eventually there is relapse. And unfortunately, even though they may be classified in the antidepressant category, that they can trigger suicidal thoughts as well as anxiety, which might well be because of nicotine withdrawal. So this is an important thing that people ask. So if I quit smoking today, when will my risk drop and by how much? Well, the first thing you tell them is your risk never goes to the same as a non-smoker. Well, if you live for 100 more years, perhaps it would, but it only approaches that. But within the first 5 years, the risk drops almost 40%. This is encouragement for people. The long-term effects of e-cigarettes are not fully known. This was addressed by Dr. Joshi in the morning. The problems primarily would have to do with the acute increase in nicotine in the body, which can actually be more addicting, and also the carriers that they use. Many of them are subject to turning into carcinogens when mixed with the inflammatory cells in the lung. It's easy to quit smoking. I quit 3 times already. Try again. Tomorrow I'll quit. Tomorrow I will exercise. Tomorrow I will, mistreat or stop mistreating my wife and children. But then you wake up and it's today again. It's better to start today. Since being in Cayman, one of the questions that I've been asked, and many of the statements that have been made to me, is there's so much cancer in Cayman. Since there's the registry is inadequate to capture the information regarding the majority of cancers that are diagnosed here, that no firm conclusions can be drawn. So you go back to the data from the US, and I hope it's large enough to see, but this study was done of cancer rates in the African and Caribbean African population that lives in Florida. And what they found is that the persons from the Caribbean in general, some of which would be Caymanian, had a lower rate of death from cancer, almost a third lower. This is a plug to the ministers, the governor and premier, to make a serious effort to have a comprehensive cancer registry based on ones in the UK and the United States, and indeed much of the rest of the world. This is a busy slide, and I drew 2 lines on it. This is a frequency of cancer sorted in 2 different ways. I know you can't see it, and I apologize for that, but I'll try to point out that if you sort the cancers by the ratio that occur in men versus women, that lung cancer is only 1.1-fold more likely in men than women. But if you sort by the ones that occur in men and women overall, then the lung cancer becomes one of the top cancers as compared to relatively far down, depending on how you look at it. So lung cancer is a big problem, a bigger problem for men, particularly because men tend not to survive as long. Perhaps it is because they have lived a harder life or exposed to things that their wives have told them not to be exposed to and not listen because of stubbornness. Whichever it is genetic as well. We metabolize carcinogens. That is, near and dear to my 30 years of work in how glutathione metabolizes carcinogens. That there are very clear differences in how women and men metabolize carcinogens. And the funny thing is that most chemotherapy drugs resemble carcinogens in chemical structure and in what they do. Carcinogen exposure is over years and decades, and you get cancer. Chemotherapy exposure takes all of that and makes it into 5 minutes. However, if you give 2 milligrams, you cure. If you give 4 milligrams, you kill. So it's the reason why oncologists have a responsibility to treat, to be very, very specific about who they treat and what setting that they treat. And so some of the rest of the talk will be regarding how cancer is differentiated, particularly lung cancer, and how the treatments are different. That everyone shouldn't expect to be getting surgery, everyone shouldn't be expecting to get chemotherapy or immunotherapy and other treatments. And so these are the cancer statistics, again, from the United States, because the data is not as directly available for Cayman, although there is a registry. The number of patients is relatively small. But here I wanted to point out that these survival curves, I did the wrong one. These survival curves actually since 1991, which sort of by a fortunate circumstance coincides with the year that I started as an oncologist, that they've been consistently decreasing for lung cancer and colon cancer, which are the number one top causes of cancer. The other thing I want to point out in here is in females, the uptake of stopping smoking was delayed. Rather than starting in the 1960s with dropping smoking rates, they waited a while because it was just too cool to smoke, and their curves have declined more slowly. But regardless, we all talk about, well, one day we'll cure cancer. This shows that we are curing those cancers, not just because we're preventing them, but actually the treatments that we have now are significantly better. So these are abnormal CAT scans. If you can't see them clearly, then I'll just point out that these white areas here should not be here. The lung normally looks black colored like this, and there's a heart in the middle. Very bad, not quite as bad, almost as bad, better, and just barely abnormal. And the same here, different levels of badness. And the point here is that on the top, those are COVID lungs, okay? On the bottom, those are lung cancer patients, okay? Everyone knows that lung cancer patients are very likely, if they have, if they have this extensive stage of disease or this extensive stage of disease that's actually present in both lungs, that they're not going to survive, okay? People, this is similar to cases that I've seen in asymptomatic COVID, that they never knew. And patients that are asymptomatic are really not asymptomatic. They've coughed a little bit, they've had a low-grade fever, taken Tylenol, taken cough syrup, but they're not truly asymptomatic. And when they come, I end up having to get biopsies done on this and send these patients to pulmonologists like Dr. Joshi who do bronchoscopy and find out that it's necrotic tissue. So this is my plug for COVID and for the vaccination, which I'll come back to in a little bit. So here I'm going to talk more about not all lung cancer is lung cancer. There are two major types. One is non-small cell, and the other is small cell. You have to remember that a cancer cell in volume can be as much as 100 times larger than a normal cell. So even the small cell is much, much larger than, let's say, a normal red blood cell or a lymphocyte that we see, based on small increases in the radius and to the third power increases in the volume. And the non-small cell and small cell designation came about a long time ago, histologically, but it has held up in the sense of what the prognosis was predicted by pathologists when it was first described. So there used to be, very clearly, we used to say that there was squamous cell carcinoma, adenocarcinoma, and large cell carcinoma, and they represented roughly equal amounts and approximately 3/4 of all of the cancers. As the pathologists have gotten smarter, they have begun to classify those cancers that were large cell more into the adenocarcinoma, which is why adenocarcinoma is increasing in the total proportion of patients. There's an interesting thing about adenocarcinoma is that smokers also get, or non-smokers also get lung cancer. That tends to be adenocarcinoma. It is more likely in women. It is more likely in the Far East. It can be considered, as I had mentioned in the first slide, an act of God. These are single mutations that occur that are called drivers, and one gene with one abnormal alphabet letter out of 10,000 is sufficient to cause the cancer. And when this was identified not that long ago, within the last 2 decades, that it revolutionized the treatment of lung cancer, particularly non-small cell, and mostly adenocarcinomas. Squamous carcinomas, squamous is a term that we used for skin, or the cells of the skin, and these have different shaped cells. Adeno means gland, therefore under the microscope you can see that there are glandular structures that you're looking at, and there are clear differences in the way they respond to treatment. Present day treatments include oral medications, which have taken over almost 1/3 of all of the lung cancer treatments, or perhaps more. And they are more useful in the adenocarcinomas because they're more likely to be driven by drivers. Of course, they both have these genetic mutations, and what happens through your life is that these mutations, they accumulate in your DNA. These mutations accumulate at random spots, and since less than or approximately 10% of your entire length of DNA actually encodes genes, all of the other spaces can be mutated and have no effect. So that you can have as few as 7 or 8 mutations that are present, that are found in today's technology in looking at lung cancers. The importance of that is that we get confused about what the driver is then, because once these multiple mutations are present, and there are targeting medications now for every one of those, or a good number of those drivers, almost half of all of the adenocarcinomas have some driver of that nature. But some have more than one, so it makes it difficult to predict which medicine you should be taking. Squamous cancer, on the other hand, unlike the adenocarcinomas, they have problem with stability of their chromosome. They tend to get pieces of the chromosome that are amplified or deleted more often than just mutated. One of the differences is a protein called P53. One of the names of P53 given on the front page of a Nature article a long time ago was it is the guardian of the genome. Guardian of the genome basically means that when a cancer cell is mutated, P53 is activated and keeps those cells from dividing until the DNA repair is done. Unfortunately, as the mutations accumulate, there are these hotspots in the P53 gene that frequently develop mutations that keep it from doing that function, stopping the cell division before the repair of the DNA occurs, and therefore every replication of a cell that is on its way to becoming a cancer causes accumulation of these mutations. So what I have studied over, and thousands of other researchers have studied over, is what causes those mutations and which ones are responsible for cancer and how many mutations, but more importantly, what prevents those mutations. So everyone here probably, or I doubt that anyone has not heard of antioxidants. So we divide those into two. We divide them into the chemical and the biological. Okay, chemical antioxidants are the ones that are present in plants and a variety of things, including calcium chelating agents, are antioxidants. Why? Because a good antioxidant actually prevents butter from becoming rancid. And if it takes 1 milligram of antioxidant to keep a bar of butter from getting rancid, it's not as good as an antioxidant as if it takes only 0.01 milligram of that antioxidant to do so. And that rancidity is actually the underlying cause of aging, and also the underlying causes of the chemicals that mutate DNA, that originate in your cells, and they originate from these fats that we call essential fatty acids. The other names of these are omega-3 and omega-6 and other omega fatty acids, and they actually generate these carcinogens. When you study what metabolizes those carcinogens, you find that there are groups of enzymes that basically take these carcinogens, they hook them up to glutathione. Many people may know, people use it as infusional therapies for everything from arthritis to cancer. Unfortunately, sometimes glutathione is misunderstood. It is misunderstood because people misunderstand antioxidants. An antioxidant is the same thing as an oxidant. The only thing that is different is the concentration. Something that will prevent rancidity at a very low concentration will, at higher concentration, actually promote it. Therefore, I wrote this in a book about maybe 25 years ago, and I was one of the first few that recognized work of Dr. B.N. Ames at the National Cancer Institute, who and other chemists had basically worked out what antioxidants are and how aging occurs and how cancer occurs from aging. So antioxidants, basically, because they're also oxidants, it is a matter of how much. So when you're taking, and I mentioned this comment earlier, when you're taking things that have antioxidants in them, first, be careful what's in there. Second, be careful how much of it is in there, because you may actually be promoting your lung cancer rather than stopping it, so that they cause these mutations that cause adenocarcinomas and more commonly DNA breaks in long segments of DNA that are present more commonly in the squamous carcinoma. And cigarette smoking occurs, 90% of all smokers, 90% of all squamous cell cancer patients are smokers. Less for the adenocarcinomas because, as I mentioned, there are people who do not have a smoking history. Now, many of them also have exposure to secondhand smoke, but regardless, many of them have mutations that they acquired probably through no fault of their own. The squamous cancers and these non-small cell adenocarcinomas have a high frequency of mutations of the guardian of the genome. In the last cancer that I mentioned here, small cell lung cancer, 95% of it, of these cancers are mutated in P53. P53, in addition to being called a guardian of the genome, is actually a tumor suppressor. If it works, it prevents cancer. If it doesn't work, it doesn't. And the importance in humans, this is not just in a mouse or rat. There is a syndrome called Lee-Fraumeni syndrome, discovered by Dr. Lee and Dr. Fraumeni, who basically found these families that had high incidence of a variety of cancers, and the number of cancers are a very long list, but leukemias in children, brain tumors, sarcomas, and increasingly recognized breast cancers, and basically all types of cancers, particularly things like endometrial carcinomas, uterine carcinomas, ovarian carcinomas. They have these mutations in the P53 gene that very often leads to cancers. The other gene that has been, and since it's mutated and missing, you basically have to genetically replace it, okay? Unlike the other type of mutations, they're called oncogenes. And oncogenes, when you mutate them, they become more active. So you can put an inhibitor, a drug in, and you can stop the growth of cancers. Those oncogenes are the ones that have the driver mutations. You can make medications. P53, you can't make a medication, at least not one so far, that is available to patients that can actually reactivate the function of the P53, and that may come in the future. So P53 makes lung cancers very difficult to treat, and because the cancer cells keep changing. We give them chemotherapy, and as I told you, chemotherapy are mutagens, they're carcinogens. Therefore, they change the cancer cell to become resistant eventually to treatment. And if they don't have P53, they can't repair properly. The other gene that is the big elephant in the room is called RAS. And RAS is a gene that is responsible for the vast majority of cancer signaling that is abnormal in these cancers. The reason I mention that is because for years people thought that this gene was undruggable. This protein, you cannot make a drug against it. And recently, in the last couple of years, that has been demonstrated to be not true, and there are now there is at least one medication that is quite effective in in actually inhibiting this RAS protein that can treat these cancers. So the difference, the major difference, the reason that they're divided into this is that in the past that this one was considered sensitive to chemotherapy. Chemotherapy with drugs that contain platinum salts. That's exactly what it is, platinum dissolved into liquid and given as an IV. And other medications that can put, 80 to 90% of these patients who have small amounts of cancer into remission. Unfortunately, about 80% of those get reoccurrences, so that somewhere between 1 in 10 and 1 of 20 people with this kind of lung cancer are actually curable. And with the combination of chemotherapy and radiation, and this is a very long-known phenomenon. Non-small cell was traditionally not responsive to chemotherapy, and it wasn't until the early and mid-90s that it became apparent that you can take extracts of the Pacific yew tree, from which a drug called Taxol originates. And you can take a altered platinum called carboplatin, and you can actually get responses to chemotherapy, and even in these cancers. But unfortunately, a mouse is about this big, okay? It weighs, a couple of ounces. Their tumors are about this big, okay, very small. You can cure and treat a mouse easily. I've cured and treated thousands of them, okay, in the laboratory. Unfortunately, humans are this big and much bigger than me also. And their cancers are huge, okay? The scans that I showed you indicate the size. Therefore, these cancers develop resistance, and the non-small cell lung cancers develop resistance faster. Therefore, the response rate there is about 1 in 3 with chemotherapy, and the response doesn't last long. So now I'm just going to show some pictures for the rest of the talk and make some points. So this is an adenocarcinoma. Notice that it occurs at the edges of the lung. They can occur they can be something called scar carcinomas in people who have had tuberculosis, or if they have had cavities in the lung caused by prior fungal or other infections. And we'll find in the future that COVID lungs are going to do some of the same thing, is that these adenocarcinomas can develop inside of those cavities over a period of time. Here's another example, and here I wanted to point out that the opposite side of the lung also has cancers that spread through the airways and through the blood into the opposite side of the lung. This cancer is curable, okay? If you catch it, you can cut it out, and you may not even need any other treatment afterwards. This cancer can only be treated with medications. And occasionally you get lucky enough that you can shrink this cancer and a little bit is left and you can remove it. Squamous cell cancer typically itself develops these cavities, okay, and can be mistaken for cavities that are caused by tuberculosis or fungal infections. The only way of making a diagnosis, therefore, are biopsies, like for adenocarcinomas, and Dr. Joshi is very good at that in bronchoscopy. This is a small cell lung cancer, and this whole thing represents about 2 to 3 pounds of cancer in here, okay? It is blocking the airway of the lung, and I've cured some of these patients, okay, with chemotherapy. because it is so chemotherapy sensitive. And after it gets better and essentially goes away, this is an example, you're left with, many years later, just a scar, but these people don't have the cancer. So small cell is quite different. The other thing that I want to remind the practitioners of, unfortunately in Cayman, there are a lot of delays often in getting to Miami or Houston for treatments with radiation, getting biopsies, getting insurance approval. That small cell lung cancer can double in size in less than a month. Okay. So when you diagnose it, you need to have them on chemotherapy, ideally, within 2 days, 3 days, a week. And PET scanning should be done quickly. Bronchoscopy and diagnosis should be done very quickly to keep these people from dying, because once it gets into the liver and other places, the chances of cure are less than probably 1%. Perhaps that's changed with immunotherapy recently. So there's another type of cancer that we don't talk about much. It's more rare, but it occurs in patients who are exposed to asbestos. Okay, they have a particular pattern of thickening of the outside of the lung and fibrosis or scarring inside of the lung. This is a particularly difficult cancer to treat. And interestingly, when this was demonstrated as asbestos being the cause of it, the industries that exposed people to asbestos had to cough up billions of dollars that are still sitting in accounts for patients who can prove that they have mesothelioma. This is also responsive to chemotherapies, and some of the chemotherapies that are now used in adenocarcinomas were initially found to be effective in this cancer. So lung cancer spreads. The longer you wait, the more likely it is that it will show up in the brain. Cancers in the brain in general are a very poor prognostic indicator. They're by definition the fourth stage, and the fourth stage of lung cancer has a very low 5-year survival rate. The numbers that we cite, unfortunately, are older numbers, so they don't take into account the effects of the current treatments, but these numbers can be in the 5 to 10% range, depending on survival. And over my lifespan as an oncologist, I calculated I've seen about 60,000 clinic visits of patients. And since about 1/5 of them were lung cancers, and a typical lung cancer patient has about 10 visits. Up to 2,000 patients I've seen, and almost to the point where I can recognize what they have. But in the past, when we saw this, there was an old phrase, it was called the fifth in the fishing pole. And they buy 1/5 of something and a fishing pole and spend the rest of their time being as happy as they can. Now you can remove, if there's a single one, you can remove it, and 5 years later it will not come back. Okay, it requires radiation afterwards, and now we have the powerful tool of immunotherapy to make sure that the radiation works better and keeps these people alive longer. Liver. These cancers, like the liver, about 1 in 3 patients, if they live long enough, will, depending on the type, can develop cancers in the brain. The liver is a little bit less, approximately the same frequency, but here, again, I want to show that we can treat this, even though this is 4th stage cancer, that with treatments, this is a case of immunotherapy, that the cancer is gone. And the other reason I wanted to put this image up here is this is a PET scan, okay? The PET scan can show small cancers that you would miss by chemotherapy. Interestingly, you know what this brightness is? That's sugar. Okay, these cancers are eating, these little tumors are eating sugar at a very much faster rate than normal. So we just take some sugar, radiate it, make it radioactive for a few minutes, and we inject it, and it localizes in these cancers, and we can see. We can scan the entire body at a time and be able to avoid so many different tests that we had to do in the past to have a diagnosis this good. And fortunately, we do have this technology on the island. And at least we can know a patient can be sent to Health City for resection of a lung cancer versus start chemotherapy. This is the kind of the focus of my soapbox, really, is that when you detect cancers at a late stage, you get the treatments, like I said, surgery, radiation, chemotherapy. Unfortunately, now the technology shows that, sorry about that. Technology shows that you can do these, sorry about that. So technology in CAT scans has gotten good enough. I can't keep up with it, even this one. Okay, but technology in CAT scans has gotten good enough that there are these low dose, high resolution CAT scanners that can scan the entire body within minutes. And they will detect lesions down to 2 millimeters in size. And that's the size at which the cure rate might be as high as 95% by just removal of the tumor. Unfortunately, it has some downsides. That is, that if the lesion is less than 6 millimeters in size, they're difficult to biopsy to know that they're actually cancer. There are many other things that, that can give these nodules in the lung. As we get older, we've had pneumonias and other lung problems, and we may end up biopsying a lot of patients that, you know, putting them through the risk of getting these procedures if we do this. So entire recommendations, guidelines have been made according to how large the tumor is, who actually is eligible for this screening, so that we don't end up with harming the patient. And with those guidelines being followed, what this chart shows is that at 6 years later, in those people that had this high resolution, low dose, and even not that high resolution at that time, low dose CAT scan, that there was a substantial reduction of people that were that had cancer, that did not have cancer and survived with a low dose scan versus a chest X-ray. This is, I think, quite good evidence, and it has been corroborated by at least one other study. And the interesting thing here is when you look at the numbers, 0.75 means a 25% reduction. If you look here, 0.39 means a 61% reduction. And therefore, if a patient meets the guidelines for having smoked long enough, so I'll give an example first before I get to that. These are some of the small lesions that you can find with CAT scans. Unfortunately, you find these ones also. These are too small to biopsy easily, although now there are technologies, one called endoscopic ultrasound, that with biopsy through bronchoscopy, that you can biopsy things perhaps as small as 3 millimeters in size reasonably safely. This is what a CAT scan guided biopsy looks like. This is a needle, and there's a tumor, and you're lying in a CAT scan, and the needle is inserted into the tumor. It has a hollow core, and it gives you a small amount of tissue for diagnosis. So who should have lung cancer screening? If you have a 20-pack year smoking history, you're eligible. If you have smoked up until the last 15 years, if you're 50 or 60 years old, you have to have all of these, that you are eligible for these screenings. Unfortunately, there is debate regarding the CDC and other authorities that give a more complicated and different criteria. But the CDC criteria I showed first is probably a better one. It does give you higher rates of these false positive tumors. So will this technology be used forever now? Unlikely. That is that already we're able to detect the presence of cancer in the body by doing something similar to the RT-PCR test, a little bit more advanced, in which you basically sequence all of the DNA that's in the blood and figure out whether there are mutations or other characteristics that indicate the presence of cancer. This study was, a lot was made of this study, a 36% reduction in late-stage lung cancer compared to standard clinical practice. And this was done in the UK by the NHS. Unfortunately, the difference in how long these people survived was not significant. So how can that be? Okay, that you caught it early, okay. Perhaps that I can conjecture that medical oncologists and surgical oncologists have gotten good enough that even if we waited for a while to get that cancer, that we are able to successfully treat it. Then there's early diagnosis of lung cancer by other types of blood tests. The previous one was with antibodies. This one is with DNA fragments that you can sequence. These are called liquid biopsies. These are called liquid biopsies, essentially taking a blood sample and determining whether you have cancer. This is a recent article in 2018. In 2021, there have been additional advances, and prediction is that within 5 years, we'll be able to apply this technology widely for not just lung, but other cancers. Presently, we use something like it to actually check for mutations in patients' blood who are undergoing treatment, who we know that they have a mutation, to either to find what type of mutation it is, if there's another additional mutations that can guide drug treatment. So this is sort of a schematic of bronchoscopy, and there's Dr. Joshi there sticking this tube down in your lungs under guidance, and this is an ultrasound probe, okay, that can actually show you where the tumor is and which direction to put the needle in to get the biopsy. But surgical treatment of early stage lung cancer. Early stage lung cancer requires that your lung functions be good enough, because often you have to take an entire lobe of the lung, which can cause up to 20% or more loss of your lung capacity. The positron emission tomography, PET scanning, causes us to quickly evaluate the stage of the disease. MRI of the brain is necessary. And if there's no evidence of spread, you do surgery, and if you find no lymph node involvement in the middle part of the lung, where the root of the lung is, then you may not need any other treatment. If you do have involvement of those lymph nodes, then additional radiation therapy may improve your odds by as much as 30%. So this is an example of PET scan detecting different stages of lymph node. Early stage, just the cancer, no lymph node. Cancer in the hilum or in the middle part of the chest. Cancer that has spread into the middle of what we call the mediastinum, but on the same side of the tumor. And then, unfortunately, cancer that has spread into here, which is considered had to have prognosis equivalent or near that of metastatic disease. Nowadays, instead of opening up the chest or making large incisions, you can actually use this video-assisted thoracoscopic resection called VATS to remove small tumors. And this is a big advantage because if you can detect the cancer of 0.7 centimeters this size and get either a radiologist or pulmonologist to make a biopsy diagnosis, you can actually have 3 little surgical scars and the cancer can go. There's still debate as to whether that is as good as removing the entire lobe of the lung, but this is an alternative to patients who cannot tolerate bigger surgery. Unfortunately, this shows that the majority of patients have extensive late disease. They don't have early stage disease, and therefore their survival is in the range of 6 to 10%, whereas in the 5 years, this gives you a pretty accurate estimation that if you have early stage lung cancer, you have at least a 50% chance of surviving. If you don't take any treatment, the survival rate for less than a year is even worse than that. The stage 3 lung cancer, or 3A, early stage 3 lung cancer, is treated with a combination of, and this is where the complexity of oncology comes in, that we can treat them with chemotherapy, we can treat them with chemo and radiation therapy. Nowadays, we can treat them with immunotherapy, perioperative immunotherapy with radiation, preoperative or immunotherapy, all of the different combinations. And sometimes we can make surgery possible. In the late stages, 3B, that's pretty much all we can do, and most of the time we can't do surgery. There have been major advances in the combination of immunotherapy with chemotherapy and studies ongoing with the combination of all three that seem to give responses of the tumor even before surgery well above 60%. This slide is impossible to see, and I put it that way because in stage 4 lung cancer is where the oncologist is of key importance, because without treatment, you have the same natural history as you did 40 years ago, which is when the doctors told you you have 6 months to live. Now, those stage 4 patients are relatively routinely living to 3, 4, 5 years, long enough to watch their granddaughter graduate from college and high school. And those are, and this is a picture, the last picture I'm going to show about lung cancer, in which what it shows is that this technology, the next-gen sequencing, the RT, this is well beyond RT-PCR, where you can actually sequence the entire genome nowadays in less than a few hours. It'll take you a couple of days to analyze the results, but regardless, you can identify that up to half of the patients with cancer or adenocarcinomas have a driver mutation. And these are some of the medicines. I didn't list all of them. I forgot to include crizotinib. But these are medications that are directed at these mutations that occur within the epidermal growth factor receptor. And that is the, treatment-wise, that's the most important gene in lung cancer. Then, of course, you have the NIBs. All of these are NIBs, and then you have the MABs. And these monoclonal antibodies they target the blood vessels, they target the immune system, they target different type of proteins that are on the surface of the cell, whereas the drug actually goes inside the cell. And a Nobel Prize has been awarded 2 years ago to Dr. Allison at MD Anderson, who figured out that when tumor cells are growing, they express on their surface certain proteins that block the immune system. And if you put antibodies against this is, many people will see the ads for Keytruda or pembrolizumab, and this is ipilimumab or the Yervoy. And the combinations of these now are approved for almost all cancers, with the exception of breast, unfortunately. We're working on that. So the take-home messages here are that prevention is key. Early detection is the key to the cure. There are major advances in the past 2 decades that have radically changed cancer treatment. Hiding your head in the sand is likely to get it severed. A little knowledge is a dangerous thing. It's harder to read now. An opinion is worth what you pay for it. Okay, that doesn't necessarily mean what you pay to the medical oncologist. It means the time that you spend from your work, okay, to actually find out what's most important. And I'm going to get on my soapbox for 1 minute here. The same technologies that I've described to you have led to a vaccine that is revolutionary. It may eventually cure the common cold. No one has been able to make a vaccine for the variety of viruses that COVID represents, which people thought were just common cold viruses, and I've shown you what they do. This is me. There's a scar, 2 of them. Okay, because my parents at the age of 1 year old let me get this vaccine, I don't have to see this smallpox in my child. There is such a difference between selfishness and sacrifice. And anyone that does not take the vaccine just because they're going to get a small cold or a flu for a few days, I think it falls onto the left side, and then the last one. And this, I want to leave you with this, okay? That is that this is a physician, Edward Jenner, okay? And the tale goes that he noticed that the milkmaids were prettier. They didn't have the smallpox scars on their face. And why? Because cows had pox. So he took pus from the cow pox, heated it up, inactivated it, injected it into patients, and presented this to the King of England. This is now over 300 years ago, okay, or 200 years ago. And it says, utmost importance to the future welfare of the human race. Medical professions have now confirmed this truth, okay? So this is my plug for the COVID vaccine, and I'm sorry my time is up, but do I have any time for a question? I can take 1 question. Okay, but I've befuddled everyone enough, so maybe that there aren't questions, but going once? Okay, thank you sincerely for your attention. Here I wanted to plug myself, and that is that these are the titles that I've held in the past 30 years. And thank you.
We want to thank Dr. Awasthi for that very informative presentation, and we'll be back in just about a minute with the setup of our next section. So just 1 minute and we'll be back. Straight to Mr. Richard McAree. He'll do the intro. So no.
He'll do the intro to the panel.
Yes.
Okay.
He'll do it.
Hello, everyone. My name is Ben Mead. I'm the Marketing and Communications Manager at Health City Cayman Islands. It's indeed a pleasure to be here with you today. I know we've had a full morning already with some very informative and helpful presentations. I look forward to hosting the remainder of the day's program and giving Nellie a breather. She's done a good job so far for the day, though she won't get too much of a break because she's going to be part of the next presentation. So we move on now with another key topic. But before I do that, I'll let you know that lunch is being served next door. For those of you in the room, it's buffet style, so you could always grab some and come back in. So let's move on to the next topic within our Breathe Easier theme. One that is very relevant to all of us here in the Cayman Islands. This next panel provides more information on the public-private partnership for the planned ReGen Energy from Waste facility. We will have in this session Nellie Pouchie, who's been with us, the Chief Officer in the Ministry of Health and Wellness, presentations as well from Thomas Ferrara and Rosalind Flavell, international consultants on the ReGen project, and then we'll open up for some questions. We'll also have Hannah Reid from DART moderating a Q&A session with the full panel, including Antoinette Johnson, the lab manager from the Department of Environmental Health, and Richard McAree, the Environmental Social Governance Program Manager at DART. So we will have the next session, Clear the Air, ReGen's impacts on air quality and human health.
Welcome, everybody. Thank you for joining us either in the room or virtually at the Cayman Islands Healthcare Conference. Under this year's theme of Breathe Easier, the conference speakers so far have explored mental health, respiratory medicine, climate resiliency, alternative medicine, and best practice for adopting a new normal that includes global challenges like COVID-19 pandemic and climate change. Addressing these challenges will require innovative, holistic and sustainable solutions that benefits our natural environment and our communities. One such project is ReGen, the country's planned energy recovery and recycling infrastructure that will transform the way the Cayman Islands handles its waste and significantly reduces greenhouse gases emissions, all while protecting environmental and human health. Constructed and operated to the highest global emission standards, ReGen represents an exciting opportunity to really modernize Cayman's waste management system. The ReGen Energy Recovery Facility will divert approximately 9 megawatts of electricity from fossil fuel sources, using household trash to power over 2,000 homes and businesses in Grand Cayman. The project also includes remediation of the existing landfill, which will reduce greenhouse gas emissions by more than 23,000 tons per year, equivalent to removing 5,000 cars from our roads every year, which is significant. And new facilities for processing green waste, scrap metals, household goods, and construction and demolition waste will allow things to be recycled and allow an education program to push us up the waste hierarchy. Since the project contract was signed in March of this year, the public-private partnership team has been working diligently to progress remediation of the Georgetown landfill and the environmental impact assessment and financial close for the project. Today, I'm delighted to share that following the public consultation held earlier this year, the terms of reference for the ReGen infrastructure EIA has been finalized. This is a very important milestone in the AI process, and the terms of reference will really act as a roadmap for the baseline environmental assessment studies on air quality, emissions, hydrology, noise and vibration, marine ecology, and terrestrial ecology, all important environmental aspects for the project on the island. Once complete, these studies will then form an environmental statement which will go to the public consultation next year. In keeping with the conference theme, the focus of this session is air quality emissions and the impacts to human health of the proposed ReGen facilities. Please join me in welcoming Rosalind Flavell of Fichtner, who's based in the UK, and Tom Ferrara of GHD, based in North America, who join us remotely to go through more detail on the project and subsequently in the panel discussion. Thank you.
Thank you, Richard. Today I'm going to speak about the air quality impact assessment for the ReGen project. GHD is involved in many of the different media studies, but my specific qualifications make me talk about the air quality impacts. So the first thing I would like to do is sort of review an energy from waste facility, a typical one, just to familiarize everybody with what is going on. So the process here is, this is a process schematic, and the process is basically to receive the wastes from the residents, dump it into a holding facility in which it can then be added to a steam generating boiler as necessary. And one of the things about a dump facility like this is the waste is contained. It's not, none of this is done outside. The heat from burning this waste is then used to generate steam. The steam generates electricity, and the electricity is off for consumer use. The key parts to this system that interest me is the air pollution control equipment. So the first step that makes this system better than what is here now and other types of, certainly landfilling of waste, is any decay of the waste and any uncontrolled combustion that may occur from waste is non-existent and happens in a controlled environment. So the combustion is highly controlled. The emissions of metals, acid gases, particulate matter, and other combustion products are controlled, one, through the combustion process, and two, through air pollution control equipment. There are acid gas scrubbers, particulate filters, and carbon or some proprietary absorbent material for volatile metals like mercury. This plant is being designed to meet the European Union Industrial Emissions Directive, and so there are limits in terms of control on parameters such as dust, organic vapors, hydrogen chloride and hydrogen fluoride, which are the acid gases, also NOx, SO2, the full range of metals. Most of the metals are particulate metals, but some are volatile at these temperatures, and so those are also controlled and limited. And then dioxins. And this system will involve a continuous emission monitoring equipment so that the exhaust from the stack is monitored continuously. And part of that continuous monitoring is used to control the combustion process, but part of it is used to control the air pollution control equipment. And the other portion of that then lets you know that the system is operating as designed and properly. And there are alarms if there are any upset conditions that would require maintenance, or not so much maintenance, but repair or attention as the facility is operating. So the next piece of what I'd like to talk about is what is the process for this air quality impact assessment. So currently, the assessment basically looks at several there's several steps in the process. The first step in the process is to describe what are the conditions that exist right now at the areas impacted by this facility. The second thing is to assess those assess the impacts of the new facility, and then the third piece is to combine the emissions from the new facility with the existing baseline conditions and describe a cumulative effect of these of the pollutants that would be released, and then to compare those cumulative effects with any air quality objectives. And again, so what we are currently in the process of right now is collecting a laundry list of air pollutants, and I'll go into that in a little bit further. But right now, they're setting up some air quality monitoring stations so that we can define and describe what the existing conditions are on Grand Cayman at the moment. The other part to that baseline evaluation is to look at other sources, the existing power plants, existing industrial facilities, existing traffic conditions, to define and describe the air pollution sources that already exist on the island. The second portion of this impact assessment, is where we look at the design of the facility and look at the expected throughputs and the types of materials that will be accepted at this facility, and then the control equipment designs, and then we can estimate, and it's always conservatively estimate, what emissions may be coming out of this facility. And then those estimated emissions are run through an atmospheric dispersion model, where we model what those impacts would be from the facility, and then we add together the impacts from the proposed facility, the impacts from the existing facility, and then compare those results to any health-based standards to make sure that there are no issues. And then the sort of the feedback loop is, if there are issues or there are potential areas that might be of concern, then some additional look might be, or an additional look would be taken of the design to see if there's anything that can be affected to change that. So the first part of this is again the baseline conditions. So here is the section of the island where we are focusing our study at the moment. And you can see from this windrows, which is in the upper right-hand corner of this figure, the prevailing winds in this area make all the impacts, essentially, in the south, more south west of the source. And most of the industrial sources in this area, and even the main road source, impact these facilities in the southwest. All these facilities are going to be considered in our evaluation. There you go. Okay, so this slide shows it's the same windrows, but this one doesn't have the sources. This has the stations that we are currently installing right now to monitor and collect several months worth of data to use as our baseline. And we have the station number 1 is a continuous operating with continuous data for all the parameters listed here. And then some of the other locations are designed to pick up any local sources that might be, whether it be the traffic sources or the power plants or some of the industrial sources under different wind conditions. So this is the facilities that are being installed right now, and you may actually see them when you drive past them. The bottom line is at the end of this assessment, we will understand what the conditions are now, layer on top of those conditions the impacts from the facility, the ReGen facility, and the other existing facilities, and then compare what we predict the impacts will be to the limits that are set out. And right now we're using we are using the UK National Air Quality Objectives. And these are the compounds, and these are all health-based, all health-based limits. And, Rosalind is going to speak to the health aspects of these emissions. But this is what I have at this point. So I think we're going to hold questions to the end, I believe. And that's all I have.
So, Adam, I think it's my turn to share. Good. Hi, everybody. Strange one doing this over online things, but anyway, I can't see everybody, so if I lose you all, I've lost you. I'm sorry. My name's Rosalind. I'm an air quality consultant working at Fichtner Consulting Engineers. I'm a chartered environmentalist and a chartered scientist and a member of the Institute of Air Quality Management. I've been working in air quality for the last 15 years, and the last 10 years I've been working at Fichtner, where we have a very strong focus on energy from waste plants of varying sizes and technologies. So Tom has just provided a really good overview of what is being proposed for Cayman, a modern energy from waste plant. As explained, it will be designed not to have a significant effect on the local environment, and that will take into consideration the impact in line with guideline values from the UK on the potential impact on human health. The plant will need a permit to operate, so it's not a case that we can just build it and operate it. The regulatory authorities have to ensure that they are happy that it's not going to have a significant risk to human health based on its location and how it operates. So in the UK, we have a very similar system where a plant needs a permit to operate, and it can only be issued if the regulatory authority is satisfied it will not have a significant impact on the local environment, and that includes human health. And the plant will have to adhere to very strict control measures. As Tom said, it will need to comply with the Industrial Emissions Directive, which is the legislation which covers these kind of plants across Europe. So I'm now going to provide an overview into the research that has been carried out into the health effects of energy from waste plants. This has focused on research from the UK, specifically England, for a number of reasons. Firstly, health statistics are very well documented on a local scale, and this includes data on live and stillbirths, congenital abnormalities, mortality, and cancer incidences. And secondly, we have a very high number of plants that have been operating for a while, so we have a long-term data set to analyse to look at the trends in statistics. Now, Public Health England is an agency of the Department for Health and Social Care for the UK government. They are responsible, as it says here, for researching, collating and analysing data to better understand the public health challenges. They provide evidence-based scientific expertise and support many bodies, including the National Health Service and central government. As part of their work, they have been developing an understanding of the potential health effects of energy from waste. This has been both to satisfy their responsibilities, but also as a result of public concern due to the number of these projects coming forward in the UK especially. In 2009, they published a review, and their position statement concluded, it's stated here, but that modern, well-run and regulated incinerators are not a significant risk to human health. They did state that whilst it's not possible to rule out adverse health effects, any potential effect for those living nearby is likely to be very small if detectable. Now, this was based on detailed assessments of the effects of air pollution on health and the fact that modern and well-run waste incinerators make only a small contribution to local concentrations of air pollutants. This included research carried out by DEFRA, the Department for Environment, Food and Rural Affairs in the UK, in 2004, and the Committee on Carcinogen of Chemicals in Food, Consumer Products and the Environment, another big mouthful, And they both reviewed research carried out in the area on the long-term effects linked to the releases of carcinogens and particulate matter from energy from waste plants. Now, a key piece of research was carried out by the Small Area Health Statistics Unit. This includes researchers from Imperial College London and King's College London, so reputable university colleges. Initially, a very large study was carried out by the unit where they examined cancer incidence between the mid-1970s and the mid-1980s of about 14 million people living within 7.5 kilometres of 72 waste incinerators operating at the time in the UK. It's worth noting that these were operating before the European legislation was in place to control emissions, i.e. the Waste Incineration Directive, which has now been transposed into the Industrial Emissions Directive, which this plant would operate under. And after considering the research, the Committee on Carcinogens concluded that, it says here, but any potential risk of cancer is exceedingly low and probably not measurable. Now, as part of continual research in the topic, in 2008, the committee reviewed 7 further studies on cancer incidents near waste incinerators that were published since the original review that they did in 2000. These papers all studied the older generation of incinerators, so similar to the original work, those that were operating around the 1970s to 80s. And in many of these cases, the emission limits were already being exceeded because, well, they didn't have the emission limits that we have now. But they found that there's problems in interpreting most of the studies due to failures to control the socio-economic factors and the inclusions of other sources of emissions, not just those from the incinerators in question. And as such, the committee concluded that the studies were inconsistent with the results of the larger study carried out by the Small Area Health Statistics Unit, and there was no need to change its previous advice, but the situation should be kept under review, which is correct. And that is what's happened. So Public Health England have continued to facilitate research into the area. And in 2012, they commissioned the Small Area Statistics Unit, get it right, to carry out a study to extend the evidence base and provide further information to the public about any potential reproductive and infant health risks from municipal waste incinerators. These were published in 2018 and 19, so fairly recently. They had a slightly different choice of metric than the original studies, being looking at reproductive and infant health risks. But these were studied as they were considered to be more sensitive to the accumulation of pollutants in the environment than the other potential markers, such as the lifetime cancer risks that we looked at previously. These studies all considered plants operating in the UK under the Industrial Emissions Directive, so modern plants and the regulations that would be used for this plant. In the UK, many of the original plant studies have closed down as they could not achieve the requirements of the legislation. And currently there are 54 fully operational plants in the UK. So the first 2 studies showed no effect on birth outcomes that was linked to exposure to PM emissions and the proximity to the waste incinerators. The first one is Gosh et al. 2018, and then the second one is Ferrara et al. In 2019. There was a final paper that was released as that pack of 3 papers after the 2009 position statement. And this found no evidence of increased risk of congenital abnormalities from exposure, but a small potential increase in the risk of abnormalities for children born within 10 kilometres of a municipal waste incinerator. However, the paper did not demonstrate a causal effect, and it was acknowledged by the authors that the results may not be, may well be down to not fully adjusting the study for factors such as pollution or other source of pollution or deprivation. And as such, the Public Health England have decided they still stand by the 2009 statement, which is repeated here, that modern, well-run and regulated municipal waste incinerators are not a significant risk to human health. And that is me. I'd like to open it up to any questions. Stop sharing.
You can do it from there. Okay, if that makes it easier. Thank you, Tom, and thank you, Rosie, so much. I hope you can continue to hear us as we move into the moderated panel discussion. And I actually want to open up by following up on that, the number that you just gave about the 54 fully operational plants in the UK, and this can be for yourself, Rosie, or for you, Richard. You know, are these types of plants typically located close to human populations?
Yes, in the UK we've not got that much land around us, so a lot of these are actually developed in urban areas. So I can name them off. Cities of Sheffield have got one that's in close to the town centre. There's quite a few of them in London. So a lot of them are close to. It's close to the waste arisings. It prevents having to travel long distances with waste.
Yeah, that's absolutely right, and I wouldn't say it's just the UK. Globally, the greatest benefit is to have these facilities located in urban areas, and that, in addition to the availability of the waste, it's then power distribution, transmission requirements, cost, the carbon aspect of actually having the waste not to have to travel long distance for processing and incineration. So. Many facilities have been developed for a long time and have been proven to be safe in an urban environment.
And so maybe, Tom, we can go back to you. You know, how exactly do you determine whether the plant would have an impact before it's built and operational?
I guess I don't really understand that. How would the plant would have an impact before it's built?
Well, how
during the construction phase?
Before the plant is built, how do you determine its potential impacts? What sort of I guess what sort of considerations are you taking into account?
Well, so as Rosie said, there are emission limits that are prescribed emission limits. So the plant is designed to meet those emission limits for those contaminants of concern, and it's likely and probable that the plant will be well below those limits. They don't, they're going to be well below the limits. But when we do the impact assessment, we use the limits. We pretend that the plant is right at the edge of where it's allowed to be, and we use those essentially worst case emission limits to, in an atmospheric dispersion model, which we, model the emissions from the stack, and statistically allow that plume to move across the neighborhoods based on the wind speed and direction and the atmospheric stability parameters that historically have been measured, and then the computer models then essentially tell you where the impacts are going to be and what the ambient air concentrations are going to be. And then those concentrations can be compared to the health-based standards that, in this case, are the UK. I mean, most of my work is done, obviously, in the US, and so we use the US EPA standards for most of the stuff that we do in the States.
Yeah, it'd be probably worthwhile adding to what Tom said that these, obviously from the presentation, these are it's well known technology. It's not really new technology. So we know what level of combustion, what the combustion process is about. So what level of emissions will be coming out of the plant. And when we do the modelling, we basically assume that the plant continually operates at the top end of the emission limits, because that's going to be the worst case of what the impact's going to be on the environment. And we can use dispersion models, like Tom explained there, which take
hourly data, and we can predict the way that the plume will disperse in the in the local area, and then what the impact of that is. And that all takes into account a lot of local factors. So obviously being right by the sea where you are, it's lovely. But we can take into the modelling. So we can take into account the difference in the surface roughnesses and how that all affects the dispersion. So it's not a single model fits everywhere. It's a very tailored model to your climatic conditions.
And I guess on that note, I'm probably the only person on this panel who didn't recognize all of the chemical names that came up in Tom's slides. So perhaps maybe you could both tell us a little bit more about the chemicals and conditions that you'll be monitoring for and what they tell us about, you know, the environmental conditions or neighboring industrial activities.
Okay, well, I don't have all the compounds in front of my slide, but so obviously most of the compounds are products of combustion. Some of the compounds are not. So, for example, they're related to what you put in the waste stream contains. So if the waste stream contains, the waste stream will contain metals, and those metals can come from just the trash that you throw out, anything that has metal in it. That metal doesn't go anywhere. It goes into the incinerator, and it gets combusted. And what will happen to it is some of the metals will become particulate matter, and some of the metals are volatile at those incinerator temperatures, and then can leave the incinerator as a gas. So the air pollution control equipment is designed to control volatile metals, typically by absorbing the vapors onto a carbon, and then it becomes a particulate, and then the particulate can be removed from the particulate control system, and then those metals that are particles will also be controlled by the baghouse, or basically baghouse is a filter. So basically the filtering system will filter the emissions at the end. Compounds like, I mentioned acid gases like hydrochloric acid. Hydrochloric acid is a product of burning plastic bags, essentially. The polyvinyl chloride bags will produce chlorine, and the chlorine is hydrochloric acid is an acid gas, and it's an irritant. And so what happens there is some type, and I don't know the specific designs of this particular system, but some types of systems control acid gases, again, by spraying into the waste stream, the exhaust stream, some sort of powdered neutralizing agent, and then that powdered neutralizing agent reacts with the acid gases, and then is scrubbed out again by the filter house, or in some cases there are wet scrubbers that are used. That's to remove the acid gases. The other thing that can happen is dioxins and furans can be formed at certain temperatures in the combustion process, and those also are removed through the well, they're controlled by how you stage the combustion. You can control for them by how you stage the combustion, but they are also end up, the proper word is they end up in the particulate, and then they can also be controlled by removing the particulate matter from the waste stream. So all the technologies for removing these pollutants are well known and in common use in not only waste energy facilities, but essentially every other kind of facility that has air pollution issues. So I don't know if that answered the question, but.
I think the choice of baseline is a key point as well, Tom. So you've chosen to monitor those pollutants that will be regulated from the facility. So the idea of actually understanding what the existing concentrations of those pollutants are, so we can add on the contribution that the facility will be providing, so you can determine whether we're within the limits per se.
Yep, thank you both. And on that note, I guess, Richard, if we can go to a question for you, and then we'll come back to you, Antoinette. Because we're moving from a system of aerobic decomposition in the landfill to a combustion process. So how do the energy recovery facilities with these appropriate air pollution controls compare to or improve air quality compared to landfilling?
Well, certainly in Grand Cayman, very, very favorably. The reality is we have a essentially uncontrolled landfill at present that is being remediated. So it is generating methane, we know it's generating hydrogen sulfide. There's both aerobic and anaerobic decomposition happening in a, Tom, at the start of his speech, it's about that controlled or uncontrolled environment. So we're transitioning very much to a fully controlled environment where both the impact assessment helps inform the design of the facility, the methodology for the air pollution control system, right the way through to stack heights, potentially as necessary and as reflected on the dispersion modeling. So the transition from the landfill that we have here to the energy recovery facility is going to see a significant improvement in general air quality from that waste management area.
It's high. It's also, I think, really a key thing that you'd be generating electricity from the waste that would alternatively be going into the landfill, and that would be displacing some electricity that's generated by your current mix, which I believe is diesel. So it's a lot clean, it's a lot more controlled. So you've not got those emissions from the original, electricity generation that that you're displacing. I think that's a really key thing for energy from waste.
So Rosie, on that note, how do well-run energy recovery system emissions compare with those from other types of plants that create energy, like the diesel generators that we're discussing now?
Yeah, so energy from waste is highly limited. It's highly regulated, and it operates to very strict control measures. As an example, the emission limit for NOx, well, there's a full suite of pollutants. It'll take me forever to go through everything, but if I just focus on NOx, for an energy from waste plant, the emission limit is 200 milligrams per normalised metre cubed. At the same reference conditions, an emission limit for a diesel engine under the Industrial Emissions Directive is 300 milligrams per normalised metre cubed. And unabated diesel generators are 10 times that. So you've got a massive saving in basically not running the diesel generators and running the energy from waste plant instead. And that is just on the NOx emissions. And you've also, that's all the things that can really affect human health. But you've also got the benefit on carbon emissions as well, which is obviously the global warming potential of it. So landfill, you get approximately 0.4 tonnes of CO2 per tonne of waste at your landfill, emitted back via methane, basically. And an EFW, you generate approximately 0.46 tonnes of CO2 per tonne of waste. So it is higher. However, when you take into account the offset of the electricity that would be generated by diesel, it becomes a net benefit over putting that same tonne of waste into a landfill.
Yeah, and I think just to close that one out, Hannah, where the impact assessment is going to really benefit the island and regulators and the government is that it's, this is a baseline assessment pre-energy recovery facility. So we're actually going to see, probably for the first time, some real clarity around emission emissions that are currently taking place, whether it's from cars, whether it's from CUC or industrial units on the island, and what air quality impacts they have. We then build in the cumulative impact on the energy recovery facility.
And Antoinette, can you tell us a bit more about the role that the DEH laboratory is playing in these air quality studies that are part of the environmental impact assessment for the project?
Well, the laboratory has, as a PPP, the public-private partnership, we're working with the operations level of doing this impact assessment. So you heard earlier that the equipment is in the process of being installed. 3 persons from DEH, from my laboratory, are undergoing parallel training with persons from DART who are also going to be responsible for the equipment. And we are learning how to troubleshoot, how to monitor the equipment, how to do basic data collection, and we are getting hands-on experience with how the equipment works. Now, the impact assessment is short, 4 months or so. So once that is done, the equipment will stay on island. So then it will be available for us to be able to use for other similar studies or the ongoing monitoring. And that's the benefit of having local persons and local technicians learn how the equipment works and how to run it effectively and make sure that we're getting good quality data out of it.
Can you tell us, maybe some of us who aren't as familiar with the DEH laboratory, what are some of the things that your team does on a daily basis? What are some of the responsibilities that your team has?
Well, our team supports the work of the department in monitoring things that impact environmental health. So a lot of monitoring programs. We've done a lot of work in indoor air quality and water and food safety. Ambient air quality is new for us, so we're learning. This is an area that throughout the region, there's a lack of data on being able to monitor ambient air quality. WHO and PAHO have made it a priority that we have to be able to get this data to see what's happening in the world. And recently, World Health Organization changed and reduced the limits, the guideline limits for some of these ambient pollutants. So we want to be able to know what exactly is happening. And Richard mentioned that we're going to be able to get some data for the first time. The equipment is expensive, and the technical expertise requires quite some getting used to. So it's not something we've been able to do prior to now. So we're glad to be able to do that and add that to the cadre of the test that the Environmental Health Lab does.
That's quite exciting, and it's something that I think from our perspective at DART with our Minds Inspired programs and also other organizations in Cayman, like I know Health City Cayman Islands as well, there's this focus on diversification of the economy and careers of the future, and STEM education frequently comes up in those conversations. So, what is your perspective on the sort of changing role of STEM careers in Cayman?
I don't think it's so much a change in as a coming to the fore. We've always had a need for technical expertise, and in a lot of cases we have been bringing that expertise in from the outside. I'm really excited to see that our STEM focus is also now helping us. We really appreciate the help, but we have lots of smart young people who are excited about protecting the environment in which they live. And by doing this kind of training and these kinds of partnerships, it's allowing them to have a say in their own futures, which I'm really excited about.
And I think that leads us on to something that you've brought up before, Richard, which is that the terms of reference cover a lot of the environmental impacts and considerations for the project, but there's also the socioeconomic considerations, like the creation of jobs. Is that something you could tell us a little bit more about?
Yeah, sure. I mean, on the STEM side of things, we're focusing obviously on air quality, but the project overall gives an ability to not just look at the environmental parameters and the science behind that. This is a huge significant value project for the island, the largest, in fact, for the island currently under the PPP. And it gives huge opportunities across all forms of engineering, design, architecture, a multitude of aspects where young Caymanians could and should have the opportunity to participate. With regards to what it provides from a social and economic perspective, well, clearly jobs are an associated aspect of that. There will be significant short to medium term construction labor opportunities, circa 300 roles. It's a large project. Then as we transition into operation, then particularly the energy recovery facility allows for quite high technical management of those facilities from an operational perspective, the broader management of the facilities. Once again, in the spirit of the PPP, it is a true partnership with the operational transition from the landfill operations into other aspects of the ReGen project, whether it be the composting or the construction demolition waste facility or the metals recycling. So upskilling, training of landfill operators and DEH operations for the aspects that they're going to be taking over as part of the broader ReGen 9 elements of infrastructure involved. You know, we're up around kind of circa 80 jobs in that space as well. So from a Cayman perspective, it is significant.
And I know that both Rosie and Tom mentioned several times that this is proven technology that's in use around the world. But can you tell us a little bit now about, recognizing that the treatment method was decided by the Cayman Islands government, why was mass burn combustion chosen over other technologies that we hear about sometimes, like gasification? And that can be a question for Rosie, Tom, or
Hannah, I'm going to interject, because that's probably an unfair question for either Rosie or GHD, who I dare say probably weren't part of that process at the time. Well, I wasn't even on island at that time, but I think I've got a reasonable idea of the conclusion that was arrived at. In that mass burn provides the flexibility, a technology that is proven, and we need to keep reinforcing that across the world. It is proven, it is safe. It provides us a thermal combustion methodology that can encompass a broad waste composition, which we have on the island. So there are times you get, there's influxes of, wet waste, wet season. At times, there's aspects that some of the yard waste and the green waste will have to go through it. So that the calorific value range that it allows for is much more suitable for the island than some of the more distinct and increasingly and improving technologies that are available for the island. What I would say, though, is the decisions have been made, and it's still across the group and the team considered the right decision and the right technology. But that said, it's based on best available techniques, and indeed, Rosie and her team at Fichtner are actually part of the work they're doing. This is looking and considering those best available techniques. That this mass burn combustion technology is appropriate for the project. So every step of the way, we're looking to check and recheck and ensure we're on track with that. The EIA informing the design of the facility, and managing and ensuring human health and environmental health as a result of the design and development of this project is absolutely critical to everybody involved with it.
And I think this goes back to something that Tom mentioned. Are there ways that once the facility's up and running, the public can help make sure that the facility's operating to its highest level? I'm thinking about, making sure that some of those metals that could be diverted out of the waste stream are. Are there other examples of things that the public can do once the facility's up and running to help improve its environmental impacts?
Sorry, was that right as well? Well, I mean, the first and foremost aspect of the message is going to be let's move up the waste hierarchy. So that's the fundamental message is, avoid, reduce, reuse, and recycle are critical aspects of any integrated waste infrastructure. By way of direct operational interface for the facility, of course, we want to avoid, some particularly maybe hazardous materials going through the facility, some hazardous chemicals that need a separate form of treatment. There will be a separate facility for clinical and medical waste, so we want to make sure that material gets diverted to that facility. And other, what we don't want is large gas bottles going, whilst it is designed to chambers for explosions and things like that. Within the combustion chamber, of course, to contain that, there's just aspects in the kind of the sorting and the crane operators to manage and mix the waste, and at the front end where the waste is being tipped off to ensure that materials that are out of spec, essentially, for the facilities don't get put into it. So those things blended together, I think, are the most critical aspects.
So from my standpoint as a person, living in Cayman, once it's up and running, I just make sure I'm doing some of those same best practices that we're doing now, making sure that I'm reducing as much as I can, recycling things that can be recycled, and making sure that things that are those potentially hazardous things like batteries or light bulbs, things like that, are not going into my general rubbish bin.
Sure. No, absolutely right. And it is at the household or at undoubtedly there will be an increase in recycling facilities introduced by the government over time and part of the education process. There's a big big operational change when it comes to the public as well. We're currently in operation where, be it commercial or community, can drive to the landfill, can tip their waste there. There is, from a health and safety perspective, there is definitely not the opportunity for the public to drive up into an incinerator, an energy recovery facility, and tip their waste off.
I hope not.
In the same sort of scenario they do so currently at the landfill.
Yeah, absolutely. I think we're at almost about 10 minutes, and I just wanted to gauge if anyone in the audience has any questions that they'd like to put to the panel at this stage. Yes, we've got one there.
Yes, hi.
Antoinette mentioned that there is a lack of quality. Now it's on. Okay. Antoinette mentioned that there is a lack of ambient air quality measures in the region on a whole. I guess I was wondering if we have any historical data regarding air quality in Cayman, because Tom was telling us about the details of the background sampling and testing that they're going to be doing. However, that's going to be done at a time when we haven't had any tourism, we don't have any aircraft, we don't have any cruise ships. The traffic on the roads is a lot lighter than it usually is when we're at our full capacity with tourists. Not as much waste is being produced because we've got thousands fewer people on the island. So how can we gauge that the background testing is actually what it is, or what it usually is?
That's a great question.
Yeah. Do you want to take that? Or Tom, do you want to? Did you hear the question?
Yes, I did hear the question, and I think it's a very good question. Well, I think what it means is that well, let me just back up. So things like traffic, when we do the modeling, we will be modeling traffic. All right, so we won't be just relying on the information we have from the background measurements. We will be, supposing that the traffic doubles in the future. What would the impact be at that point? So we will be, trying to account for increases from where we are at the moment. With respect, I personally, I just do not know the impacts, as more trash being added to the existing facility. I don't know what that's going to do. However, we do have to understand that one of the things we have to consider is that in the future, the new facility will be replacing the old facility, and so the emissions from the old facility will be going away. So with the facility that's there now, some of our background measurements will essentially end up in sort of over-predicting what the impacts might be. Again, everything leaning towards being conservative in overestimating what the impacts are going to be, such that what actually happens will be somewhat less.
I think if I could just add to that.
Yes, please.
I mean, the AIA, we're concentrating on air quality today, but there is actually a traffic analysis study that's going to look at historic traffic on the island that can be considered in the air quality monitoring that GHD will be undertaking. So they can look at those numbers. Interestingly, we continue to monitor the volume of waste going into the landfill, and whilst you would think it has reduced significantly, it actually hasn't. The volumes have been fairly consistent, and I think actually our July figures over 3 years of monitoring this July, no, 4 years, I beg your pardon, this July was the second highest volume of waste going into the landfill, all of which is, of course, delivered by trucks and cars and et cetera, et cetera. So, yes, of course, air traffic has significantly reduced. That will just have to be, there's a number of elements that just have to be considered in the model of what we consider the baseline is going to be. But we also believe that the main elements of air quality and air quality impact in the island currently relate to actual industrial process, so traffic and industrial process. And so, you know, the cement works are working, the distilleries are working, CUC are still generating power. And those kind of key areas, industrial plants and processes that Tom highlighted in an earlier slide.
Yeah, I think, sorry to butt in, I think it's really key that an environmental impact assessment, a key part of it is actually sensitivity analyses. And something like this, like the COVID pandemic, it's happened all over the world. So we're all having to consider the effects of those on our baselines. So as part of the EIA, whoever's writing it will have to consider the uncertainty over the baseline concentrations that's been collected, not just the uncertainty over the measurement technique, but on the scenarios, what was happening at the time, i.e. the lower volumes of traffic. And as Tom said, if they are going to be modelling traffic, they can do, we can model traffic quite well, similar way to modelling stack emissions. And we can produce like an updated baseline, which is like the monitor baseline plus the other sources that would be happening in the future. So a future baseline, sorry. And that can be captured within the EIA.
Thank you. Is there any other questions from the audience? Thank you.
Good afternoon. I have a comment and then a question. And I'm somewhat, I'm going to piggyback on what Dr. Ebanks Peter said yesterday, because she covered quite a bit. I was like, 1 hour of climate resiliency, I don't know, but I mean, she hit it. And what I think for me, when she made mention of all the impacts, I was like, oh my gosh, my total focus on COVID-19 has now shifted to reproductive health and student performance, and I'm like, oh my gosh, we need to focus on those things now rather than COVID-19. But nonetheless, it also took me back to other documents where we've had various studies, and one of them would have been the National Assessment of Living Conditions. And there's an actual section in the NALC that has, was to address strategies for impacting quality of life in the Cayman Islands, right? And it also was to address the infrastructure relating to climate change. And one of the things that Dr. Petrie said yesterday, what she said yesterday, as it relates to having a collective future and everybody being involved, we're going to have to sell a hard, it's going to be a hard sell to say to people that which we've been saying for several years, well, probably over 20 years, right, that we're true to our word. Because I found it quite interesting that one of the, under adaptation, I think, was the strategy for embedding resiliency measures into development and planning legislation. And you're going to have to prove to people that there are indeed policies and I was going to ask her the question about robust enforcement, what that meant. Because if people can't see one thing happening and they don't see another thing happening, because then why should I? Because I grew up knowing that if I threw trash out the car, that's $500 fine, and I didn't want to have to pay that, out of any little allowance I got, So, is it that people are going to understand that, okay, when ReGen does this and they're improving our air quality and DEH is doing whatever their part, no, my part, I'm supposed to do my part, but then when legislations, fail to uphold the policies and have those enforcement measures, then persons might be like, I don't care then, right? My question is, what is the benefit? I think it was Mr. McAree, is it? Did I get it right? McAree. You mentioned benefit to the consumer, right? How does instead of a general benefit, how does the consumer benefit as it relates to electricity? I think you mentioned electricity that will come from this particular facility.
Well, from a financial basis, obviously the distribution of power and the cost of power still will come from the CUC. What 9 megawatts does is allows us to offset approximately 10% of their diesel requirement. So for that element, they will have a fixed cost, essentially. So there'll be a so it won't be at the whim of the market for diesel prices. So for 10% of their power generation, they will be able to fix that cost. Now, it then comes down, I guess, to CUC with regards to how that is considered by the consumer. But what they do know is that it's guaranteed, and it's across the life of the project, which is a 25-year PPP and a 40-year operational plant life of the infrastructure. I think the broader benefits of the project are, there's some very real ones. For example, we can certainly eliminate any future opportunity for landfill fires, which have a significant impact on the community in Cayman, as they have done over the last few years. Never mind, some of the direct, environmental impacts based on either odor or pest or those sorts of things. So a general environmental impact and improvement to the community, I think, is fair to say is guaranteed. So as well as then obviously the socioeconomic aspects of upskilling, training, and additional jobs associated with the infrastructure.
Thank you so much. I believe we're at time. And I just want to say thank you very much to the audience for asking questions. Thank you to everyone who is with us in the room and has been joining us remotely. And thank you to the panel for your time this afternoon.
And certainly thanks to you, Hannah, for moderating that segment, and for the panelists here and those joining us via virtual means. Now we're going to have a short break, and we will be back with you in 1 minute. Thank you for joining us for this conference. Next up, we have presenting for us Dr. Sarah Watkin. She's a consultant pediatrician and neonatologist with Integra Healthcare Limited. And she's going to present on optimizing and protecting child health in the post-closure era. Now, this is a significantly important topic, as nothing makes us all breathe easier than knowing ways that we can keep our children protected. She will cover critical questions about what we need to consider, from vaccination risk, social development, mental health issues, to fear and trauma, as well as education and economic risks. We'll welcome Dr. Sarah Watkin to the podium.
Good afternoon, ladies and gentlemen. Professor George Davis, Professor of Epidemiology, said in the BMJ, the British Medical Journal, in October 2020, in an article called COVID Known and Unknowns, the more certain someone is about COVID-19, the less you should trust them. The World Health Organization talks about the COVID-19 epidemic and the infodemic of false information spread by social media that many take more credit for than information provided by their own medical personnel. Here in Cayman, we as pediatricians talk about the unnecessary pandemic of fear in children and their parents. And this pandemic of fear has a greater risk in the long term, potentially to our children, than COVID-19 itself. Now, a lot has changed since October 2020. We now have a vaccine for COVID. We have new tests like lateral flow tests, and the amount of data we have today is considerably more than then. But it is really important for us that we do operate not under false data and neither under old data too. So the aim of my talk today was to talk about how we protect and optimize child health post-closure. But we need to recognize that post-closure is not post-COVID. COVID is here to stay. And we must consider that what we're doing during closure may have long-term implications for our children. So what I'm going to talk about today does creep into the arena of politics. It creeps into the arena of discussions about vaccinations, which many have different opinions on, about school closures, and many other aspects. And I want to reinforce now that I am apolitical, but I do serve the needs of children. I've been a pediatrician now for 34 years, and I've devoted my life to child health. And I am going to be open and honest about the issues we are facing. So the first thing we need to realize is that COVID-19 is a mild disease in most children. It is milder than many things that we would consider normal and which children get admitted to hospital for example, severe gastroenteritis and bronchiolitis. But we are taking decisions affecting our children's post-pandemic health, welfare, education, and life chances for adults. And I want to re-emphasize that. The decisions we are taking are to protect adults, not to protect children. So who are we really talking about in this talk? Well, we're talking about children under 16, but especially those under 12. That is the unvaccinated population. And we're talking about that in the context here in Cayman, that every adult and every child over the age of 12 has been given the opportunity to protect themselves against COVID with a vaccine that has almost no contraindications. This slide shows the United Nations Convention of the Rights of the Child, and I'm going to highlight a few of the squares. Square 24 talks about every child has the right to health, water, and food. 27 includes clothing and a safe home environment. Square 28, access to education. Square 6, the opportunity for life survival and normal development. But the two squares I'd really like to highlight are squares 3 and 12. We need to be doing everything in the best interests of children, and we need to do that by recognizing the voice of our children. So the critical question we need to be asking ourselves is, what should we be protecting our children from? Is it from COVID-19, or is it from COVID-19 measures? I'm going to come back and talk in more detail about COVID-19, but I've already hinted it is a mild disease in children. But many of the measures we are putting in place, and I'm going to come back to these too, have long-term implications. And I'm going to just give you one example. Closing a whole school for more than 15 days deprives our children of their education. It deprives some of their parents from a salary. It deprives those children from having food on the table each night and the ability to think and behave as children. And it is increasing fear and trauma in our children. So we have to be very clear about what we are doing and why we are doing it. And so the questions I want to try and address in this presentation are these. What will happen if my child gets COVID? What are the health consequences of COVID measures? How can we prevent COVID and still optimize child health well-being? And what is the role of vaccination, if any, in children? The last three questions I'm going to consider together. The role of good health in children now and the future, what we as adults can and should be doing to really protect our children, and how we move forward healthier together for the children. So I want you to ask yourself the question, which of these children has COVID? And the reality is that 60 to 70% of children with COVID infection are completely asymptomatic. That is, they have no symptoms whatsoever. So we might ask ourselves, why are we excluding from school children with symptoms? And even then, are we excluding children with the right symptoms? At the beginning of this school year, there was a school that would not allow children with a runny nose into school. Runny nose is not even a symptom of COVID infection. And those of you who are parents will know that some winters your child has a runny nose almost every day. So let's go back to the question of what are we protecting our children from, and look at COVID-19 in a little bit more detail. So are we protecting our children from death? Well, the data from the UK shows that the chance of dying from COVID is 2 per 1 million children. That is 1 in 500,000 children die of COVID. Are we protecting them from severe illness? 47 per million children with COVID are admitted to an intensive care unit. And those children who have no underlying comorbidity are much less likely to die and much less likely to be admitted to an intensive care unit. So I'm just going to look at UK admissions in children under 18 in a little bit more detail. The slide on the right of this, the graph on the right of this slide shows the total population by age group in England, and there are 10.2 million children aged 0 to 14 years in England. This study looked at all children with COVID from the beginning of the pandemic to early September of this year. During that period of time, there were 5,800 children admitted to hospitals in the UK with the virus. 25 children died from COVID, and about 250 required intensive care. 690 children were admitted with a condition that's extremely rare post-COVID called pediatric inflammatory multisystem syndrome, or also called multisystem inflammatory system of children. And we know from the UK data that although Delta variant has increased transmission, it has not increased the severity of disease in children. But what we do know from this data is that children living with multiple conditions, children who are obese, and children with heart and neurological illnesses are most at risk. I want to try and put the UK data into perspective. In the UK, there have been 3 lockdowns, but on March the 8th of this year, the UK reopened all of its schools, allowed children to attend schools under normal conditions without wearing masks and without any other aspects of protection. This is a picture of Boris Johnson, the Prime Minister of the UK. Boris Johnson said, "Keeping children at home is a far greater threat to their well-being than the coronavirus. Every time we exclude children from school, we may well be causing lasting harm to health, well-being, and life chances." One of the things people often say, well, the UK data is different to the US data. So here is the US data to see alongside. So this slide shows the number of coronavirus disease in the US as of September the 29th of this year. Sorry, this is coronavirus deaths. And what you can see is that the proportion of deaths in young people is tiny compared to the adult population. So there are 73 million children aged 0 to 17. The total deaths in children up to September the 29th in the US is 478. That's a total death rate of 0.0007%, or 6.5 per million. So you might ask why 6.5 per million compared to 2 per million in the UK. The likelihood is the poor access to healthcare for Black, Hispanic, and Latino populations within the US, who are also more likely to have undiagnosed underlying health conditions. I think the next slide is a really, really important slide, because it compares the death in children from COVID to other common causes of mortality in children. If you look at the graph on the left-hand side, this shows deaths per 100,000 children and adolescents. It divides it into 3 areas: urban in the blue, suburban in the orange, and rural in the green. The first 3 columns are deaths from motor vehicle accidents. The second from firearm injuries. The third from cancers. The 4th, suffocation, and the 5th, drowning. I hope when you look at this slide, you can see that the deaths from all of these things is significantly, significantly higher than the deaths from COVID, both in the UK and in the US. So I've tried to take this data and see what it might mean for us in the Cayman Islands. It is estimated that we have 11,000 children aged 0 to 14. If we assume a mortality of 1 in 500,000 children, then Cayman is likely to suffer one childhood death every 45 years from COVID. If we take the rate of severe illness at 47 per million, we're likely to experience one child needing intensive care every 2 years. And without comorbidities, we would expect one child death every 145 years in the well population, and one severe illness requiring pediatric intensive care every 12 years. Now, of course, that death could come in year 1 or year 145 or anywhere in between. But what this really reinforces is that we should be identifying and protecting the at-risk group of children who are a very, very tiny number in our population, and letting the rest of our children get on leading normal, healthy lives. So one of the things people often say at the moment is that more children are getting infected. And that may well be true, but remember the data, even with the Delta variant, shows that the vast majority of children are asymptomatic with COVID-19 infection. This is data from the USA, and it looks at the number of cases of COVID-19 added each week for children and adults, and this data goes up to the 23rd of September of this year. You can see back at the very beginning there were relatively few children with COVID or recorded as having COVID compared to adults. Today, it seems like that proportion is much higher, but remember, adults can be vaccinated and children cannot. We do know that children are just as likely to get infected with the Delta variant as in previous variants. We also know that children who do get COVID appear to have persistence of protective antibodies for much, much longer than adults. So in seropositive kids, 12 months after they've had COVID, they are still protected by their natural antibodies from getting another infection. And so we could be asking ourselves, why aren't we just allowing our children to get COVID and to develop natural protection for themselves? If our adults are vaccinated, we should not be getting worried about our children getting COVID. So let's just talk about COVID disease in a little bit more detail. So my first reminder to us all is that 60 to 70% of children are asymptomatic, and the majority of the remainder have mild disease. But I'm just going to focus for a moment on the symptoms of COVID and two complications of COVID, long COVID and multi-system disease. So this slide shows the symptoms in symptomatic children with COVID, and it divides those into children under 11 and children 12 to 17. If you look at children under 11, the 5 top symptoms of COVID are headache, fatigue, fever, sore throat, and abdominal pain. If you look at the 5 top symptoms in older children, they are again headache and fatigue. But sore throat, complete loss of smell, and fever are the next 3. Your typical child with COVID under the age of 11 has 3 symptoms, and your typical child over 11 has 4 symptoms. If you look down this list, runny nose does not feature anywhere. So some people are quite rightly worried about this condition called long COVID. An initial study suggested that maybe as many as 50% of children might have long COVID. The chances of having long COVID symptoms does not seem to be linked to this illness severity. And the symptoms are multiple, as you can see from this slide, but the most common symptoms reported are headache and tiredness. The good news is that this is probably not as bad as we thought it was going to be. I must emphasize that this slide shows a pre-publication results of a study, but which has been widely reported in the media and in medical journals. Because it is pre-publication, the data may change. The study looked at children in the UK who had done a COVID test and sent them questionnaires 15 weeks later. Between 2 and 14% of children still had symptoms 15 weeks later, but almost none of them had sought help from a doctor, and almost none of them were not attending school. Because they asked children who had been both positive and negative on PCR testing, it was interesting to find that 66% of children who had tested positive had one or more symptoms, but actually so did 53.3% of children who had tested negative. However, 3 or more symptoms was more likely occurring in 30% of children who had a positive PCR compared to 16% in children who had a negative PCR. Just over a year ago, reports started appearing in the media and in the pediatric literature about a condition called multisystem inflammatory syndrome in children, or pediatric inflammatory multisystem syndrome. This is a condition that presents 2 to 6 weeks after COVID infection, but on average 4 weeks after infection. The most striking feature is a persistent fever with many other symptoms, and it resembles a condition called Kawasaki disease. The median age of children with this condition was 9 years. It appears to be distributed equally across different ethnic groups. 98% of children who got this condition had had a positive PCR test, and the remaining 2% had been in contact with someone with COVID. And 60% of the patients were male. The good news is that for almost all children, they get better. So this is data from the USA from January 2020 to August 2021. And it looks at daily reporting of these cases of MIS-C and daily reporting on a 7-day moving average of COVID-19. The blue line is MIS-C and the grey line is COVID-19. But please note that there are very different scales of reporting. So the scale on the left hand for MIS-C is in actual numbers. So 5, 10, 15. And the scale on the left-hand column is in thousands. So 50,000, 100,000, 150,000. Up until the end of August of this year, there have been 4,661 children in the USA who have been diagnosed with MIS-C. Of these, there have been 41 deaths. The population in the US from 0 to 19 is 81.25 million children. The chance of acquiring this condition if you have had COVID is 1 in 17,000. And your chance of dying if you've had COVID is 0.88%. So now that we've looked at COVID, let's look at the consequences of our COVID measures. And we need to ask ourselves, what harm might we be doing in trying to protect our children so that we protect our adult population? UNICEF said in April 2020, children are not the face of this pandemic, but they risk being its biggest victims. So you've already seen this slide twice before, and the provocative question is, what are we protecting our children from? We know a great deal now about COVID-19 in our children, and as I've hinted to you already, we know that it's a mild disease. But our COVID measures risk our children's long-term social development. There is no doubt that they have been associated with increasing mental health issues. They're associated with fear and trauma in our children. We are depriving our children of educational risk, their education, and depriving them of long-term life chances. We're depriving the families of those children of their economies, and we are putting children at risk of basic poor housing, poor nutrition. In Iceland, there is data that shows these children who are isolated at home have increased risk of committing suicide, especially in young adolescent boys, and there has been significant school dropout in older children who have never returned to education after being locked down at home. This is a slide from the UK that shows the life expectancy inequality gap between males in 2014 to 16 in the most deprived decile and the least deprived decile. So if you are in the most deprived decile, your average life expectancy between 2014 and 16 if you're male was 73.9 years. In the least deprived decile, it's almost 10 years longer, 83.3 years. If you look at the contribution to that gap, the deaths are coming from heart disease, lung cancer, chronic respiratory illness, cirrhosis of the liver, and other liver disorders. And we need to ask ourselves, are our attempts to protect adults through measures which affect children, put them at risk of becoming more deprived, setting up both children and adults for ill health and early death for generations? This slide is from the Kaiser Family Foundation, and it shows that health disparities are driven by social and economic inequalities. The poorer you are, the less educated you are, the less ability you have to put food on your table, the more likely you are to die, the more likely you are to be ill, the more likely you are to have increased healthcare expenditure, reduced health status, and increased functional limitations. And what we're doing at the present time with our protection against COVID-19 in children is increasing that. We are potentially depriving our children of educational attainment, socialization, and putting them at increased risk of poverty. These interlinked set of risk factors will influence the future health and prosperity of our children. This is a very important slide from Archives of Disease in Childhood, published in 2020, which looks at the waves of impact for children and adolescents from COVID-19. This is the impact at the time of the pandemic. This is the post-pandemic impact, and this is the potential impact for future generations. In the pandemic, our children are at risk of mortality and morbidity, but probably more from other illnesses that have deprived them of access to healthcare than from COVID-19 itself. There's also been increased unemployment, insecure housing, and financial distress, which all put children at risk through increased risk of child abuse, not enough food to be fed properly, etc. Post-pandemic, risk to children includes the impacts of delaying their immunization, impacts with delays of normal health care, impact of school closures on nutrition, education, and mental health during the pandemic, and there's a differential impact on our most vulnerable children. The future impact we don't know about, but I'm going to show you some data later that suggests that children may leave school earlier, not have the same educational attainment, and therefore put themselves at risk of long-term health problems, reduced resilience and worsened mental health, reduced education and employment opportunities. And I think this slide just summarizes that. This is a slide taken from something I mentioned earlier, which is from Iceland, which showed that with class exclusion, there has been increased suicide rates in young men, increased children never returning to school, and increased child abuse. So let's look at school exclusion, attainment, and health in a little bit more detail. The first part of this slide on the left-hand side, is published from Youth Truth Survey, and it shows, or asks the questions, what are the obstacles to virtual learning? So they asked children, do any of the following make it hard for you to do the at-home learning opportunities provided by your school? 64% of children said distractions at home made it difficult to learn. 50% stated they felt depressed and stressed at home. And 30% said there was no adult to help them learn. If you go to the bottom of this slide, though, you will also see that 22% of children had limited or no access to the internet, and 16% of children had no access to a computer. So we know that children don't learn as well as at home, and we know that poorer families are going to suffer much more than wealthier ones. The second half of the slide looks at the National Health Interview Survey from the CDC. And what this slide shows is that whatever your ethnic group, whether you're a white man or a white woman, or a black man or a black woman, the lower your educational attainment, the worse your health. And it looks at a whole variety of health measures: poorer fair health, multimorbidities, and functional limitations. So what this is telling us is that worse learning attainment is directly linked to worse later health. So next, let's now look at school exclusion, economics, and health. So this is data from the US, and it shows that if the lower your educational attainment, the lower your usual weekly earnings, and the higher your chances of being unemployed. So these are children who reached less than a high school diploma, and these are adults who reached a doctoral degree. So what we're really saying here is that worse learning attainment is linked to lower income and higher unemployment. The other half of the slide looks at child and adolescent obesity rates related to family income. And what this slide shows is that the lower your family income, and particularly if your family income is below the poverty line, the higher the chances are that your family, your children, your adolescents are obese. So 21% in the lowest group and only 12% in the highest wage earners. So again, income and unemployment are directly and indirectly linked to poor health. So now let's look at mental health and the mental health and physical health link. And I'm just going to use one example today, and this is data from England, which looks at eating problems in children. And it compares 2017 to 2018. The columns that are in the orange are boys, and the columns in the blue are girls on the left-hand graph. And what you can see is that there has been a significant increase in eating problem disorders in both boys and girls between 2017 and 2021. What is more striking, perhaps, is the slide on the right. So at a time when it is extremely difficult in the UK to get anyone into hospital, there has been a very, very significant increase in the number of young people being admitted to hospital with eating disorders. And having worked in the UK, I can tell you that your eating disorder has to be extremely severe to be admitted into a hospital setting. So again, mental health is directly linked to learning attainment. And learning attainment is directly linked to mental and physical health. So I'm going to change topics now and think about preventing COVID and protecting our children. And think about some of the practical measures and some of the unpopular realities for post-closure health. So one of the questions we need to ask ourselves is, how is COVID transmitted to and between children? And what does this really mean for health and education? So this slide tries to summarize the Australian experience with the Delta virus. It looked at 11 primary schools over a period from the 16th of June to the 31st of July. And it's important to know that the average teacher-student ratio in these schools was 1 teacher to 33 to 38 students. During that period, there were 14 COVID primary cases, 9 in students and 5 in staff. But what the data showed was that the risk of transmission of COVID in schools was 4.7% compared to 70% if a child with COVID went home to a non-vaccinated family, and that you were more likely to get COVID as a child in school from your teacher who was unvaccinated than from another pupil. You are more likely to get COVID from an unvaccinated teacher than from another pupil. The risk of child-to-child transmission in schools is low, but if a child takes the disease home to an unvaccinated family, the risk of transmission is high. Professor Christine McCartney, the director of the National Centre for Immunisation and Research at Sydney's Children's Hospital, said, "We're very lucky to know, and it's consistent with data over the course of the pandemic, that COVID-19 is mild among children. Only around 2% will require hospitalisation, and for many of those 2%, it's for monitoring and social care. Unfortunately, often their parents are unwell with COVID-19, and that's why they're actually being cared for in a hospital." So our reality is that an adult who is unvaccinated, a teacher who is unvaccinated, can accidentally give COVID to children who then take it home to their own unvaccinated family and cause spread of the disease. But as I've hinted to you all earlier, we as adults absolutely have the ability to protect ourselves by being vaccinated with a vaccine that has almost 0 contraindications. So I'm just going to reflect for a moment about vaccination in adults, not children. I'm going to come back to vaccination in children. This is about vaccination in adults. And just a reminder that vaccination does prevent infection and it does prevent death. So this is data from the UK, and it looks at how effective are COVID vaccines at preventing infection. So this is, the first slide is data from December the 1st, 2020 to the 31st of May, 2021. And we'll just look at the total data, which looks at both the Pfizer BioNTech vaccine and the Oxford AstraZeneca vaccine. But if you have been vaccinated and have had a single dose, if you look at the population as a whole who've got COVID, only 0.5% of those people have had 1 dose of the vaccine. Again, if you look at those people who've got COVID, only 0.1% of that population have had 2 doses of the vaccine. In other words, the vaccine is highly effective at preventing new COVID-19 infection. The second slide looks at the effects of vaccination on COVID deaths. So this looks at the percentage of people who've died according to their vaccination status. So 37.4% of all people who have died from COVID in the UK were unvaccinated. 23.5% of people who died were within 21 days of their first vaccine dose. 9.9% were more than 21 days after their first dose. If you'd had 2 doses, then your chances of dying fell to 1.6% if it was within 21 days of the second dose, and down to 0.8% if it was more than 21 days after the second dose. So vaccinations work. This is data from 3 hospitals in the USA. This is single-day data. I can't read my slides from here, but the first hospital is, I think, Sarasota Memorial Hospital. This is the Medical University of South Carolina, and this is a group of 14 different hospitals that make up OSF. And what you can see from this data is, whichever slide you look at, is that if you are hospitalized, you are much more likely to be hospitalized if you are unvaccinated than if you are vaccinated. If you're admitted to intensive care, and I'm just going to use the MUSC data, so on the 26th of August at MSUC, of the people who were in intensive care, which were 57, 49 were unvaccinated and 8 were vaccinated. And then if you look at those who are on the ventilator, 29 were unvaccinated and 5 were vaccinated. So vaccines definitely do work. So I'm going to talk about masks next. And I'm just going to stick to masks in children, to be fair. So the important thing to be aware is there's absolutely no consensus across the world as to which children should wear masks and which shouldn't. So there are variations between nations, there are variations between agencies, and there are variations across age bands. But I think absolutely everybody is in agreement in the Western world that children should be at school. So this is the only real published article on masks and other factors in schools to try and reduce the risk of COVID transmission. And it was done pre-vaccination. And what it showed that if teachers wore masks, and remember these teachers at that stage were unvaccinated, that worked to reduce transmission. And the only other thing that worked was increasing ventilation. And for most classrooms, this can be done very simply by opening doors and windows. Things that didn't work were distancing, hybrid teaching models, classroom barriers, HEPA filters, and student masks. So putting masks on students did not reduce the risk of transmission, but putting masks on teachers did. So who actually says what? So there are many countries not mandating masks, including the UK and Ireland, but also all of Scandinavia, France, Netherlands, Switzerland, and Italy. The CDC recommends, but does not mandate masks for all children over the age of 2. And WHO and UNICEF say there should be no absolute requirement for children 6 to 11 to wear masks. So UNICEF says that in children 0 to 5, we should not wear masks for their personal safety and their personal development. It is absolutely essential that a child can get a mask off in an emergency. And for the ages of 6 to 11, children should only need to wear masks where it can be done safely and where there is widespread transmission. And in one of the countries with the highest vaccination rates in the world, widespread transmission should be low. So could we operate schools as normal? And I think we could, as long as our teachers are vaccinated and are wearing masks. As long as our families who've got children in school are vaccinated. If we're distancing our children in the classroom by ideally 3 to 6 feet, then there certainly should be no need for children under the age of 12 to wear masks. And if we start using tests such as lateral flow testing to test children with symptoms and to keep them away from school if they test positive. So you will all know that lateral flow tests have been introduced into Cayman this week, but in other countries of the world, such as the UK, they have been used regularly for some time. I have 3 children in the UK. They're all expected to test themselves twice a week. They test themselves at other times if they're going out for a party, so they make sure they're socially responsible and don't take COVID to a group of people. These tests are cheap compared to PCR. They may not be cheap here in Cayman at this moment, but they're cheap across the world, costing somewhere between $2 and $5 each compared to $150 for a PCR test. And they are much more simple to do. They're a bit like doing a pregnancy test. They can be read at home. They're not as invasive as a PCR. You need to touch your tonsils with something that looks like a cotton wool swab and the front of your nostrils. And they are 99% accurate at recognizing those people who do not have COVID. So these tests are really, really good at telling you that you are truly negative, that is, you truly do not have COVID. They are less good, perhaps, at telling you if you are positive or not. In other words, if you have a positive test, you may not really be positive. And in those cases, you need a PCR test. But these tests are easy to do and would allow us to start leading normal lives again. We also need to be serious about when children shouldn't be in school. So students, teachers, and staff should stay home when they have signs of COVID. But with lateral flow testing, they can be tested almost immediately, and if they are negative, return to school. And I'm actually just going to go back 2 slides for a moment, because this is really important. So these tests are really, really good at showing you when you have symptoms that you are infectious. And in fact, they are perhaps better at showing you when you are better than PCR tests. And I want to just highlight this for a moment. So PCR tests can remain positive in the post-infectious period when people are no longer infectious. And yet we have a policy at the moment that if you are PCR positive at the end of your 15 days of quarantine, you have to remain quarantined until that test becomes negative. Those tests for some individuals can take 90 days, and they are not infectious. But those families are losing income. I'm talking to families who are not being paid. I'm talking to employees who I know are not paying their employees. They can't afford to pay them if they're not working. And we have to take these things seriously. Ooh, that was good. How to get it back on? So let's talk briefly about vaccinating in children. So the things that are really worth knowing is I'm vaccinated, my children, this is my son Oliver in the middle slide, is vaccinated, and all our nurses and doctors in our practice are vaccinated, and we're all alive and well. I've been doing pediatrics now for 34 years, and during that period of time, vaccination schedules have changed tremendously. Particularly during my senior house officer years, that's when I was a junior doctor, I saw many, many children die of infectious diseases that we now vaccinate for. These slides here show actually children with septicemia and meningitis. All of these are now prevented with vaccination programs that we have in this country. In 1989, I was a senior house officer at Great Ormond Street Children's Hospital. That year, I saw 2 children, previously well, die of measles. These were children who died who had not been vaccinated. And we forget how important vaccines have been at protecting our children against serious disease. So generally what I'm trying to say to you is I support vaccinating children because I've lived through too many children dying unnecessarily. But we do have to think, what is the role of any one vaccine? And vaccines have 2 roles, one to protect ourselves and the other to protect others. An example of a vaccine to protect others is the German measles or rubella vaccine, and this is a picture of rubella here. We give rubella vaccine to our children to protect their unborn brother or sister or somebody else's unborn child. But we're not really bothered about rubella in the child themselves because it's a mild disease. When we think about the COVID vaccine, we are really, in children, the real question is, who are we giving the vaccine for? Are we giving it to protect children, or are we giving it to protect adults who can actually protect themselves by taking the vaccine themselves? So, as you all know, 2 vaccines have emergency approval to be given to children aged 12 to 15. They're the Pfizer vaccine and the Moderna vaccine. But in fairness, the Moderna vaccine is certainly not being used in the USA or in the UK. So these vaccine trials were actually done on relatively small numbers of children. So this first slide shows the trial for Pfizer and the second for Moderna. Pfizer used a dose of 30 micrograms, and this is really important because the dose with Moderna was 3 times higher. The trial that has allowed us to put this vaccine into place had 1,131 children receiving the vaccine and 1,129 receiving placebo. The trial showed that there were no major adverse events related to the vaccine, and the children did produce an immune response. And of course, or good for the vaccine company, there were no deaths in the COVID vaccine group and 16 in the placebo group. This is the trial of Moderna. So as I said, Moderna gave 3 times the dose. They gave 2,489 children the vaccine and 1,243 had placebo. Again, no side effects, good antibody response, no child died in the vaccine group, and 4 died in the placebo group. But since these trials have been published and since we've been using this vaccine, there's been increasing reporting, especially in the USA, of myocarditis. This risk is particularly high in young boys, and it is higher after the second rather than the first dose of the vaccine. Fortunately, it appears to be acute illness that is clinically self-limiting, and there have been no deaths. But we are unaware yet about what the long-term consequences of this myocarditis might be. This data in the UK stopped us until very recently vaccinating our 12 to 15-year-olds because UK paediatricians asked themselves, were the effects of the vaccine worse than actually the effects of COVID? And we just need to be very aware of this when we're thinking about vaccinating our younger children, who again, we would potentially be vaccinating to protect our adults who have decided not to get vaccinated themselves. So, how do we interpret this? So, vaccines in children do work, but they provide a tiny benefit for the thousands that are vaccinated. There is possibly reduction in prolonged symptoms, there is possibly some prevention of MIS-C, and there's been modest reduction in onwards transmission. You'll be pleased to know, I think, that the FDA has asked the vaccine companies to go back and increase the numbers of children under the age of 11 put in their trials before they say that these vaccines are safe for the under 11s. So let's quickly look at optimizing and protecting child health in the post-closure era. And we have to recognize that what feels rather like science fiction today is going to look very normal tomorrow. But what COVID has already told us is what we already knew. That if you are well, you tend to do well in health. And if you're well and you become ill, then you tend to do well also. But the children who don't do well are those who are unhealthy. And I've shown this picture here of the child eating the burger on purpose. There's been one meta-analysis of 42 studies looking at severe COVID-19 infection and pediatric comorbidities. This study has looked at 275,000 children without comorbidities and 9,000 with comorbidities. Only 0.2% of children without comorbidities got severe COVID, whereas 5.1% of children with comorbidities did. If you look at the bottom line, it tells you that the relatively risk ratio of dying if you have comorbidities compared to without is 2.81. But what was most striking was that obesity was worse. So the children who are obese and get COVID are more likely to die. So why is this important? Well, this is data from here in Cayman. It's old data now. It's data produced by Dr. Lawrence and overseen by Dr. Hazel Brown from HSA. And it shows that between 1987 and 2007, there was a significant increase in the number or percentage of children defined as, at the time, overweight, but which would now be defined as obese. And these data have continued to increase. Now, sadly, obesity is a symptom of families who are struggling. I showed you this slide before, but the lower your income, the more likely you are to have children and adolescents with obesity. And we know that if you're obese as a child, you're more likely to go on to long-term problems with high blood pressure, diabetes, cancer, and cardiovascular disease. I've also shown you this slide before, and I just want to reinforce again, that health disparities are driven by social and economic inequalities. And what we are doing at the moment in Cayman is worsening that. So we can all breathe easily when we're addressing the fundamentals of health and wellness. And we need to start by appreciating that child health is not just a goal, but it's a barometer of health. And we need to be thinking of wellness in multiple dimensions, and I'm glad that this conference this week is doing that. So we need to ensure that the basics are there, that every child has nutritious food, adequate shelter, adequate sleep, exercise. They have immunizations on time, and we are protecting their emotional and psychological safety. And the ways we can do this is ensuring that children have their well child checks and ensuring children have their school checks. Last year, there were no school checks in Cayman, and this year it was abandoned until very late in the year and only happened in the public schools and not in all of the private schools. We need to continue to ensure that our children are vaccinated against the common childhood diseases, and we need to identify and protect our vulnerable children, and those children, again, who are at risk of COVID. So what is the contribution of us, the adults, to our children's health? The number one contribution that all of us can give is to vaccinate ourselves. If we do this, we can stop thinking about what we can do to protect our children through other measures that are more harmful. I can't tell you how many mothers ask me, what can I do to protect my child? What vitamin can I give them? What supplements can I give them? And I ask them the question, are you vaccinated? No. And yet vaccination of themselves is the greatest gift they can give to their children. We need to wash our hands reliably. We need to wear masks when unwell. We need to ensure good ventilation in our schools and social distancing when mingling inside. We need to make sure that our children attend well child visits and that we preserve these. We need to give them a healthy diet with active vitamin C and particularly vitamin D. And then I want to focus on this. We need to protect our children's mental health. We need to avoid scaring our children, and we are scaring them. And coming back to this comment, a pandemic of fear in our children. And that pandemic of fear is being driven by us, adults. We have to stop closing schools, and we have to stop depriving our children of education, and we have to stop them being frightened of a disease that is mild for them. Yes, we do need to keep children home if they've got symptoms, but we know if they've got symptoms, if we do a lateral flow test and it is negative, they don't have COVID, and they can be back at school assuming they don't have a fever. And of course, we need to encourage our children to exercise, and we need to take our time to play with them. So we need to learn to thrive with COVID and not to hide from COVID, because our children's health depends on it. And if we do thrive, we will do more for the future child's health than anything else. And then we all can breathe easily. Thank you.
Thanks, Doc. If you can stay there, just have a couple of questions for you from some viewers joining us virtually. And you just touched on the pandemic of fear. Can you report on the number of children with anxiety that you've seen, say, over the past year, and how much of this is about their fear of COVID?
I can't necessarily give you numbers, but I think all of us working in pediatrics and those working in psychology and other child services will be able to tell you that anxiety has increased tremendously in children over the last year here in Cayman, and there is also data across the world showing similar.
Thank you. We can open up for one more question from the room. We'll take one quick. Right here.
This lady here. Oh.
Dr.
Watkins,
yes. I noticed you didn't have much stats for the children within the region, which would be good to have. But I just want to say thank you very much. That was really good. And it was so informed, and it just keeps reminding me of why it's very important to have informed decision-making. Don't just make decisions because you think that is the best decision, but it needs to be informed by data. So thank you very much.
I'm just going to make a comment. It would be lovely to have more data, and we must have data here in Cayman. We must be able to tell you how many teachers have got COVID, who's spreading COVID to who. That data is all there. We must have data about how many families are presently locked up at home, but we're not publishing that data. And I think we should be asking to see it.
Okay, Dr. Watkins, thank you very much.
Thanking you.
once again, thank you very much to Dr. Sarah. She had a very captivating presentation. I know she held our attention, those of us here in the room, and certainly those viewing virtually. Thanks as well to Integra Healthcare, one of our premium sponsors. Of course, the conference is able to be held each year without charge to attendees, thanks to the amazing corporate sponsors who come on board. So we say thanks to them. We're going to transition quickly and move forward, a packed agenda, and we're going to keep rolling. We now have Dr. Mark Hauser, President of Medical Affairs at Baptist Health, South Florida. He's going to be joining us via Zoom, and he will be presenting on COVID and long COVID, and will cover generally virus biology and COVID-19, vaccines deployed in the US and how they work, vaccine components, efficacy, and safety data. He'll also touch on variants, including Delta, the evolution of evidence and evidence-based therapies, long COVID, additional vaccines and booster shots, and most importantly, protecting our individual and collective health. Dr. Hauser, we welcome you virtually to the Cayman Islands, and we look forward to your presentation.
Thank you for that kind introduction. My disclosure is that I am a full-time employee of Baptist Health South Florida, 10 hospital system here in Florida, and I do not accept any money from any drug companies or vaccine companies. And if I mention any off-label or unapproved uses, they're things that are endorsed by the CDC, the World Health Organization, the NIH, or prestigious specialty societies. So I took the liberty of going to your website and pulling up your data. I wish our data looked as good as yours, although there is some recent uptick in activity in the islands that I'm sure you're concerned with and will address very professionally. Worldwide, there's been almost 240 million cases with almost 5 million deaths. In the US, where I am, 45 million cases, 730, a mortality rate of 1.6%, less than the world mortality. Obviously, there could be unreported cases and unreported deaths, but the United States only has 4% of the world population, but almost 19% of the cases. So I don't think we should be very proud about how we handled the pandemic in general, but the individual cases I think we're handling well, because our mortality rate is 15% of the mortalities, whereas our cases are 19% of the total. So some plaudits, but overall pandemic handling, I think, not very impressive. This is the cases in the United States. Remember back in April of 20, everybody thought that was bad. In Florida, where I work, the hospitals were shut down basically for anything elective. We had half full hospitals, half full of COVID cases. And then last summer, the United States had a wave, but I was in one of the 4 states that had a bad wave. And our bump would be much, much higher than that. And then, of course, after the winter, the winter had a really bad surge in the United States and a smaller one in the spring. And now the Delta variant gave us quite a surge, but not quite as big as happened. And the estimates that I've seen is that if we had not vaccinated during the December, January, February period, this April surge would have been as big or bigger, and hundreds of thousands of more lives would have been lost with 4,000 deaths a day. So the vaccination really has, and I'll get into what might have happened with the Delta surge without vaccination. I think the other ones are tiny compared to what we would have lived through. And then this is the mortalities that occurred, quite a few during that initial surge, not as many during the summer in the United States overall, quite a few, up to almost 4,000 a day during the winter. And then our more recent surge peaked at 1,700 and now is down to about 1,100 per day. Hard to believe we could become the least bit complacent over those kinds of loss of life. This is my health system. I just thought I'd give you a glimpse about what's going on in Florida. we had a peak of about, in 10 hospitals, about 150 new patients a day. We got a census of 970 at one point, and 130 ventilators. And now we're down to about 20 cases a day and about 40 ventilators, with a census of about 150. So we're on the way down in regards to this. We had some really awful operational challenges in beds and staffing and even liquid oxygen supply. They couldn't top off our tanks, and very stressful. We were never in the comfort zone for weeks and weeks. Another interesting thing is the age ranges. This is our age ranges throughout the pandemic, and we could discuss at every point in this why. But what I'd like to point out in regard to that elegant pediatric discussion you were just able to hear, in the 5 to 17-year-old group, we've seen the top graph is our positive tests, in the 8 to 10 range, but the last few weeks up to 26% have been in that age group. The lower graph is the ages of the population that we're seeing in the hospital. And this big bump that we saw up to 63% recently is, as the other cases become less frequently, these are the very vulnerable older patients in that 65 plus group that are frequently in the ICU or ventilators and either recover or expire after everybody else goes home from the surge. I'm going to do some really basic stuff. I apologize if you're a physician, and maybe some of these comments will help you deal with your lay population. I was told that this was a mixed audience. So the two most important things to know, we look at this picture all the time, and I like to stop and say the two most important things to think about is the spike protein on the surface, because that's what determines, the receptor that the virus can attach to. And this particular one, the bad ones, happen to be lung, heart, blood vessels, and kidneys. And that blood vessel one is as an intensivist, is one that's really scary for me, something that causes an infectious vasculitis. And then the other one, of course, is the nuclear material, which is the yellow spiral, which in this case is an RNA virus, and it's single-stranded. The importance of this is that that's what's picked up on the PCR test. And also, single-stranded RNA is more likely to mutate than our double-stranded virus, which is much more stable due to the base bonds that keeps the two strands together. This is my 10th grade biology for non-clinical people. Viruses attach to cells, inject their genetic material, it multiplies, makes pieces of viruses, which assemble and come out, not four, obviously, innumerable, and attack other cells. The first vaccination was Jenner, back before the turn of the 20th century. And he noticed that dairy maids and dairy farmers did not get smallpox, but they did have some sores on their hands. So he took the pus from cowpox cows and injected people. Those of you who are in their 60s and 70s like me might have a little scar in their arm because it causes an eschar and leaves a scar. And this prevented smallpox. And of course, those of us who live near Spanish-speaking countries or in bilingual areas like me know VACA very well. And so we are cowinating people with vaccines. So for me, the basics are, for the virus to enter a cell, the spike protein has to find the receptor. In this case, it's that ACE receptor, which, as the physicians all know, is involved in blood pressure regulation and tends to be in places like kidneys and heart, lungs, and blood vessels. And the approved vaccines all cause our cells to make spike protein. The body sees the spike protein as foreign. We make antibodies so that if we counter it in the future, the antibodies will coat the spike protein, if you will, and keep it from entering cells. Again, 10th grade biology, in case there's anybody who isn't a physician on the call, DNA is our genetic code. DNA makes proteins by this ingenious method where it uncouples, makes RNA, The RNA in the cytoplasm makes little pieces of transfer RNA, which lines up, mRNA, which lines up transfer RNA, which brings a specific amino acid, and voila, we have a protein that acts either as a structure or an enzyme to make something else complex. Obviously, in mRNA, the thymine is replaced with uracil. So the Pfizer and Moderna vaccines skip the old DNA, RNA thing and start directly with mRNA. So people who tell me they're scared of mRNA, I go, well, if you get COVID, you're going to get, billions of copies of DNA and RNA from a virus, and then you're going to get that same mRNA anyway. So that doesn't really make sense. And then, of course, the J&J and AstraZeneca, only the first is approved in the US, use modified cold viruses. The first is AD26, and the second is a chimp virus, and they can drag their genetic material that's been modified to make spike protein into cells, but not multiply. And then it does the RNA, mRNA, tRNA thing and makes spike protein. In all cases, we get immunized to spike. So the Moderna and Pfizer, Moderna, are 21 and 28 apart. J&J is 1 so far. All demonstrated in their trials complete protection against hospitalization and death. They are less effective against Delta, but still as effective as many other viruses vaccines. AstraZeneca is not approved, and it's presently 2 injections, and various countries have done between 4 and 12 weeks. You probably know the US FDA approved the Pfizer vaccine completely a few weeks ago for 16 and up, and it's still under emergency use for 12 to 15. This is the data directly from the CDC website on the submissions for these approvals. And let's just look at the Pfizer. You're injected on day 0, somewhere around day 12 or 14. The treatment group doesn't get very many more cases, and the placebo group continues to go on a straight line, the blue line, and have some severe cases and maybe 1 severe case in the treatment group. By severe, I don't mean ICU ventilator, die severe. I mean some pulmonary infiltrates, needing oxygen, very mild criteria. And Moderna had a similar curve, J&J, a little less impressive, but no severe cases after day 48. That's directly from the CDC. You can go and look at it yourself. This is the Pfizer local reaction data. Most people had a sore arm, as you probably did if you got a shot, and a few people get a little bit more local reaction. As far as systemic reactions, the most common are viral symptoms, but not the sore throat, runny nose, cough. Those are symptoms of infection, not a vaccine. And the number in this group that prevented work was 0.7%. If you look at the next to the last line, 124 out of 18,000 missed a day of work. It might have been a little higher in Moderna. For those of you who had that, you know that it can be a little bit rockier. But look at the placebo group, 101 out of 18,000 people missed work for a saltwater shot. So humans will be humans. For those of you who are aware of the cerebral sinus thrombosis and thrombocytopenia reaction that was seen with AstraZeneca and J&J, and also some other large blood vessel clots, this is what the FDA used as its CDC talk used as its justification for going on with the approval. In females of 18 to 49, there were like 7 cases of TTS and 6 deaths, 6 deaths prevented, 56 ICU and 297 hospitalizations prevented. So, and in females over 50, 1 case and much more morbidity prevented. So when people ask me about this, I go, look, if this worries you per million cases and you're a woman 18 to 49, take one of the mRNA vaccines, which are readily available, especially in the United States. And if you're over 50, you might make the same decision, but not necessarily. It looks a lot safer. In men, the chances of getting it are 1 per million if you're under 50 and about 0 if over. So very low incidence, and that's why they approved it. And again, if you're a woman 18 to 49, there's plenty of alternatives. This is a publication that somebody did that I stole, and very interesting. AstraZeneca vaccine, 4 cases per million, birth control pills, 500 to 1,200, smoking, 1,700, and COVID infection, 165,000. So the people who are worrying about clots from vaccines should think about the disease. What's in it? The Pfizer and Moderna both have mRNA, laboratory made mRNA. The J&J has this replication incompetent adenovirus that has DNA that codes for spike protein. If somebody's going to be allergic, it's the second component, which is polyethylene glycol, which is in Miralax, which is used for constipation. So if somebody's going to be allergic, it's probably the second line. The rest of the components are all things that are in a lot of injectables and should not cause a stir. This is one I found, what's in AstraZeneca, which we don't talk about a lot in the US. It's got that recombinant replication deficient chimpanzee adenovirus, and it makes, and its DNA makes spike protein and a bunch of other things that aren't scary. 3 things can happen to you that are adverse when you get vaccinated. The first is you can have an allergic reaction. It's usually hives or itching. It's occasionally anaphylaxis. Those of you who are physicians know that can be scary, but all the sites that administer it in the US are required to have rescue medications like adrenaline and oxygen, blood pressure cuffs, and so forth. The second is people faint when they get shots, and that is not a dangerous situation. And the third is you could have one of the vaccine side effects that we discussed. So the Delta variant is really a different animal, at least in my experience. So it's more contagious. People are finding 1,000 times more viral particles in the nose. It's likely more severe. I'll show you the CDC slide on that. And there are breakthroughs infections in the vaccinated, which probably are transmissible as unvaccinated. But it does prevent a lot of severe disease. And if we had not had vaccinated people during this Delta, we would have really been in trouble in the United States. We're in trouble already, but my area is getting better, and it would have been beyond trouble, a nightmare. So the CDC is recommending in the US mitigating behaviors to mask indoors if you're in a high-risk area, except when you're with your family bubble, and in outdoors if you have to be close to people. This is for Florida, where I live, the Delta statistics, 97% Delta. So if you get it, you probably have Delta. And this is what the CDC showed on their COCA call. If you haven't had an opportunity to look at any of those, they're very good, and most of them are recorded and available. 8-fold at least reduction in disease, 25 in hospitalization, 25 in death. This is what we want from a vaccine. This is a horizontal line is the contagiousness, if you will, and the vertical is the mortality statistics. So the original ancestral strain, each person, this is that R0 or R-TAW, if it's modified, gave it to 1.5 to 3 people, but with SARS, 5 to 9, average around 6, it seems. So much more contagious. The herd immunity number for this, if one exists, is probably more like 90 than it was for the original variant of 65 or 70. And obviously, this is a log scale, and it looks like it's they were saying it's about 50% increase in mortality at the time of that publication. But it's not as morbid as the original SARS-1 or a Spanish flu or Ebola, bird flu, MERS, some other coronavirus, right? So this is something from California that I threw in. It was their statistics up and through July, which showed unvaccinated versus vaccinated infections versus hospitalizations, still very effective. If you're going to take one slide and you're a vaccine proponent and put it in your pocket to use, this is the slide. Because this is a prestigious journal, New England Journal publication, of the difference in these adverse effects over the baseline per 100,000 population for vaccine in blue versus COVID infection in orange. So acute kidney injury, 0 to -5 versus an extra 125 cases. Appendicitis, the same. Arrhythmia, 166 to less. DVT, 43 to -1. Now this herpes zoster, higher and then lower the wrong way. You know, we've seen some funny immune effects from vaccines, and I haven't found any more detailed data about this, but I think a risk of 16 shingles infections per 100,000 would be worth it. Intracranial hemorrhage, 8. Now, those of you who deal with this know that you can get some swelling in the axilla of lymph nodes from the vaccines, certainly worth it to be immunized. Heart attack, 25. And then this whole myocarditis, pericarditis thing, 3 more than baseline per 100,000 and 1 for myocarditis and pericarditis from the vaccine and 11 from COVID. So obviously getting COVID isn't the way to prevent needing to be vaccinated, and then for pulmonary embolism, 62. So really an elegant presentation of why you shouldn't get COVID to prevent having to get vaccinated. This is something the Joint Commission put out for a week in August. This is 1 week's of mortality, 5,564 deaths during this week. And the vaccinated were the yellow ones. So at this time in the United States, a little bit more than 50% say we're vaccinated. So basically, instead of having these few yellow dots, we would have had twice as many blue dots. In Miami, it would have been, since we're 75% vaccinated, it would have been 3 groups of blue dots more, or 4 times as many deaths, 20,000, instead of these few who were vaccinated. So it saved our bacon. I mean, the number of cases, we had 970 cases in the hospital. If we didn't have that 75% of the population vaccinated, we would have had 4 times that many. And the same thing with our ICUs, which were full. So it saved us. Here's our data for mortality by age group. So up to age 49 from 18, 4 out of 76, very low. 50 to 64, 15 out of 124. Over 65, not as impressive, right? Vaccinated 82 out of about 250, about a third. So this is, why did the CDC recommend booster shots for over 65? I'm sure that we are somewhat representative of what's going on in our country environment. So people over 65 had waning immunity. So during this entire time, I've been responsible for the COVID response, a clinical response to COVID for my 10 hospital system and all the employed physicians and everybody. And, you know, there was like 130,000 posts in the first year on various websites. That's like 365 a day. And they range everywhere from a news report that you've all seen this. Somebody on TV says something that is a theoretical consideration, and you know, people start quoting it on social media, or there might be a press release. You know, the drug companies do this all the time about their antiviral or their vaccine. It's going to work great in kids. And sometimes the headlines are the opposite of what it does, like aspirin for COVID was one I wrote down. So press releases confuse people. Abstracts, well, then we get to, you know, somebody publishes, they did a research study, and they decide we can't wait one more day, and they post it, not peer reviewed, and they just give us an abstract of the result, but we don't even see the data. And then maybe they'll post the data, but it hasn't been peer reviewed, and we don't, you know, and then finally it might, if it's credible, and it's get published in a journal after peer review. We can see if it was a randomized controlled trial or just some of this observational stuff that we were getting early on in the pandemic. And then it might be supported by experts, authority like FDA, EUA, whatever. And the NIH has been very good at us being wingman for our doctors. You'll see some of that. or specialty societies. And then at Baptist Health, we support things in these other last two groups with order sets and algorithms and try to make it easy for our doctors to do what they have to do without reading 130,000 publications. The Surgeon General of the United States, Dr. Murthy, happens to be the son of a doctor on the medical staff of one of our hospitals. He's so proud. You can go and see this thing that he published on misinformation, which is you hear something that is not accurate scientifically and tell hundreds of people on social media, or disinformation, which is even worse when people purposely give out information which is not. I recommend this to you. There was this publication in the Journal of Antimicrobial Chemotherapy, which looked back at a lot of the early publications that were observational studies, and when randomized controlled trials were done, they were not upheld. So we really need to be careful, even with observational studies, about what we implement. So what is out there that's evidence-based? Well, remdesivir is this antiviral, which is fully approved by the FDA in the United States, which interferes with viral duplication. And it's approved for hospitalized patients. And the sad thing is that after randomized control evidence showed it reduced hospital days, they stopped the study before we could get good mortality data. There are some newer studies coming out on remdesivir, which are not as reassuring, and I think we need to see how that plays out. For the time being, this has become a standard of care, which is continuing. The other thing that has been shown to be beneficial is the corticosteroids, dexamethasone and methylprednisolone. There is randomized controlled trial evidence that it prevents progression of lung inflammation and reduces mortality. Monoclonal antibody, there's been new information coming out even this week, which is more reassuring. There's one with two by Lilly and by Regeneron, and these both have FDA EUAs, and I'll show you some more evidence, but we are doing a lot of this in our community. And then there are these anti-inflammatories that you see advertised in the US on TV that say, take this if you have psoriasis or inflammatory bowel disease or rheumatoid arthritis, and tell your doctor if you have an infection. And these immune modulators have been used to try to calm the cytokine storm, and there are some other ones that can be used when there's shortages. This is an example of the kind of information that's available from the National Institute of Health, and they update this regularly as the stuff. I'm not going to go through the details of it, but basically it's a wingman for the poor hospitalist who's taking care of 50 new COVID patients a day about what if they don't have oxygen, high flow, or ventilator, and very specific about what to do and not to. So they've really been a big help. And then the monoclonal antibody, just this week, the New England Journal publication that the original data was that it reduced hospitalizations and emergency room visits in outpatients by 70%, but now it's showing that in this same group, a 4.6 to 1.3% reduction in mortality, symptoms down by 4 days, and decreased viral load. So we are doing a lot of this. I don't think that people should forego vaccination to be rescued with a monoclonal because it certainly is not the right way to think about this. There is an emergency use authorization for symptomatic outpatient infections and high-risk exposures in the United States. It's given intravenously, preferably, but some government sites have been giving 4 2.5 ml injections, like 1 in each arm and 2 in the belly. So a lot of this has been given. This is how much we were giving. At the peak of our recent thing, we were given 1,200 doses a week, and now we're down to about 200. So theoretically, if it reduces 70% of ED visits and hospitalizations, if we gave 1,000 doses, we might have prevented 90 of those. So a worthwhile thing to do. This is the ivermectin controversy. A lot of ivermectin is being prescribed in the United States during this last wave. The FDA says it's not approved for prevention or treatment. It's unusual for them to make a statement like that about off-label use. And the NIH is basically saying it should be used in a study. We have very little being used in our hospitals. Once in a while, a patient's family, usually when they're not even in the infectious stage anymore, they're, will insist on it and threaten to call a judge. And my own feeling is if a doctor's willing to write for it, we'll let it happen. It's a relatively harmless thing to do if not yet evidence-based. Obviously, we should not be using farm animal doses like has happened in some people. So I know that long COVID was billed as part of this talk, but there's really not a lot known about long COVID. The World Health Organization today defined it as mainly, a foggy, mentation, fatigue, and dyspnea. And it can occur in all kinds of situations, hospitalized and not. There is an excess deaths at 6 months of 29 per 1,000 people who get COVID, and a lot of burden from COVID. And my own feeling is, why is this happening? It infects blood vessels. This is not published information, but things that infect blood vessels scare me, and that might be the reason. I've gone to COCA calls and stuff. All kinds of bad things can happen to you when you're sick in the hospital. You're on a ventilator for 3 weeks, you're going to be weak and deconditioned, have pulmonary fibrosis and deconditioning and short of breath and hypoxemia. And then there's this other effect, these lingering, non-specific chronic fatigue-like symptoms and brain fog symptoms that I don't think we understand very well yet. But people certainly are complaining of. Here's my Mythbusters. I hope you agree. It cannot be spread, the vaccine, from person to person. There was somebody in Miami in a school, a private school, that wouldn't let vaccinated children attend because they thought they were going to catch it from them, the vaccine. I personally wish we could catch the vaccine. That would probably fix this whole thing very quickly, but so far, no. The only fertility effect that I've seen is affecting sperm from COVID, not from the vaccine. All 3 obstetrical societies recommend vaccination for women who are planning to conceive, think they're going to have babies in the future, during all 3 pregnancy trimesters and lactation. And Parkland published just this week something I didn't have time to put in the talk about really much more severe disease in pregnant women from the Delta version, and very strong recommendation for vaccination. Again, they are not made from the virus, they're made in a laboratory. Some of them do have an adenovirus in it, as we said. They don't alter one's DNA or enter the nucleus. Sorry, docs, they don't have nanochips or magnetic material or 5G, whatever that is. And they don't cause zombies. I tell people who think they cause zombies that they have even a different medical problem if they think there are zombies. And they cannot cause COVID-19 infection, obviously, and they're as safe as and effective as the data that we showed. So there's a lot of discussion about relative immunity from vaccine versus infection. Well, both of them confer some degree of immunity, which obviously is not permanent. But there's good information showing that vaccination on top of infection probably reduces another round of infection by at least 50%. So it is recommended by the CDC. And which one is better really is not the useful conversation. It's one should not get COVID to prevent vaccination, because COVID is really much worse. And they shouldn't think that they're going to be rescued by ivermectin and keep that and zinc in the closet and say, well, I'll just take ivermectin and zinc if I get it. So what about third doses? So the FDA and the CDC approved a third mRNA vaccine, both of them for immunocompromised patients, effective in August. It's the same, you're supposed to take the same one, and it's not a different version. It's either the same Pfizer or the same Moderna. You're supposed to not cross over. One study, demonstrated some cancer patients may benefit from the third dose, and the real life unpublished data from Israel, it's probably published by now, and I just missed it on this slide, is 86% prevention of illness and hospitalization. So this is considered a third dose because they probably didn't get a good response from the first 2. And here's the CDC recommendation: solid and hematologic malignancies, transplants, these primary immunodeficiency, congenital syndromes, HIV with bad counts, 20 milligrams of prednisone a day, some other immunosuppressives, and those tell your doctor if you have an infection drugs, the tumor necrosis blockers for psoriasis, etc., are the ones that we may miss on these indications. Now, there's also, the Pfizer is also recommended for a booster. A booster isn't the first two didn't work, it's the first two are wearing off. So that's third shot versus booster. So the recommendation on the CDC website is here. It's you're over 16 and you're 6 months out, you're in a long-term care facility, 18 plus, and you're 6 months out. You're 50 to 65, 6 months out from your first ones with an underlying condition. And those are should. Then there's the maze. The CDC director added these maze, 18 to 49 with underlying health conditions, 18 to 64 working in an occupation like healthcare where you may be exposed. So that's the booster information in the US. Some parting recommendations. I tell people to accept the administration of a vaccine, not only for you and your family's benefit, but as a citizen of the world or your country to try to get us out of this vicious cycle of this pandemic. Make that decision based on science, not news or social media, looking to disrupt society or some other political group. Continue the mitigating behaviors when necessary in your community. In the United States, every county in the country just about is red, except for California, every state rather. And we need to be kind to one another. These are really stressful, dangerous times. And then another final comment, the golden rule, we mask to protect one another. And mask, you remember John Kennedy, President of the United States, very personable, assassinated young. Mask is not what your country can do for you. Mask is what you can do for your country. And I hope that was interesting and useful information for somebody on this talk, and I'd be happy to listen to any questions.
Thank you very much, Dr. Hauser. Yeah, we do have some questions for you from some viewers. The first question is, what percentage of people who have had COVID are getting it a second time? And follow-up, is there evidence or statistics showing that if you get it twice, the original strain and then the mutated strain like the Delta, if you're seeing anything like that?
I think people now who got the original in Miami, at least in the United States, they're getting the Delta because that's what's in the United States. So they had the original, the protection of infection is waning. And, the Delta is hitting you with 1,000 times more viral particles, and somebody aerosolizes it in the area and, people just don't have enough antibody after a certain amount of time to get it all. So people get an infection. And fortunately, most of those infections are not severe, but we are seeing people who've had initial infection reinfected. I know individuals who've had COVID, vaccination, and got COVID again. So even vaccination on top of it is not perfect, but certainly better than going unprotected.
Thanks for that. Is there anyone in the room with a question for the doctor? If there isn't, I will ask another question that we have received from a viewer. If I am vaccinated, got COVID with mild symptoms, do I need to get the booster as I am over 65 years old?
I would. I think that it's a really harmless, I've already had 3, I'm 74. So I went and got the booster. I didn't have COVID infection, but you could probably, if you wanted to, wait. You should wait at least until you're uncontagious, but I have seen no official recommendation to wait on getting the booster because you've had an intercurrent infection, except to be non-contagious, so you don't infect the nice person giving you the third injection.
What about yearly boosters? Is there any indication yet from studies about the need for yearly boosters going forward?
I mean, that's really only conjecture. We didn't know until 3 weeks ago we were going to need a booster at 9 months, right? At 6 months, I guess. So So we just don't know that information yet. But I wouldn't be the least bit surprised if this became endemic like flu and we were getting some type of a vaccination every year.
Okay, so I'm going to look around the room once more if there are any other questions from within the room. Just giving you time to get those coming in. But I think you have captured our attention, Dr. Hauser, on your presentation. We had some questions come in. The room has been quite attentive to you. So, of course, I would like to thank you very much. Do you have any other parting words following the questions?
No, it's been really a challenge navigating this. You know, I've been involved in medicine. I finished medical school in 1973. My thinking goes around science and logic, and this post-Enlightenment period that some of our country has entered into, which rejects science and logic, is really a disturbing phenomenon. And I think it's going to be a challenge for all of us who are scientists and try to do the best we can based on evidence going forward.
Dr. Hauser, thank you very much for your presentation and for answering our questions. Here's hoping that come 2022, you will be able to join us in person here in the Cayman Islands.
I would love that.
Yes, and thanks as well to Baptist Health for your continued and unwavering support of this conference. Now, we are going to take a break. Those of you at home in your offices can get up from the computer and stretch a bit. Those of you here in the room can get up and stretch and get some refreshment. Coffee break coming up, compliments of our sponsor, Marsh. We'll be back in here at about 28 minutes after 3. So we have a bit of time for you to get up and move about. Thank you.
are going to be here and Pouchie will be running. Let me run through them.
Yeah, exactly.
Welcome back, everyone. Here's hoping that those of you here got a chance to get some refreshment, stretch your legs, maybe catch up on a few work emails, and those of you joining us virtually would have been able to do the same and made the break productive. Now, our next presentation covers another topic that has become more and more relevant since the onset of the COVID-19 pandemic: coping with anxiety in the new normal. This is vital not just to our mental health, but by extension, our physical health. I would like to welcome Shannon Seymour, Director and Psychologist at the Wellness Center, also a supporter and sponsor of this annual conference. I'm looking forward to this session and to be hearing more information on what we all can do to cope with anxiety. We'll have Shannon Seymour.
Thank you very much. Thank you for keeping me all clean. I'm going to put this right here. Okay. Thank you to the organizers for inviting me to talk about what I think is a really important topic any day, regardless of what's going on in the world, but particularly in light of what is happening right now around the world, and particularly in terms of what's happening in our community. So I wanted to talk about anxiety, but also just mental health in general. And one of the things that's been interesting is that all of the speakers have touched on the topic of mental health. So Miss Gina Ebanks Petrie talked about mental health related to physical health, and Dr. Watkins spoke about the mental health of children quite a bit in her presentation. And so I think that it's certainly not the topic that's reserved for those of us who work in mental health, because all of us experience mental health. And so I'm glad to see it becoming sort of the norm when we talk about anything related to health. I've not seen this kind of clicker before. Okay, so we're just going to cover some, what are some of the statistics that are out there? What are we finding about mental health and COVID around the world and in the region? We're going to spend some time understanding stress and the HPA axis, because this really explains a lot of what it is that we're experiencing and what it is that we're feeling. And I think it's interesting that last night when I was here sort of milling about talking to different people, and even today when I've been talking to people, the common theme is, I'm struggling. I've had people say to me that they're really having a hard time. I had somebody telling me yesterday about a story of sort of breaking down, and part of it was in, we were having a laugh about it, but the other part of it was that people are having a hard time, and we're doing the best that we can, but it's something that we need to all be mindful of. We're going to talk about some of the mental health challenges and some of the challenges that the mental health community has faced as a result of the pandemic, and then we're going to sort of talk about how we need to really start to switch our thinking if we're going to be able to manage this ongoing stress that's in our environment. So I think you can imagine that the mental health research from around the world is painting a pretty dire picture. It's painting a picture of increased substance abuse and addiction everywhere. It's painting a picture of increased depression and anxiety and other mood disorders everywhere, an increase in psychiatric comorbidities. We certainly are seeing an increase in family conflict, and we're seeing an increase in community conflict here at home, and we're seeing increases in sleep disorders across the board, children and adults. And so these are coming across everywhere. This isn't unique to any one particular region, but if we look at the UK, we look at North America, we look at PAHO, these are the kind of things that people are reporting. So the PAHO guidance sort of helps people and organizations and countries to be ready for what might be coming next. And they have some very simple statistics that they've gathered over many, many, many years of gathering data. PAHO is the Pan American Health Organization. And they say that after any sort of humanitarian emergency or any type of natural disaster, that every country can expect the following. They can expect that approximately 3 to 4% of the population are going to experience a severe mental health problem, and that about 15 to 20% of the population is going to experience a mild to moderate mental health problem. And when we put those percentages and we apply them to the Cayman Islands population, then what we're seeing is approximately 2,400 people with severe mental health problems and about 12,000 people with mild to moderate mental health problems. And this is an estimation of how we should plan our resources based on a single natural disaster or some type of humanitarian emergency. We are 18 months into this pandemic. This is not a one-time event. This isn't something that was terrible and horrific, but that it ended. We are still in it. And so we're yet to really see where these numbers are going to fall, but I imagine that they will continue to be quite significant. The WHO did a global mental health survey in, I think it was the summer of 2020, so fairly early on in the pandemic, and one of the things that they found was 60% of the 130 countries that they surveyed said that there had been a disruption to their mental health services. There had been a disruption to the way in which people could access mental health care, which put at risk those people who already had mental health problems because they were no longer able to access their therapies, they were no longer able to access their doctors as readily, they were no longer able to be part of their group interventions or engage in the community activities that were part of their treatment plan. What they found was that this impacted the most vulnerable people in communities, new mothers who wouldn't have had access to postpartum care, to home visitation from child care minders, also older adults, and our children. And what we found here was the transition to telehealth was really easy if you lived in a house with good Wi-Fi and you had a laptop and you had a private room where you could have a quiet conversation with your therapist. But it didn't really help those who lived in multi-generational families with not such great Wi-Fi without privacy. And maybe somebody across the kitchen table who's the same reason maybe you're coming to therapy. And so we found certain populations of people at greater risk for being able to not be able to access mental health care. 89% of countries listed psychosocial supports as something that was part of their pandemic response, something that they were going to do in reaction to what we knew was going to be sort of a mental health pandemic after the pandemic. What's interesting, though, is that only 17% reported having added additional funding to these kinds of programs. And so while countries said, yes, we need these things, there wasn't a lot of countries that were willing to put a lot of money into it in terms of being able to make sure that they were robust and that they were easily accessible. 70% of countries adopted telehealth, but only 20% of those had access and participation parity, which meant that somebody could participate in telehealth equivalent to or equal to the way that they would have been participating in in-person therapy. And we found that here. We found that initially our insurance companies weren't funding any telehealth services. And then we were able to get that rectified, and then they were willing to cover 1 hour of telehealth therapy, which wasn't helpful if you saw a parent for an hour and then a child for an hour, or maybe you saw a couple for an hour and then you talked to another service provider for a little bit. And so we didn't see the parity or the equity across those two platforms of delivering mental health therapy. And I think all of these things have contributed then to the increases that we've seen. We also know that things like isolation, bereavement, anxiety, and addiction are continuing to be the things that show up frequently across all jurisdictions. The NHS in the UK does a children's mental health survey every year, and so they've got this great sort of pattern of data that allows them to compare what's changing in the mental health status of children in the UK. And I think Dr. Watkins alluded to this, but they're seeing a significant increase in eating disorders. They're seeing a significant increase in sleep problems. I found this a really interesting statistic. 55% of kids, 11 to 16, think that they're spending too much time online. And most kids that I know don't think there's any amount of time online that isn't healthy for them. And so the fact that they're identifying, yeah, this is too much, speaks, I think, to the way in which they're even being impacted by this. The other thing that came out of it is that boys aged 6 to 10, and girls 17 to 23 seem to be faring worse. And what that's about, we could discuss that or debate that. I have some ideas, but those seem to be our groups that are showing up as most vulnerable. So we know that children's health has suffered, and so has adult mental health since the lockdown. A study by the Kaiser Family Foundation, and this is a family foundation that has done some incredible study. The Kaiser Foundation is where we get our ACE studies, looking at adverse childhood experiences. A lot of our trauma research comes out of the seminal research that was done at Kaiser Permanente. And so these are people who we like to follow and understand what they're collecting. They've done a comparative study where they looked at essential and non-essential workers. And why I thought this was really interesting was that tomorrow is World Mental Health Day. And the theme this year is looking at inequality in mental health. And I think we can start to see where those holes are for our more vulnerable families. What they found was across the board, whether it's anxiety and depression, substance use, or suicidal ideations, are essential workers, those people who had to be on the front line, who had to go out, who didn't have the benefit or the luxury of being able to stay at home and feel safe and be with their families, are having much more difficulty when it comes to their mental health. What's puzzling, not puzzling, but what's troubling to me is that those are often the same people who have very limited access to mental health insurance, right? It's often our non-essential workers in the Cayman Islands. That would be our financial industry, that would be our banking industry. They typically have much better health insurance policies. They typically have in-house employee assistance programs. They have corporate wellness programs. And so they have access to those services, where often our essential workers, our cleaners, our grocery store attendants, our food delivery personnel, those are people that are often on much lower health insurance plans that don't provide any mental health coverage. And so we could say, is this because they've been out in COVID working on the front line, or is this because they have had difficulties that they haven't been able to get treatment for? I don't know. I imagine a bit of both. What was striking to me was the increase, or the difference, I guess, between suicidal ideations. So 8% of non-essential workers reported having had suicidal thoughts in the last 30 days, compared to 22%. And that's a significant amount of our population. When we think of 22%, that's a quarter of the population has thought in the last 30 days about killing themselves. So I just pulled our data. Right before lockdown, we had transitioned to a electronic health record system that allows us to pull some data fairly quickly. So a comparative between 2020 and 2021 in an outpatient clinic in the Cayman Islands, we see our Q1 data. This is total number of appointments. So this isn't hours, this isn't clients. This is just the total number of appointments attended. And you can see that we've never gotten back to our pre-pandemic rate. And we're seeing a bit of a steady climb. We've got a bit of a dip in Q3 of this year. I suspect, if I had to hypothesize, it might be people were feeling a little bit of like anticipation of some relief. So it'll be really interesting to see what Q4 looks like. But what you can see, I mean, Q2 of this year is double the 3 months before the pandemic hit. And so we see that, and we're one clinic, there's 10 others, and I know when I talk to my colleagues, everybody's experiencing the same thing. And this also wasn't an increase in clinicians, this wasn't an increase in service, this can't be accounted for by, we had somebody new arrive that brought a different clientele in or a different service that we could provide. This data comes from the Cayman Islands Mental Health Commission. They do a quarterly survey that's completed by all mental health care facilities in the Cayman Islands. And so we do this as well. We have to fill out a survey of data every quarter, send it off to the Mental Health Commission, and then they track this as it relates to our national data. And so this is looking at suicide attempts in the Cayman Islands. I think when I added this up early, it adds up to somewhere about 80 people have attempted suicide in the Cayman Islands since the pandemic. And we see 2021, it doesn't seem to be decreasing. And although we have always sort of seemed to have a little bit of variability, we're not sure what's going to happen with the rest of this year. And this is concerning because the pandemic isn't over yet, because we are continuing, even right today, to be here with very limited face-to-face capacity, and many, many, many of our children are back home out of school. So some of the challenges that I think we've seen in the mental health field in the Cayman Islands is that we've seen increased wait lists. I was talking to somebody yesterday who said they really wanted to speak to a counselor, and they were calling, and everywhere was 3 weeks or 4 weeks or longer. Because we're trying to see more people, we're often having to increase the amount of time between appointments. And so it might be that a best treatment plan is for somebody to be seen weekly, but maybe now they're being seen every 2 or 3 weeks so that we can try to keep that wait list down. We've had a loss of psychologists that's resulted in pretty significant wait lists for things like psychological assessments for kids with disabilities who need accommodations in school or who need treatment plans updated. We've had, we had visiting psychologists that would come in and offer highly specialized services that haven't been able to come since the lockdown. And we've had some people who've opted to leave in the lockdown. We've seen an increase in hospital admissions. The mental health unit, I think, has been at capacity since the pandemic started. And we've seen that even within our own clinic, the number of clients that we are referring to the inpatient unit. And I think that quarantine, although I understand the medical reasons for it, adds significantly to mental health problems. The isolation of 14 days without anybody else around you is incredibly difficult for most people. So what is going on? Why is this happening? Why did we know this was going to happen? Why does PAHO predict that this is going to happen after any type of major hurricane or natural disaster? It's something called the hypothalamus pituitary adrenal axis. And it's a thing that controls within our brain the way that we respond to stress. And it's an amazing structure deep within the core of our brain that regulates a lot of different functions that helps us to be able to absorb and to adapt to stress. And so we're going to watch just a quick video, and hopefully it works.
Are you sleeping restlessly, feeling irritable or moody, forgetting little things, and feeling overwhelmed and isolated? Don't worry, we've all been there. You're probably just stressed out. Stress isn't always a bad thing. It can be handy for a burst of extra energy and focus, like when you're playing a competitive sport or have to speak in public. But when it's continuous, the kind most of us face day in and day out, it actually begins to change your brain. Chronic stress, like being overworked or having arguments at home, can affect brain size, its structure, and how it functions, right down to the level of your genes. Stress begins with something called the hypothalamus-pituitary-adrenal axis, a series of interactions between endocrine glands in the brain and on the kidney, which controls your body's reaction to stress. When your brain detects a stressful situation, your HPA axis is instantly activated and releases a hormone called cortisol, which primes your body for instant action. But high levels of cortisol over long periods of time wreak havoc on your brain. For example, chronic stress increases the activity level and number of neural connections in the amygdala, your brain's fear center. And as levels of cortisol rise, electric signals in your hippocampus, the part of the brain associated with learning, memories, and stress control, deteriorate. The hippocampus also inhibits the activity of the HPA axis, so when it weakens, so does your ability to control your stress. That's not all though. Cortisol can literally cause your brain to shrink in size. Too much of it results in the loss of synaptic connections between neurons and the shrinking of your prefrontal cortex, the part of your brain that regulates behaviors like concentration, decision-making, judgment, and social interaction. It also leads to fewer new brain cells being made in the hippocampus. This means chronic stress might make it harder for you to learn and remember things, and also set the stage for more serious mental problems like depression and eventually Alzheimer's disease. The effects of stress may filter right down to your brain's DNA. An experiment showed that the amount of nurturing a mother rat provides its newborn baby plays a part in determining how that baby responds to stress later in life. The pups of nurturing moms turned out less sensitive to stress because their brains developed more cortisol receptors, which stick to cortisol and dampen the stress response. The pups of negligent moms had the opposite outcome, and so became more sensitive to stress throughout life. These are considered epigenetic changes, meaning that they affect which genes are expressed without directly changing the genetic code. And these changes can be reversed if the moms are swapped. But there's a surprising result. The epigenetic changes caused by one single mother rat were passed down to many generations of rats after her. In other words, the results of these actions were inheritable. It's not all bad news though. There are many ways to reverse what cortisol does to your stressed brain. The most powerful weapons are exercise and meditation, which involves breathing deeply and being aware and focused on your surroundings. Both of these activities decrease your stress and increase the size of the hippocampus, thereby improving your memory. So don't feel defeated by the pressures of daily life. Get in control of your stress before it takes control of you.
So, okay, there we are, good. I love that video because it highlights a couple of things. It highlights that what's happening is neurochemical, but it's also highlighting that there's lots that we can do about it. And it also highlights the important role of parenting and support for our more vulnerable parents, and for nurturing and for support. And I think it gives us a pathway for understanding what's happening, but also knowing what we can do to support ourselves. So this is a visual of what that video just showed us. So there's our brain, and it senses a stressor, some kind of fear, some kind of threat, and that system activates. The adrenal glands activate. They release cortisol and adrenaline. We're getting ready to fight something. We're getting ready to run away from something. And that's how it typically works. That's the adaptation of it. That's the way that it's kept sort of all mammals continuing to be on Earth, is this system allows us to be aware of danger and respond appropriately to danger so that we can continue to survive as a species. This is a function that we share with all mammals. Not all of our brain is shared with all of the other mammals, but the HPA is, which is why they can do research on animals, and that we know that there's a lot that we can learn from that. When the HPA axis, or our limbic system, different people might refer to it as different things, but when that sort of stress response or the threat receptors are activated, we typically do a couple of things. We fight, right? We get ready to attack whatever it is that's threatening us. We run away, we flee, we get as far away from it as we can, or we freeze. We shut down and hope that it thinks we're dead and it leaves us alone. What we know, though, is when you stay sort of in a chronic activated state, which we are kind of all in, right? Then that fight response turns into things like anxiety and irritability. It turns into aggression and overeating and impulsivity. When that flight response is activated and we stay in there, not just long enough to get away from this short-term danger, but we stay in it for a prolonged period of time, then what we start to see are things like withdrawal and isolation and avoidance and depression and loneliness. And when our freeze mechanism kicks in and we stay stuck there, we start to depersonalize, we start to feel shut down, disconnected, we can have memory loss, we avoid interaction, and we can start to feel numb. And I think if we look back, I don't know if I can go back successfully. No. I did it. If we look at this, we start to see this line up with some of those mental health conditions that we're starting to see on the rise. We're seeing the eating disorders, we're seeing the sleep disorders, we're seeing the mood disorders, the anxiety and the depression. And it fits with this. And we're seeing people having great difficulties with concentration and finishing things and focusing on things. And stress, like the video said, isn't bad. Under typical situations, stress is good. It compels us to be prepared. It gives us that extra boost of adrenaline so we can win the race, so we can take the math exam. And it gives us a sense of accomplishment when we're finished it. So we've done something difficult, we've done something hard, and we feel good about ourselves. But we're not really in regular stress right now. We're not in a regular stress experience right now. We're in what we might call tolerable or toxic, and where this ends up falling, I don't know that we know yet. Tolerable stress is stress that is prolonged, it's more difficult, we have to adapt to it. It previously might have been something like a death or a loss that we had to get used to, we had to learn to live with. But what helped us was the support that we had around us. Toxic stress is the stuff we've known for a long time, and doctors talk all about it. You know, stress is dangerous, reduce your stress, reduce your stress. It's because it keeps that HPA system, that axis, activated. And it becomes toxic when we don't have the support systems around us to help us. Other kinds of things that we know are toxic stress, that there's tons of research on, are things like war. So we know the impact of war on people, and it's not particularly good. Community violence, child abuse, domestic violence, poverty, racism. Those are things that we understand in psychology as being chronic stress experiences that keep that HPA axis activated, that keep somebody in that fight or flight mode all the time. And I suspect that we will look back and we will realize that COVID was a very chronic stress experience for all of us. And what we've been noticing is that this is a typical system, right? If it was just a bear attacking me, if it was just somebody busting in my front door of my house, then my brain would detect the threat, that system would activate, it would pump out all those hormones, the cortisol and the adrenaline. I would see the danger, I would take some action, I'd run away, I'd fight them off, I'd I'd get some help, and then it would all be over. I'd be safe, and then I would go, and I would calm down. And my system would reset, and my system would regulate, and then I would carry on. But what's happening with COVID and what's been happening is this cycle has been nonstop. And in the very early years, well, I guess it's been 2 years now, in the very, very early months, we were glued to press conferences and number counts, and I feel a little bit like we're back there again, right? You get that little update and it tells you 5 more cases, and you kind of take a gasp, and you can just sense that this thing is happening in your brain again. And you feel scared, and you feel like restless, like you want to do something. And this has been happening over and over and over again for the last 18 months. And so what are some of the long-term implications for this when this system or this cycle is stuck? The video told us that when we're having this massive stress response, that our amygdala gets enlarged, and we actually start to perceive more fear than there really is. We start to see things as more threatening than they maybe are, right? So we have this heightened sense of fear, and I think we can see that in our community. People are very afraid. People are afraid of one another. People are afraid of all kinds of things. We see children very afraid. We also then have what's sort of this stuck stress response, which means we don't ever get to that regulation and modulation point. We're just always sort of elevated. It makes sleeping very difficult. It makes eating very comforting. And so we see it connected to those diagnostic increases that we talked about at the beginning. When our cortisol and our adrenaline continues to climb, it feels a little bit like that alarm system's going off in our brain all the time. And if you imagine the fire alarm in your building, and the fire alarm in our building is very loud, but if you imagine that going off all the time, it would really kind of take its toll on your body, on your mental health, on your ability to think and focus. The results of prolonged elevation of cortisol, weight gain, acne, flushed face, slowed healing. So when we're facing a global pandemic, to be really stressed is the worst thing we want, because we want to be able to heal quickly. We want our body and our immune system robust if and when we get COVID. But what's really relevant, I think, for those of us in the mental health community and for families or for communities is that it leads to increased irritability, difficulty concentrating, headaches. And I think we've become a pretty irritable group of people lately. And there seems to be incredibly rapidly increasing aggression and division and confrontation. And I don't think that this is any surprise given what we are understanding is going on from a neurochemical perspective. So how do we manage this? What do we do about it? We could just wait this out. I don't like that option because I suspect this was going to be a while, and I don't suspect that it's a waiting until it's over. I suspect this is an adapting to a new normal. And so what we have to do is we have to learn to buffer our mental health. We have to learn to sort of bolster it and create a bit more protection for it. And I think the biggest thing that we have to do is that we have to be able to tell the difference between our fears and the threat. And if we know that that part of our brain that detects threat, that's activated and it's enlarged right now, and so it's easy to understand why we can be so fearful. But if we're going to be able to reduce our cortisol levels and manage our mental health, then we're going to have to be able to help us, ourselves, those people around us, and particularly the children in our lives, to be able to manage their fears related to this. So what's the difference between a fear and a threat? And I work with a lot of kids that have anxiety disorders, and pre-COVID did a lot of work with families around this topic. And we know that a fear is a response triggered by our brain when it perceives danger, when it perceives a threat, and that under typical circumstances, this is great, right? So you see a dog running at you and your brain says, this is dangerous, and so you scoop up your kid and you move him out of the dog's way, and then the dog runs past and then you carry on with your walk. The threat is the genuine degree of danger in which we're in. And this is difficult because if you're not a scientist, an infectious disease expert, it's been a bit tricky for the average person to really assess what the threat is, right? You turn on one channel and it's a terrible threat, you turn on another channel and it's no big deal. And so we're struggling to be able to really understand what the threat is. But what I know we have to do when we're thinking about managing this anxiety is we have to be able to validate and support the fears that we're all having, but we have to be able to act according to the threat that we are really under. And if we took, for example, and applied this to mental health counseling, if somebody was coming to see me and they had a fear of flying, we would validate that fear. I wouldn't tell them that fear was ridiculous and unnecessary, right? I would validate that fear, but I would also help them work through a series of changes in their thinking to understand that although there are some dangers to flying, it's actually really safe. Now that works well with flying. It doesn't work so well when the meter stick of how we assess the threat continues to change. But it's being able to tell the difference. And I think when I look at this cycle again, this is the kind of cycle we're going to have to stay living in for a while. There's going to be continued threat. And I think we're starting to feel economic threat, and we're starting to feel community division threat. That alarm system is going to be the same. That's our neurological system, and that's not changing. We're going to have to start learning how to pay attention differently. Before, we were sensing the danger and we were acting on it, whereas now we're going to have to learn to assess it for ourselves, to identify this fear that's triggered in my brain. I get it. Is the threat there? What is the threat level, and how do I act in accordance with that threat? What kind of action do I need to take? And we've got to be able to increase our ability to regulate and modulate. And I know for myself, when we were in the full lockdown, we were taking full advantage of that 1 hour of outdoor time. And I know for many, many people, they said, oh my gosh, ever since that ended, I haven't gone for a walk on the beach. And I was at the beach the other Sunday, and I was amazed that it was empty. We have the greatest anxiety management tool available to us on our beaches. What strikes me about the video as well was the little part about the nurturance from the attentive, nurturing mom versus the non-attentive or non-nurturing mom. And what we know is that nurturing stabilizes stress in our brain and builds resiliency. I know we talk a lot about how do we build resilient children. We build resilient children by supporting them when they go through difficult things. Oxytocin levels, when they increase, they neutralize cortisol levels in our brain. And so we need to be thinking about all the ways in which we can increase oxytocin so that we can decrease or neutralize the cortisol. We know that oxytocin promotes healing, which is good when we're in a pandemic that could make us sick. And it also stimulates positive social interactions, which, if you've been on social media lately, I think we could all use. Oxytocin neutralizes the effects of stress in our brain. And so how many people know things that you can do to increase your oxytocin? Not very many people. Oh, that's very small. So childbirth probably results in the highest levels of oxytocin in our brain. And so that's probably one we're not all going to run out and do. Right? Lactation also, so does orgasm. So we know that these things that give us a great deal of pleasure, you have that new baby in your arms and you have this enormous amount of joy and your whole body floods with hopefulness and calmness. That's oxytocin in our brains. There's a lot of research related to oxytocin and attachment, oxytocin related to bonding with babies. We also know, I can't read that. Now I know why people were saying they couldn't read their slide. We also know that sensory stimulation releases oxytocin, right? So we know that touch and warmth can make us feel calm, right? You go to get a massage and you feel good. Somebody gives you a back rub and it feels nice. It's relaxing, because when our skin is stimulated, it can increase that. So we want to be making sure that these are the kind of things that we're working into our daily lives. Food, unfortunately, also releases great amounts of oxytocin, and so it can be a bit of a double-edged sword for us. So we have to be careful, right? We eat a pie and we feel lovely, right? We know that things like positive social interaction, spending time with the people that we love and care for, also increases oxytocin. And through this pandemic, we've isolated ourselves, right? We've had things like mandatory quarantines, which are good, but have nonetheless caused a lot of our difficulties. We've had families who haven't been able to see each other in over 2 years. We've had children who haven't seen grandparents. We've had a disconnect from those people that we might otherwise rely on during times of difficult stress. And also psychotherapy, space in which there is an exchange of support or a receiving of support, of kindness, of unconditional positive regard, of warmth and validation. They've done a lot of research that shows that oxytocin levels are higher after somebody attends a therapy session. And sometimes people will say, you know, I don't even know why therapy is helping, but I feel better. Because there's something about being supported that releases oxytocin in our brains. There's something about being listened to. There's something about being attended to fully, to have somebody's full attention on you and what it is that you're thinking and feeling and saying in that moment. It releases oxytocin in our brain, and it can bring down our cortisol levels. So the effects of increased oxytocin are elevated mood, relaxation, improved sleep, increased trust, promoted attachment and caregiving, overall increases in psychological well-being, reduced substance cravings, and also improved social skills. And so I think we all need a dose of oxytocin. So when we compare this to the things that cortisol does to us, we've got to be able to, because we can't do anything about the pandemic that's out there. We can get vaccinated, but we can't do anything about what's happening unless we're in charge of those sorts of things. But what we can do is we can make sure that we are engaging in those behaviors that increase our oxytocin, and we're managing those things that are going to increase our cortisol. So some of the ways that we can support our brain, and why I think this is so important, is the part about the epigenetic implications. What we know now through the science of epigenetics is that we can have the expression of certain aspects of our genetic makeup can be altered as a result of an interaction with environmental stressors. And that can get passed down and inherited to our children. And so I think that there will be research in many, many, many years to come looking at what epigenetic changes happened as a result of COVID-19. I'd like to be that little kind of, there's that island where they say they don't have any heart disease. I would like to think that we could be that place where, you know, we don't see these long-term epigenetic changes, but we're gonna have to make some big changes quickly. Some of the ways that we can do this is we can stop and pause and breathe and reflect, and I think that's the theme of the conference today. We can connect with others. I know it's easy to work. It's easy to stay busy. There's a lot to be done always. But taking the time to connect with others is really important. We need to maintain healthy routines. We need to be showing kindness to one another, because it's what I can do for myself, but it's also what I can do for you. This is one thing where we can actually really help each other. We can engage our sensory system. This means smelling and touching and walking on the beach with bare feet and smelling the salt air and swimming in the ocean. We can go to the beach. We can exercise and we can meditate. We can get and give massages. I love to get them though. We can get good sleep. Sleep is really important. Sleep is highly disrupted right now. And so finding ways, talking with your physician, talking to a counselor, figuring out ways to increase your sleep or improve your sleep is going to be really important. and you can seek support. And how do we do this for our children? And I think this is really, really important. We can practice patience and presence. Lots of kids that come to see me tell me that their parents don't listen to them. And I know their parents listen to them. But they probably listen to them the way I often listen to my own children, which is half with my eye on my phone, half watching the TV, and half listening to what they're saying. So similar to the effect of a counseling session where somebody is fully attended to, we need to be fully attentive to our kids. And I know sometimes we feel bad and we got to rush around and go to work, but make the most of the time that you have with them because their brains really, really need that right now. And if you think about what you could be doing for them, that's what you could be doing for them. There needs to be lots of touch and cuddles and back rubs and lotion, all those things that are going to give them that sensory stimulation, all those things that are going to release the oxytocin in their brains. We need for them to connect with their friends. We need for them to be in school. We need for them to be doing their sports and their activities. We need to let them see us being kind to one another. And we also need to let them see us practicing this balance between what it is that we're feeling in terms of our fear and what the threat really is. And so we have to allow ourselves to feel fear, but we have to be able to behave in a way that is aligned with the threat. We need to let them exercise, do all those good things, and we need to be helping them to sleep, supporting their fears, but acting based on the threat. And so I'm hearing kids afraid to leave the house. There's no danger in leaving the house. So we can remind them that it's okay to feel that, but that there is nothing scary about going outside. And we can remind them that although it might be scary that mom's got to go to work, mom's taking whatever precaution she needs to make, and mom's safe at work. Because our kids are sensing this, we also know there's a huge connection between these systems of children and their parents. And anxious parents often have anxious children, and so managing this for ourselves is an important thing for our kids. And I think if I had to write you a prescription, it's going to be a larger dose of Cayman Kind. I think we've understood today that there is this neurochemical thing that's going on that we can't do anything about in terms of the cortisol being released, but what we can do is mitigate or buffer the impact of it. I also think it's important that we are following the science and that we are listening to those people who can guide us and give us factual information related to the threat so that we can manage our fears, so that we can act accordingly. Because where anxiety really grows is when we are behaving in a way that is different than the threat that really exists. We have threat all around us, and yet we still do things. We drive in cars, and people die in car accidents. We swim in pools, and people die in pools. And I'm not suggesting that we be negligent. I'm not suggesting that we don't follow guidelines. But I'm saying if we're following the guidelines, we're taking the precautions, then we need to be behaving in a way that replicates the threat that exists. And we need to let our kids see us doing that. Thank you very much.
Thanks, Shannon. I'm not sure if there's anyone in the room with any questions, but I do have a couple. So we've heard in a few different presentations, and we've all observed that increased screen time is becoming an issue for our young people. How do we strike a balance, especially when the schools are using more and more of technology and screen time in their learning and teaching methods?
I think that's a really good question. I think that's a really tough question. Obviously, during the lockdown, and some of our schools are back online now, I know, it's very difficult. It means that if they would typically have had recreational screen time after school, then maybe we're replacing the recreational screen time with other type of recreational activities because we're recognizing that they've had their screen time during the school day. I think it's also tricky because a lot of kids connect to each other on social media, they connect online, they game together, and that's their way of support. So I think if your kids are old enough to have conversations about it, to be engaging them in terms of what might be a healthy amount, but also watching for their behavior. I always think we know when our kids aren't doing well by how they're behaving, right? And if they're irritable, or if we see that they're not sleeping, or if we see that their eating is different, then we need to be making some changes. And I know sometimes we don't want to have the fights or deal with the repercussions, but these are times where we need to be making those decisions because we know what the implications are. And so an unhappy kid today because they couldn't game all night, I'm okay with that, right? When we think about what's at stake in terms of their brain, we think about what we saw in the video in terms of learning, long-term learning, the size of the brain changing, right? So an unhappy kid all of a sudden seems a little bit more acceptable.
Thanks for that. No, not just the children. We struggle with it. Going back to the shift to working from home that we did last year, to what extent have you seen the issue of people having problems disengaging, particularly when they're forced to work from home or have the option to work from home, and any tips that you could give to try to manage with that?
I think that was a huge contributor to a lot of the anxiety and sleep difficulties we were seeing early on, because it was so easy that the minute your eyes opened up, you could be at work. You didn't have to get dressed, you didn't have to have a shower, you didn't have to sit in traffic, you were there immediately. And I spoke to a lot of people early on during the lockdown that were finding that very, very difficult. And so if space allowed, you could set up a room that was a work room and have some time limits where you left work and went into the rest of your house. Not everybody had that. So some people I know were doing things like putting a cover over their work laptop to sort of signal the end of the workday. It was hard though, because it was so easy to just go on there and check one more email. And the reality is we walk around with our work computers often in our hands. And so we don't even need to turn the laptop on to be engaged. I think it's recognizing that we're in the long game, right? Like, this is not until the pandemic is over. This is not until it's finished. This is now, we're starting to realize this is needing to be a new shift in preserving our mental health. So we're really in, I think, a state of trying to figure out what is it that I do to preserve it and to build some resiliency that allows me to cope with however long this continues. And so the work stuff becomes tricky. I think talking to your partners, if you've got, to make sure that there's some designated meal times, to make sure at least when we're eating, we're off our devices, that we're getting outside for at least an hour every night, that we're gonna go for a walk around the block. There's a lot of mosquitoes right now, but we're gonna do something that gets us physically moving, whether it's just a video in the living room. So I think putting those things that we know help, right? Getting outside, doing some baking, playing a board game, setting some kind of scheduled time that allows us to take a break.
Early in your presentation, you showed some statistics with increased uptake of people seeking mental health support. To what extent do you see this being just an increasing people needing the service and people paying more attention to their mental wellness?
I think it's probably a little bit of both. I think people are feeling increased difficulties. I think people who have never had mental health difficulties are having mental health difficulties. And I think people who have had mental health difficulties are having exacerbated difficulties. And so I think we see clients needing increased levels of care, which is accounting for the increase in uptake, but we're also seeing people who previously maybe managed their stress or their mental health through travel, through doing something that they really enjoyed doing, through getting together with some of their friends once a year. We all have those things that we can do, and those things for many people have not been accessible. And so we start to have a bit of a cumulative effect. We can all kind of hang in there, right, until that thing that allows us to kind of rejuvenate and reset and regulate. But if that thing hasn't happened, we have to stop waiting for it, and we have to start doing small things on a daily basis.
Thank you very much. Is there anyone in the room with a question? So we have a question right here. And in case anybody else is thinking, we'll have room for one more question after this.
I have two-ish.
Go ahead.
The first is just, and it sounds silly, but it's kind of serious. So in the same way that our body produces melatonin and there's also a pill for it, is there oxytocin in a pill? I know there's an injection for childbirth. That's not what I'm looking for right now.
Oh, that'd be a good question for the doctors in the room, if there's oxytocin in a pill. Okay.
Oh, I'm glad they're working on it.
Yeah.
Okay. All right. So not right now. Have to think of something else.
Okay, what I'll do, I will visit this gentleman as there are people at home who may be having trouble following along. If you could just repeat.
No, I just wanted to say that oxytocin is a peptide, so it's simply digested by our body when we ingest it. As Dr. Awasthi said,
they're making these peptidomimetic drugs that can actually be absorbed orally, and they appear to have anti-cancer properties. So a side effect may be that we can all start taking oxytocin for mental health.
I'll look forward to that. My next question is about the rat or the mouse, whichever it was, the mother, and her ignoring her child, essentially having effects later on in generations.
Yes.
Am I understanding that in that if, say, for example, my parents had some sort of childhood traumas, that I could, in my DNA, be absorbing some of that? Is that basically...
absolutely. Yeah, and if the science is becoming very clear if we look at some of the studies that are coming out related to Holocaust survivors. If we're looking at descendants of slaves and things like the post-traumatic slave syndrome work that's going on. So there's some of the indigenous research that's coming out of Canada in terms of intergenerational trauma, right? And so we know that we pass trauma through our DNA, and so we can see the offspring of people that have had severe, long, prolonged trauma have less ability to cope with the stress of life at that point. And so some of the original research that was done on Holocaust survivors showed that even 3 and 4 generations, having never experienced any of their own first-generation trauma, had higher anxiety disorders and eating disorders and things like that. So it's pretty remarkable.
Well, yeah, but how do you treat that? Because it's one thing for me to go to a counselor for my own problems that I know are mine or my own traumas, but I don't know. I might know vaguely that my mother was physically abused, for example, but how do I exorcise that from my soul?
I think that it's about an understanding of vulnerabilities for mental health problems. And just like we know that we have medical vulnerabilities, we know that if you've got a parent with breast cancer, you are more vulnerable. So you take good care. You start your preventative measures early. You start your screening and surveillance earlier. So if we know that this is what happens when people experience trauma, that it actually changes our brain, it changes our brain's ability to cope with stress, it increases our risk of mental health problems, then what we understand is that we have to buffer and support ourselves even more. And so we have to be very proactive. And I think it speaks to Dr. Watkins' stuff about some of our more vulnerable children who live in way more adverse communities, and they face adverse challenges, and many of those challenges have been generational. And how do we support those communities?
Do we have any more questions from the floor? Okay, so we have one here and then one more.
Okay, so yesterday, several persons made mention of spiritual health. And in your presentation, it reminds me of a forum I was on, I think about a week or so ago, where the speaker spoke about faith-based responses versus fear-based responses. And the unfortunate truth is a lot of persons are responding to the situation from a fear-based perspective. And I'm like, I probably need to do better as a minister of religion as it relates to helping people to respond from a faith-based perspective. And, but in terms of accessing services, mental health services, I think it was several conferences ago I made a similar, or asked a similar question in terms of access to service. And the unfortunate truth of it, with so many more persons needing this service that cannot access it, I'm very concerned. Because as much as, I mean, I love the fact, I would love to do neurofeedback that Infinite Mind Care is offering, but I can't afford it. I would love to do that, you know, and the other services that are very needed right now. I'm concerned of the certain demographics in our community that cannot access these services that we know that they need it.
Yeah, and I think we share your concern, Sylvia, because we know that right now there is no legislative outpatient mental health coverage in our insurance laws. And so insurance companies don't have to provide coverage for outpatient mental health coverage. And they mandated inpatient mental health coverage a couple of years ago, but they left off outpatient mental health. And so the majority of people have a health insurance policy that is extremely expensive, that provides $1,000 US a year. And the standard health insurance fees, the basic SHIC plan doesn't provide any. And so there's a lot of people that don't have it, and are more vulnerable people that might be working in roles and in jobs where they're not going to have big fancy insurance policies, are going to be those that are going to have the most difficult time accessing. Yeah. And so it's adversity layered on top of adversity.
Not to mention those that don't have insurance coverage at all.
Yes, exactly.
But my comment really was, it's a comment, it's not really a question. Just following on from what Ben said about, you know, we worry about the children with the screen time and the adults not being able to switch off because they're working remotely, and as soon as you open your eyes, you're on your work computer and so forth. But I just wanted to comment on the danger of adults having too much screen time as well. And I don't mean working remotely. I mean watching the news for hours on end, and it's all about COVID, the number of cases, the number of hospitalizations, the number of deaths, spending hours online doing their own research, you know, on social media, clicking on link after link after link, going down this rabbit hole with lots of information, staying up until 2, 3 o'clock in the morning reading about this. And it is definitely driving a lot of the anxiety. If it's not anxiety about COVID, it's anxiety about the vaccines. And it just seems like an endless cycle.
And if we could go back to that cycle that I had up, that graphic that had the threat and the activation of our stress response system, and then our attention. And so if you hear a bang in the night, all of your sensory system goes on alert, and you try to figure out what that bang was, right? You hear glass break, and all of a sudden, you're listening very attentively, you're still, because you're trying to figure out through your sensory system what that threat is. And so what's happened is that COVID hit, and our brain is doing the same thing. It's trying to understand what the threat is through our sensory system, listening to things, watching things, paying attention to things. And so we've seen this excessive consumption of information, I think, as part of that. And because it's changed so rapidly, because it was this and then it was that, because it was this brand new virus that people didn't know. And so there's been a constant stream of information, many of it relevant, lots of it helpful and important, but it hasn't let up. And so we have to be very intentional in that intention. And it's balancing what we're going to give our attention to and deciding how much is enough, who am I going to take my information from, and then being able to kind of let go of the rest, because you're absolutely right. That's a very good point.
Thank you very much. We could give it up to Shannon Seymour of the Wellness Center. not only a speaker, but also a supporter and sponsor of this annual conference. Now, we can move forward with the program. The presentations, not just this one, have been very enlightening. The issues being discussed have been very compelling. We're not finished yet. We're nearly there for the day. I do have the pleasure of introducing our final presenter for the day, Jerry Flavell, medical herbalist from Embodied Holistic Health. Jerry will be presenting on the holistic perspectives on breathing more freely. She's joining via Zoom, so let's welcome her for her session on focus on breath and quality of life. Welcome, Jerry.
Thank you very much. I'm grateful to be here. I'm indeed via Zoom. I'm in London. It's a bit late, but that has offered me an opportunity to listen to some of the presentations. And it's wonderful to hear some of the information, because I think that we are all aware of the multi-dimensional aspect of our wellness. So I come from a perspective of preventative medicine and holistic health. I am a medical herbalist and a practitioner, as well as teacher of complementary alternative modalities. I'm very grateful to be here and to share what I continue to study and what I practice and what I'm passionate about. I hope that we can continue to bridge this healthcare discussion and empower people to develop greater awareness and recognize their own responsibility for well-being. The first slide, Adam, please. So the first slide that I have included is a slide on some very simple chair yoga practices. I would like to note that the slides that I've included will not be synchronized with what I'm speaking about, because I was very interested in sharing as much as I could. A lot of these practices are practices that you can do anywhere, anytime. And a lot of the herbalism that I will be sharing is based on plants that are readily accessible in the grocery store, in your home. So these are remedies that are time-tested and traditional. And so the slides will come along to share information, but I'll be moving through them and you can record them if you like. Firstly, the chair yoga. I encourage you to try some of these during the lectures. Don't be self-conscious. I would like for you to incorporate them into your daily lives and to share them for greater respiratory health. We're also going to start with a couple of minutes of a breath practice. Some incorporation of deep diaphragmatic breathing so that you can combine that with chair yoga and truly shift your state of mind and body. So if you will, please join me wherever you are. Find a comfortable seated position, a tall spine. Sit on your sits bones, those two bony protuberances at the base of the pelvis, ischial tuberosity. And you want to lengthen up through the crown of your head. Soften your gaze. Either close your eyes or allow the lids of the eyes to be soft and focus on the tip of the nose or the floor just beyond your feet. Feet are flat on the floor. And with the eyes soft, just start to recognize your own pattern of breath. Recognize the volume and the rate and the texture. And see if you can recognize a natural downward and grounding movement on inhalation and a natural lifting and extensive sensation on exhalation. Bring your hand to your lower abdomen. And on your next inhale, breathe in for 4 into the lower abdomen. And as you exhale, draw the abdomen in and breathe out for 5. Again, breathing in for 4. And breathing out for 5, feeling the internal spine lift. Again, in for 4, moving your lower back toward the middle of the body. Breathing out for 5, drawing your ears back. And this time, as you inhale, breathing into the lower abdomen, imagine the rib cage opening like an umbrella. And as you exhale, draw the lower abdomen in and lower the umbrella. One more, in for 4. Open the umbrella. Out for 5. Just notice the calm, centered sensation, and notice the rhythm of your breath. You can softly blink your eyes open. And as you practice some of the postures, try to incorporate that pace of breath, that recognition of deep diaphragmatic breathing. Holistic healthcare looks at the whole person, their experience, their history, and their current state of health, as can be seen through visual appearance, gestures, and discussion of concerns. Holistic care involves treating the whole person instead of focusing on an illness or a diagnosis. Holistic practices consider the physiological, psychological, cultural, and spiritual aspects of a person to administer appropriate patient-centered treatment. Adherents of holistic practice recognize that the whole system is greater than its parts. A person is complex and influenced by physical, emotional, and social factors. Holistic care understands the need to treat symptoms. However, it stresses the importance of addressing the root cause and the underlying influences that contribute to those symptoms. Because disease and dysfunction can negatively impact a patient's entire world, healthcare providers must address the entirety of the patient when recommending any protocol to truly promote health and well-being. Traditional Chinese medicine, or TCM, consider all parts works together and seeks to understand a root of imbalance. Herbalism, as well as TCM and other traditional therapies, are used to treat all illness, but considered best used as preventative and work well as an adjunct to Western medicine. I use the TCM approach of energetics to look at patterns in health and personal history. The language of energetics includes an appreciation and application of the Chinese philosophy of yin and yang. The dual relationship of yin and yang demonstrates that everything in the universe is connected and complementary, yet opposite. We use terms to identify symptom expression, such as hot and cold, damp and dry, interior and exterior. Given our current worldwide challenges, the level of stress for many has been unprecedented. The concerns about COVID go beyond respiratory health and resilience, and they affect the mind, the emotion, home and work environment, all of our relations, family, friends, community, and the natural world. We have had to separate and isolate and mask up. These experiences challenge one's ability to rebound from a stressful experience because there's no end in sight. The stress is inflammatory, and it will affect the ability to digest and assimilate, sleep, respond to a challenge, and it weakens our response to infection. The fight or flight response has been triggered, and we often forget that it is an exercise and a skilled practice not to react. We must routinely find our breath. The blood may be the fluid of life, but it exists for the transport of oxygen. So the breath and the lungs are integral not only to life, but to quality of life. In order to breathe easier, we must consider, how has the breath been compromised? What are the potential considerations of contribution, and how can we reduce their influence and increase capacity and resilience? Herbalists recognize the efficacy of plants and their therapeutic applications. The traditional knowledge has been anecdotally shared since before recorded time. The gold standard of scientific analysis has contributed to this knowledge, and the library of evidence-based information continues to grow. In fact, herbal medicine is the source of many conventional medicines, and plants continue to be studied for their application in many diseases as both curative and preventative. According to the World Health Organization, 75% of the world's populations are using herbs for basic healthcare needs. Autumn is the peak of cold and flu season, and this is the perfect opportunity to incorporate preventative healthcare practices as well as traditional remedies you may remember. So much of what I share with you may sound commonsensical, but it may be because you've heard it before or because you've experienced it. Herbalists also recognize that environments and lifestyles enhance or diminish overall well-being. Interactions with healthy environments help to create our resilience. The UN Sustainable Development Goals record that planetary health is defined as the health of human civilization and the state of the natural systems on which it depends. Planetary health and human health are interconnected, so we must consider all of our environments. Herbalists seek to bring awareness to habits and conditioning that have contributed to the current state of health. By bringing these matters to conscious attention, a person will have an opportunity to change their experience. No amount of herbal protocol will alter a state of health when lifestyle and diet are recognized as a source of imbalance or disease, and these factors remain unaltered. That said, there are thousands of herbal combinations that can help the body's own innate healing mechanisms. Herbs are safe and, when used with care, have no side effects. There are contraindications with pharmacological medication, and we look to avoid any of these incompatibilities. Can I have the second slide, please, Adam? The second slide is the lung meridian, which extends from the outer thumb pad along the inner arm up to the clavicle. So this is another opportunity for you to experience in your own body how you can shift your physiology. You find the lung point just under the clavicle, and you can either lightly hold your fingers or you can tap. And I encourage you, while you do this, to soften the eyes, to turn the attention inward and sense a shift in your breath. In traditional Chinese medicine, the lungs are known as the tender organs. They are the only internal organ open to the exterior, open to the outside world. They are subject to external pernicious influences. They're exposed to heat and cold, dampness, dryness, wind, bacterium, viruses, particulates, mold, etc. They are also affected by the conditions of the mind and the body. So when treating respiratory conditions, we look to be specific. Treating with remedies that have energetics and therapeutic actions mirroring the symptoms can aggravate the situation and often drive it deeper. The discussion of holistic health is not linear. It is a web of interconnectedness, How to address a concern and consider the entire experience in order to reach optimal health requires a client's full health history, and it's a story that requires time to recall and time to understand. Given the daily assault of pollutants from fossil fuels, herbicides, pesticides, stress, molds, home and office offset gases, the lungs are best supported with preventative measures and practices that will increase capacity and efficiency. So become aware of pollutants and where they can be found. The home environment is now likely a place where most of an individual's time is spent. The products we use to clean and decorate our homes can sometimes contain chemicals called volatile organic compounds, or VOCs. It's a good idea to avoid breathing in VOCs, as well as products that contain bleach or ammonia. Products containing VOCs, particularly those in sprays, can cause irritation to your lungs and may increase your risks of developing allergies or asthma. If you live with a lung condition, your airways are likely to be irritated. VOCs are not always clearly labeled on cleaning products, so it's best to look for chemical-free or allergy-friendly products. VOCs are found in products like washing detergents, furniture polish, air fresheners, candles, decorative substances, deodorants, perfumes, carpet cleaners, pesticides, fungicides, paints, paint strippers, varnishes, and glues. Some of these products will have a globe symbol on the packaging to tell you what level of VOC is in the product. Phenols and phthalates are ubiquitous. They are plasticizers. They are found in fabrics, pillows, perfumes, preservatives, sunscreens, and self-care products. They are known to be linked to a long list of healthcare concerns, including respiratory distress and asthma. Studies have now shown how prevalent these chemicals can be in utero, affecting the postnatal respiratory health of children. It's almost impossible to eliminate phthalates in one's environment, but it is possible to minimize exposure. A company called Silent Spring has developed an app with research-based tips to help you minimize your exposure in your home or your work. Go to silentspring.org/detox. Do you have me? Okay, would you like me to go back? Did you get that? Okay, Silent Spring is the company, and the app is silentspring.org/detoxme. Recycled air or air conditioning allows us to have a much more comfortable environment, but it can also harbor pathogens. So checking for standing water in the cooling system and replacing filters should often be a part of your maintenance calendar. Taking a break from recycled air and venturing out into nature, deep, full breaths outside can help the lungs to eliminate congestion and microbes. And of course, in green spaces, enhance oxygen uptake. When in your home or your office or your car, consider any hidden hazards like asbestos, probably not in your car, fiberglass, probably not in your car, any off-gassing from that new car smell or paint fumes or stored fuels. Open the windows and air out the home often. Mold is common in our environment due to the heat and the presence of high humidity. It is also a reason that mold species find our lungs to be a perfect environment. Outdoors, molds live in soil, on plants, and on dead and decaying matter. Different mold species can adapt to different moisture conditions. And research has shown us that exposures to building dampness and mold have been associated with respiratory symptoms, asthma, hypersensitivity pneumonitis, rhinosinusitis, bronchitis, and respiratory infections. Particular mycotoxins are also known to be neurotoxins and can contribute to an array of biochemical, morphological, behavioral, physiological abnormalities whose onset can vary from immediate to delayed actions following exposure. The duration of effects may be transient or persistent and results in disability in some individuals, while some may have life-threatening consequences. This is particularly important for those persons who have lived through hurricanes, notably Hurricane Ivan that decimated much of our island. Many people were exposed to molds for a long period of time, and it's likely that some still live with it today. Individuals with asthma or hypersensitivity pneumonitis might be at risk for progression to more severe disease if the relationship between illness and exposure to particular toxins is not recognized and amended. Moisture also provides a favorable environment for cockroaches, rodents, and dust mites. Simple household dust can lead to upper respiratory distress, sneezing, coughing, eye irritation. Repeated and prolonged exposure can lead to lung tissue swelling, asthma, and throat infections. Moreover, the symptoms associated with impaired lung function may lead to occupational lung disease. Adam, can you bring up the next slide, please? The next slide is one of my favorite formulas that I make for my family called fire cider. This is a traditional herbal remedy for most ailments that are respiratory. We use this as both a tonic and as a remedy, 1 teaspoon a day as a tonic and 1 teaspoon every hour as a remedy. There are constituents that are antiviral in action, antimicrobial, antifungal, anti-inflammatory. They are circulatory stimulants and basically boost the immune response. Pet dander can cause symptoms similar to allergy or asthma. The ENT Institute of America also cites that exposure to pet dander can lead to a decline in lung function. Dander will lodge in carpets, bedding, and furniture. HEPA filtration can help, frequent vacuuming as well, but the fewer surfaces for the dander to hide, the better. Pollution and particulates we inhale can be microscopic and lodge in different regions of the respiratory tract. Exposure to particulates can induce either local or systemic inflammatory responses as it triggers immunological response. Major emission sources include car exhaust, fossil fuel emissions, pesticides, and herbicides. While the very young are at risk, so are the older who have reduced capacity and accumulative toxicity. Those most vulnerable live in deprived areas, which often have higher levels of air pollution, or they live and learn or work near busy roads, or are more vulnerable due to their age or existing medical conditions. In your work environment, there are the same considerations for toxic exposure and more. Office buildings, schools, and other non-industrialized buildings may develop moisture and dampness problems from roof and window leaks, high indoor humidity, unclean air systems, and flooding events, amongst others. This can lead to the growth of mold, fungi, and bacterium, the release of volatile organic compounds, and also the building materials are affected. Exposures in damp buildings are complex and vary from building to building and at different locations within a building. Moisture allows increased indoor microbial growth on these building materials and can be difficult to locate. If one is managing building materials or dealing with toxic substances that emit gas fumes or dust particles, they may develop respiratory distress. As holistic practitioners, we ask, how many contributors play a role in one's daily exposure? What is the prevalence of pesticides in the home or office or both? Is smoke inhalation a common home or workplace hazard? What is the social environment at home or at work? Stress in the home or workplace contributes to tension in the body and shortness of the breath. What is your posture at work or at home? Are you sitting all day? Rounded posture compromises breathing. Your physical body. During a lifetime, a person breathes about 250 million liters of air. Accumulative toxicity damage occurs over a lifetime, from a baby's first few weeks in utero all the way through the years of older age. What we put in and on our bodies, as well as what we surround ourselves with, will have an impact. Many toxins are lipid soluble, and should one experience acute disease with wasting, that toxicity can hasten decline. Sedentarism reduces the capacity of the lungs and weakens the breathing muscles. It has also been connected to cognitive decline and risk of anxiety over time. Anxiety is linked to hyperventilation and stress markers, and so the loop will continue. Stress and anxiety cause shortness of breath. Tension in the muscular body will reduce the use of breathing muscles, which will exacerbate symptoms and weaken immunity. If we can have the next slide, please, Adam. These next few slides will contain a list of foods that will add to conditions that you may experience. So as Dr. Irka Ebanks discussed earlier today in one of her case studies, someone with respiratory distress having a high intake of milk products. Milk will cause mucosal secretions because the proteins are often seen as allergenic. So the slides will explain certain foods will cause greater dryness or more mucosal secretions. Our bodies are built to move, and one of the greatest support measures for building respiratory health is to move and build deeper capacity by pushing our tidal breath toward vital capacity, the maximum breath capacity. At that boundary line is where growth occurs. I do not advocate for extreme measures which cause stress, but I feel as health practitioners, we should encourage everyone to move toward greater cardiovascular challenge at a monitored pace. I feel we could do wonders for our community if we developed open green spaces to cultivate social interaction and exercise practices. Open green spaces help sequester air pollution and enhance air quality, as well as offer shade to interact and play. We can access the tremendous benefits for outdoor living with fresh sea breezes under the nurturing sun. One of the most beautiful experiences during our first COVID lockdown was the opportunity to ride bicycles with our family. We can all work toward a more vital society. I bring this into discussion because I see so many who run or bike in traffic lanes, seemingly for fitness, though they are likely not aware of the heavy metals they are inhaling. What is your exposure to carcinogens in exhaust and fossil fuels? Particulate matter causes thickening of the airways, leukocyte infiltration, and adhesion to alveoli. This induces local as well as systemic oxidative stress and inflammation. Think for a moment about your occupation. Where do you spend your time? Exposure to cooking oils causes inflammatory responses and oxidative stress. Cayman is known for their extensive culinary offerings. Those providing the opportunity must consider how to manage and reverse the damage. Does one manage volatile chemicals on building sites or in housekeeping positions? Are you working in hospitals or in healthcare settings with sterilizing chemicals? Do you work in a bar or a restaurant that has allowed or does allow smoking? Do you work as a hairstylist using chemicals and sprays for hours each day? We need to consider, how do we spend the hours of our life? What are we exposed to daily? Adam, if you want to cycle through the next slide as well. The mental body. We live in a world where we are linked in, hooked up, and wired 24/7. The stimulation and constant inundation is exhausting. We become conditioned to 20-second attention spans, and we are fed neurogenically by this stimulation. Without it, we sometimes feel lost. We encounter news or images that may stun. Shock and trauma, literally, take the breath away. Fear and anxiety create short breaths. The sympathetic nervous system is responsible for the fight or flight mode in organisms, and it raises heart rate, blood pressure, and indirectly respiration rate. The vagus nerve innervates the lungs, the heart, and the stomach. Deep diaphragmatic breathing helps us to reset and engage parasympathetic nervous system, calming the vagus nerve. We can develop breathing techniques that encourage slowing respiration cycles, shifting to longer exhalations compared to the inhalations, shifting the main locus of respiration from the chest to the abdomen, and paying attention to the natural breathing cycles. Imagine if you were watching a newborn. The belly lifts and falls. Slowing and deepening breathing with emphasis on a long exhalation is dominant across many CAM traditions. There are a few practices that stimulate faster respiration patterns, as in the breath of fire in yoga, which can help detoxification and oxygenation. In the physical active mind-body exercises like yoga or biking or hiking, respiration can be synchronized with movement techniques. Moving with the breath can be a moving meditation, also calming the fluctuations of the mind. How can we refresh and strengthen and enhance our pulmonary capacity? Move and be sensitive to your body's signals. Using the simple stretching techniques and breathing practices can reduce the sensation of tight breathing and encourage deeper diaphragmatic breathing, opening the breathing muscles with simple movements that can be done sitting, standing, or lying down. Side opening, heart lifting, shoulders back, head back, and gentle twists to help reduce tension and stimulate circulation. With the simple belly breathing, as we performed earlier, your hand on your belly, direct the breath into that spot. And notice that the belly moves apart from the ribs. Move the ribs out, not up. Holding the breath between inhalation and exhalation will calm the vagus nerve, or simply taking a moment to recognize the natural pause between inhalation and exhalation. This is a very helpful practice for anxiety or panic attacks. Consider your sleep. How is your sleep? Sleep hygiene should become a practice. No television or electronic device 30 minutes before you sleep. The room should be cool and clean, perhaps a soothing blend of tea. We need to have time to rest and reset and rebuild. Recognize when you're starting to feel like your immunity is compromised. Do you have congestion, runny nose, a tickle in the back of your throat? Do you have a cough? Can you identify if it's a hot or a dry cough, or is it wet with mucus? Do you feel that you have a low-grade fever? This is a sign that your body is working as it should to manage pathogens. Your social body is also an important component. We've known for a long while that interacting with friends and family improved health measures. Laughter is the world's best medicine. Science has proven that the more social roles people engaged in, the better their lung function. The greater number of roles you play will give you the greater number of human interactions and movement. Social isolation is a significant predictor of death. Interpersonal relationships enhance life experience and capacity, another reason for green open spaces. Our diet, whole foods diet. What ingredients are good for the lungs? Health practitioners recognize that 80% of the body's immune system is in the gut. Not only is our immunity supported by the microbiome, but a healthy gut is the key to digestion and assimilation of nutrients. The Mediterranean diet is one healthy alternative with its focus on fresh fruits and vegetables, whole grains, fatty fish, nuts, and oils. The diet gives a lot of nutrients, including A, B2, B6, B12, C, D, and E, which are necessary for both epithelial barriers and cellular immunity. Additionally, it offers zinc, iron, selenium, and other plant-derived minerals. These foods are rich in antioxidants. As per the instruction of the World Health Organization, consume diets rich in fruits and vegetables, buy locally so they're fresh, and these will boost the immune system. Additionally, citrus fruits like orange and lemon, and pomegranate with its high vitamin C content, grapes with resveratrol, as well as nutrient and fiber-rich bananas, apples, root vegetables, turnips, beetroots, and carrots. Leafy greens like bok choy, spinach, kale are also a very rich source of iron, potassium, calcium, and vitamins. These nutrients have anti-inflammatory and antioxidant effects, which can help reduce lung inflammation and promote overall health. So I think if we can move to the last slide, please, Adam. I don't know if you're on the T slide yet. Thank you. So in the fire cider, one of the main components is garlic. Garlic has an ancient reputation as a general universal remedy or a poor man's treacle. It's high in sulfur, which is stimulating and sanative to the entire system, but especially the digestive and respiratory and cardiovascular systems. Garlic possesses a natural antibiotic, meaning that it has antibiotic-like actions. It's used for colds and cough and for general well-being. Garlic also has more specific indications. It's suited for coughs where there is a dryness in the upper bronchioles and where mucus has congealed and dried out. To note, garlic is also a blood thinner, so one needs to be aware if they are taking blood thinning medications. Garlic can also add to that therapeutic behavior action. Propolis, bee propolis, is a resin that bees collect off of the buds of trees. It's used to block holes in the hive. It's a warming stimulant. Propolis has properties in common with balsam poplar, which classifies it as a pulmonary stimulant. Propolis is indicated in acute laryngitis with loss of voice, usually after exposure to dust or mold. It is specific for mold allergies, and it's also suited to hot, raw bronchitis with heat in the chest and coughing and very little expectoration. Onions are a classic remedy. Traditionally, onions were used as a poultice on the chest to bring mucus up and to help expectorate. Drinking onion juice can be a bit off-putting, but you can make your own onion syrup. And you can also use onions in food as well as inhaling the vapors in a steam. The herbal teas that I've brought today are accessible through the grocery market or in marketed teas. Goldenrod is indicated where there is irritation of the mucosa and respiratory tract and there's dryness or shortage of fluids. It's an excellent remedy for allergies where the eyes are red and suffused, watery, or itchy, and the nose is itchy and congested. Also wonderful for chronic sinusitis and bronchitis with yellow expectoration. Chrysanthemum is native to Asia, and it's an important remedy in traditional Chinese medicine. It's also cultivated elsewhere. The flowers are the parts that are used, and they are warm and moistening. So this suggests their use in conditions of cold and dry. Mullein is suited to very dry conditions with a lack of secretion and sharp pain. It exerts a mild influence upon the nervous system, quieting irritation and promoting sleep. Ginger tea is a tremendous home remedy. Lemon, ginger root, and honey might be one of the most popular home remedies for treating a cold, including soothing sore throat and cough. Ginger may help with lowering the body temperature as it's a diaphoretic, thus reducing fever. Fresh ginger root, lemon juice, and honey mixed with water are also very tasty and help to soothe an irritated throat. Avoid large doses of ginger as it may cause some side effects like diarrhea and irritation. Licorice root tea is probably one of my favorites. Licorice root is 50 times sweeter than sugar. The licorice root bark is used. It's not overly sweet. It will have an underlying sweetness and it combines well. There is one brand found in all of the grocery stores in Cayman called Traditional Medicinals, and the tea is called Throat Coat. This is a blend of licorice root, marshmallow root, and slippery elm. I use this and recommend it often, not only for respiratory conditions, but for digestive conditions as well. Chamomile tea is world famous for its soothing and calming properties and helping respiratory problems. Inhaling hot chamomile infusion is still one of the most popular way of treating respiratory problems related to the common cold. Rooibos is a herbal tea made from a South African plant called the red bush, and though not as popular for treating the symptoms of a common cold, this tea is very helpful because it's packed with antioxidants, it's naturally caffeine-free, and it may be soothing for the throat and the cough. One of the benefits of drinking herbal tea is that they are nutrient dense. So this helps us to obtain those minerals that are not only in depleted soils and vegetables, but not in our standard American diet or processed foods. Marshmallow root has a long tradition in home treatments of cough. One German study showed that this traditional medicinal plant has soothing properties and may reduce the irritation caused by dry cough, asthma, bronchitis, and the common cold. You can drink several cups a day. It contains mucilage that will interact with, which is a wonderful prebiotic and stimulates the microbiome. Thyme tea. The component that has been studied with thyme is thymol, and this component has been researched for many, many different kinds of ailments and diseases. Thyme possesses potent antibacterial, antifungal, sedative, antiseptic, antioxidant, expectorant, antispasmodic, antifungal, carminative, and diaphoretic effects. You can drink the tea, but this is also a very, very good herb to use in a steam inhalation. The same with sage tea. Sage has been used for a whole range of respiratory problems, including bronchitis, cough, asthma, angina, mouth and throat inflammations, and it protects the body against oxidative stress, free radical damages, inflammation, and bacterial infections. Echinacea has become a very popular plant in the last few years. Studies show that echinacea's active ingredients are fat-soluble compounds, polybutylamides, and polyacylines. These are well-researched active constituents that have been shown to strongly stimulate various activities of the immune function, such as increased interferon activity and increased killer T cell function. Plantain tea, as Dr. Irka Ebanks brought up earlier today, is not our Caribbean plantain, but it is grown in Europe and Asia and seen as a weed around the world. It's been used for wound healing. It lowers the fever and helps to treat bronchitis because of its soothing properties. Studies have shown that a hot plantain tea may help with viral infections such as malaria and may also help bacterial and fungal infections as well. Peppermint tea is antiviral, antibacterial, and anti-inflammatory. Interesting to note, peppermint tea is both warming and cooling. The effects may help may help with symptoms of a common cold, and research has showed that L-menthol is a compound in peppermint, can be beneficial to treating chronic inflammatory disorders such as bronchial asthma, colitis, and allergic rhinitis. Fennel tea is used around the world, and it's an important part of herbal medicine. It may help with reducing fever and treating a cough. It has anti-inflammatory properties and can help with decongesting the sinuses. Anise tea. Anise is used to replace licorice in many food products. It's added to many tea blends because both of the flavor and the potential benefits. It is used for treating cough and asthma and respiratory infections and may help strengthen the immune system. Practices for respiratory health. We've gone through the breathing and the meridians. I just wanted to note that the meridians allow us to regulate internally. So that meridian line from the thumb pad to the clavicle is a delivery mechanism that allows nutrient and waste removal, both physical and energetic. In the practice, both blood and qi flow freely through the meridians, and when they flow unobstructed, the body is able to maintain a healthy balance. The lung meridian can be found on either arm, and its power is to control respiration and immune function, as well as to move and adjust water channels. Breathing deeply is the fastest way to change your internal chemistry. So deep diaphragmatic breaths, regular practice of reminding yourself, and you can incorporate essential oils and resins, as they can be soothing and anti-inflammatory to the mucosa and even aid in expectoration. In the old days, tuberculosis sanitariums were located in the mountains, in the pine-clad regions where pine resins continually sanitize the lungs. High mountain air has less oxygen, requiring larger breath and thereby exercising the lungs. So using pine essential oils is a bronchodilator. Using essential oils can calm inflamed tissues for pain, as in the case of lavender. They can act as diaphoretics, increasing heat and sweating for detoxification, as in the case with cinnamon, peppermint, and ginger, and as bronchodilators like eucalyptus, clove, and rosemary. And to conclude, I would just like to say that we can focus on reducing overall toxic exposure, taking probiotics and eating fermented foods, eating prebiotic fibers found in fruits and vegetables or psyllium husk, eating less sugar and processed flours and sweeteners, reducing stress, avoiding taking unnecessary antibiotics, exercising regularly, getting enough quality sleep, and laughing often. There you are.
Thank you so very much for that. It's been quite a day, and Jerry, you hit us with some very useful information to bring this day's session to a close. So I want to thank you, not being in the room with us, but that did not take away from the reception of the information that you've provided. So I want to say thank you for that. And with all this talk of healthiness and breathing easy, I want to go outside, and I think this weekend I'm going to do something that I've heard mentioned a few times. I'm going to try to get to the beach. That should help me breathe easier and help with my mental well-being. So thanks, Jerry, and thanks to all of our other speakers and panelists who've been with us today. They've enlightened and empowered us with all that knowledge. I want to thank everyone who's been joining us across the various platforms, CIGTV, CIGTV YouTube channel, and Cayman Compass, their Facebook page. Truly hope this has been a useful day for you, joining us from wherever you are, as well as to our sponsors. We'd like to say a massive thank you. Health City Cayman Islands, Doctors Hospital, Integra Healthcare, Astor Cayman Med City, the Cayman Islands Health Services Authority, Compass Media, Kelly Holding Events and Communications, DART, Baptist Health International, Infinite Mind Care, Cineco, and the Wellness Center. Once again, thank you, thank you, thank you. Ladies and gentlemen, it's been a long day, but it has certainly been worth it. So here's hoping you have a good evening, and God's willing, we'll see you tomorrow morning for the final day of the 2021 Healthcare Conference. We will be starting at 9 a.m. We have some informative presentations. I don't want to miss those. And here's hoping that you won't miss those dynamic speakers as well. Have a good evening.